It is a privilege to gather here today for the National Conference of Family Physicians of India. As we all know, family physicians are the heart of our healthcare system, providing essential care, support to our communities. Over the next 2 days, we can engage in a scientific feast, sharing knowledge, insights, and experiences that will enhance our practices and ultimately benefit our patients. Before we dive into the scientific sessions, I invite Dr. Ashish Patel, the President of Family Physicians Association of Vadodara, to come forward and extend a warm welcome to all of you.
Namaskar. Good morning, friends. Wish you Happy New Year 25. नए साल की सबको शुभकामनाएं. I am glad to welcome you all delegates, guests and the experts at our FPNATCON 25, 19th National Convention by FFPAI, hosting by FPA Vadodara. Over the next 2 days, we will engage in meaningful discussion, share motivative practices, and explore the latest advancement in family medicines. My team has prepared all the feast by means of academy and cultural by heart. I hope you will definitely enjoy the conference at Cultural City, Vadodara. Thank you.
Thank you, sir. Let's start the first session, the panel discussion on adult immunization. I would like to invite Dr. Sanjay Shah, Senior Family Physician, Ahmedabad, to moderate the session and request esteemed panelist Dr. Yatin Lapsiwala, Senior Family Physician practicing at Surat, Dr. Kamlesh Upadhyay, HOD, Department of Medicine, BJ Medical College, Ahmedabad, Dr. Tushar Shah, Senior Pediatrician practicing at Vadodara, Dr. Prafullata Patel, Senior Family Physician practicing at Vadodara on stage. I would like to invite Dr. Sanjay Shah, sir, Family Physician practicing in Maninagar, Ahmedabad since 34 years. Sanjay sir did his MBBS and FCGP. He is past President Maninagar Medical Association and Ahmedabad Family Physicians Association. At present, he is JT Secretary, FFPAI. Interested in academic activities and involved in scientific activities of AFPA conferences. Dr. Sanjay sir, please start the panel discussion.
Thank you. Thank you, madam, for good introduction. And good morning and welcome to all the delegates of FFPA conference, FFPA Con 2025. As you know, our first session is on adult immunization. And we all know that immunization is a very important part. We can see that childhood immunization is since 1978, Indian government has started universal immunization program. And through this program, adults in our family practice.
Mitro, we all know that there are so many vaccines. રસીઓની તો વણઝાર છે. Pediatric age group માં તો છે જ, પણ adults group માં પણ છે જ. So many vaccines are in book list and so many vaccines are in pipeline. So few are, first is the tetanus toxoid or Tdap. Another one is the seasonal influenza, pneumococcal vaccine, either PCV13, PPSV23, HPV, zoster, it means it is singles, varicella for chickenpox, mumps, measles, rubella, MMR, hepatitis A and B vaccine, meningococcal vaccine, typhoid vaccine, rabies vaccine, and other vaccines like COVID. We all know that thing. For travelers, cholera vaccine, yellow fever vaccine, Japanese encephalitis vaccine, and there are so many vaccines. Other vaccines are in pipeline, like cancer vaccine. Thank you.
Thank you, madam. By enumerating different vaccines we can give in adults. Now, my second question to Dr. Yatish Bhai, and it will be my pride again to introduce him. Dr. Yatish Lapsiwala is past president of Family Physician Association of Surat, past president Bharat Ghoddaur Doctors Club Surat, active committee member of Federation of Family Physician of Association of India, and winner of Best Clinic Award, Gujarat, and winner of Best Clinic Case, IM Gujarat State Conference at 2014. And he is having a wide experience of 35 years of practice. And my question to Dr. Yatish Bhai, do you want to add any vaccine, as Dr. Prafulata has mentioned, and why adults should be vaccinated?
Good morning, friends. I think Madam has enumerated all the vaccines very well. What we can add is, as she has already mentioned, few newer vaccines are also available. One is Mpox vaccine, that is for monkeypox, at least not available in India. And second is respiratory syncytial virus vaccine. Actually, that is compulsory for pregnant women in USA, still not available. On demand, it is available in India also. So I think that can complete the list. Your second question was why we should vaccinate adults. Simple answer. Vaccination, immunization is not only for pediatrics. It's a myth. It's a myth that vaccines can be given to children only. And as such also, that practice has been taken over by the pediatrician most of the time. What is our doing is to treat adults, and we can provide adult vaccination at our center, whichever is eligible for their age. And but we have to be proactive for that. Actually, what we have seen, what our own experience is there, we are offering adult vaccinations on demand only, or on inquiry only, or somebody has written, then only we are providing adult vaccination. But actually prevention is always better than cure, and whatever vaccines are available for adult age group, we should offer. Apart from that, there are certain situations where we have to give vaccinations to adults. If we don't offer, I think we can be in fault. Suppose patient is immunocompromised, suppose patient is having advanced CKD in which there are high chances of dialysis, and we have to give hepatitis B or pneumococcal vaccine to them. If patient is having advanced COPD or ILD, we have to give pneumococcal or influenza vaccine to them. These are the situations where we have to give, otherwise we can be at fault. The only thing, we have to be proactive, we have to advocate adult vaccination, we have to make adult vaccination centers at our clinic, then only the patients will be aware, and then only it will be popular. Thank you.
Yes. After listening to Dr. Yatish Bhai, you all will agree that we family physicians should take active interest to give vaccination to adults. And each family physician clinic must have one notice board regarding the vaccination to be given to the adults. And whenever we find any adult who is a candidate to take that vaccine, he has to give the information about the vaccine. It is not the duty of pharma company, it is the duty of our family physician to give the information and awareness about the disease. We can see that the COVID vaccine, which was, I think, more than 60 to 70% of the people of India has taken this COVID vaccine, and we can see the result of COVID vaccine. Very few COVID patients died because of COVID illness, and very few people developed complication of COVID. That is only because of vaccination. And government of India is really proud to give this vaccine. Now my third question is to Dr. Kamlesh Bhai Upadhyay, and to introduce Kamlesh Bhai is very difficult. He is a professor and head of the Department of Medicine at BJ Medical College Civil Hospital. He has been allotted different responsibilities at national level and state level also. He has given so many talks on different infectious disease and different topics in different conferences. He has also given good articles in national and international journals also. And after listening to him, you all will understand that he is master of each and every subject. My question to Dr. Kamlesh, give some highlights on influenza and pneumococcal vaccine, because these two vaccines are most important vaccines we have to advocate to all the adults. And there are some restriction also. So I will request Kamlesh bhai, so to whom he will advise influenza and pneumococcal vaccine, and particularly to all adults.
Namaskar. We welcome all the delegates from outside Gujarat also. गांधी के गुजरात में स्वागत है, सरदार के गुजरात में स्वागत है, बड़े और छोटे दो साहब के गुजरात में स्वागत है. India is basically having a 65% population who is younger. We are engaged in the world, but within 20 years' time, India will have a maximum number of geriatric population in the country. In the whole world, will be number one. In these days, I'm working with the Niti Aayog on the geriatric policies I'm working. So, the concept of adult vaccination, I congratulate the scientific committee team, Pragnesh Ban, all of them who have decided this topic. Now, the vaccine is equal to pediatrics. And now we are taking the doctors out of that concept, that it's we are also growing, and simultaneously we have to develop the concept also. And that's a major challenge. Number one, more than 65 years of age, high-risk population is increasing in the country. Rheumatological cases, obesity, diabetes, rheumatoid arthritis, all are interlinked, and we are seeing the large number of cases, they are on methotrexate or steroid or anti-TNF alpha, like medicines which are immunosuppressive medicines. Cancer patients are increasing and they are on immunosuppressive therapy. Hemodialysis, HIV, and of course a transplant patient also increasing in the community. So we'll have to think now in every high-risk individual for the adult vaccination. To begin with the influenza, my favorite topic, and influenza is an annual vaccine, number one. Second thing, for North Hemisphere and South Hemisphere, there are different vaccines. So, any influenza vaccine, if 2 years are written, 24, 25, 80, 81, 77, 78, if 2 years are written, it is a vaccine for the North Hemisphere. And only single year is mentioned, 2024, 2025, 1980. If the single year is mentioned, it is a vaccine for the South Hemisphere. So, 2/3 of the population are living in the North Hemisphere, and 1/3 population are living in the South Hemisphere. So, if I have to go to New Zealand or Australia, and if I have taken a North Hemisphere vaccine, I need to take a South Hemisphere vaccine also. Or same for the vice versa. The person coming from New Zealand or Australia to the in India, we need to give vaccine with the North Hemisphere vaccine. That's the message to be kept in mind. It is a single vaccine, every year vaccine. Influenza is elder than Homo sapiens. It will remain after that also. After Homo sapiens will die. That much old. And that's why we need an annual vaccine, number one. Number two, single dose is required. 6 months and above, anybody can take. During pregnancy, any trimester, it can be taken. It is safe. Only thing is, when we give influenza and pneumococcal vaccines together, there is a risk of some possibility of a development of the convulsions and fever. So that matter, when we give two vaccines together, we have to keep in mind. Last thing, people avoid taking influenza vaccine because they are worried of the Guillain-Barré syndrome. GBS is a likely complication with any vaccine. Remember one thing, there are single dose vaccine, single pen feed for single patient, single shot, versus multi-dose vial. In any vaccine, when there is a multi-dose vial, thiamerzole is there as a preservative, and thiamerzole is responsible for the GBS. So when you are taking influenza or any other vaccines, pan-filled, single patient, single shot, there is no possibility of GBS to be remembered as a whole. Ideally, ideal recommendation is less than 5 years, more than 65, all people. Other than that, those who are having diabetes, hypertension, obesity, all hypothyroidism or any thyroid disorders, renal or liver conditions, they are on immunosuppressive therapy, all of them must take a single dose of injectable, inactivated influenza vaccine. As far as pneumococcal vaccine is concerned, it gives, there are mainly two types of the vaccine. One is PCV, pneumococcal conjugated vaccines. Now conjugated vaccine, whenever the conjugated word comes, conjugated means, and second vaccine is polysaccharide vaccines. Whenever there is a conjugation of the vaccination of any vaccine, it will boost up the immunity so that repeated dose of the vaccine is not required. That's the advantage of the conjugated vaccines, number one. Now in a pneumococcal vaccine, there is a PCV 13, 15, 20, 21 and 7 also. That PCV, pneumococcal conjugated vaccines, having a different bacteria. So for pediatric age group, children age group, the 13 everything is good. As far as adult is concerned, that two vaccines at two interval, first with the PCV 13, now the latest is coming is PCV 21. So first dose with the PCV and after 1 year with the polysaccharide pneumococcal vaccine, that is a PPSV 23. PCV vaccine will give protection against the 90 subtypes of pneumococcal, whereas PPSV, that is polysaccharide vaccine, will give protection against the 22 bacteria, subtype of bacteria. So 65 and above all, as well as less than 65, having some metabolic conditions, they must take 2 doses of vaccines, PCV after 1 year, PPSV 23, that's to be given. As far as children is concerned, influenza to be taken in pediatric age group. Influenza plus pneumococcal vaccines together can produce convalescence, that is to be kept in mind and to be warned to the children. Such phenomena is not much observed in the adults. I think that is sufficient.
I want to add and I want to confirm also with Dr. Kamlesh Bhai. If we talk first about influenza,
Sir.
Which month is ideal month? Because as you said that it is working for 1 year.
Sir.
And the new batch is coming in which month and at which time one should take this vaccine?
Generally after Diwali time, the vaccine is to come. So once after the Diwali time, and November.
I think Influvac Tetra at present most of the people are taking. It comes in the month of August. So new batch is coming in the month of August. So we recommend that one should take in the month of September or October. That will give full coverage of 1 year. If one is taking it in the month of December, then it will work for 9 months, like that. So my recommendation is one should take, or we should recommend our patients that new batch of Influvac Tetra, which is mostly we are giving to as a flu vaccine, and it is the latest Tetra part of the flu is being covered by this Influvac Tetra. Initially there was trivalent and at present it is tetravalent. Dr. Tushar Bhai will also comment something.
I would like to add before these things. The flu season is basically in the Gujarat, is a winter time. And that's why I say November, October time is better one, number one. But it is available in US market everywhere earlier as compared to this. Now we have a locally available Indian-made vaccine also. As far as Tetra and Tri is concerned, in a Tetra, there are 2A, 2B. So in a quadrivalent vaccine, there are 2A and 2B. And in a trivalent vaccine, there are 2A and 1B. The second B which is added in this, now influenza B is not causing any mortality. So if I am the given the charge for the whole nation, I'll go with the only trivalent. By adding one more, you are not getting any advantage. In US and US, they think of the loss of human man hours. They don't think only of mortality. We have to think of money also. And that's why, given a charge, I'll be happy with a trivalent rather than quadrivalent. And addition is not going to give any benefit in the mortality. That is also true, sir.
Before Dr. Tushar Bhai talks something, it is my pride to introduce him. He is MD Pediatrics and LLB, Chief Consultant and Proprietor of Navkar Children Hospital, Director EMVAC Healthcare Solutions Private Limited, Director Department of Clinical Research, KGP Children Hospital, and he is practicing in Vadodara since long period. And Dr. Tushar Bhai is basically pediatrician. We have kept him though for adult immunization, but he will give good highlights on different vaccines which can be given in pediatric as well as adult. Dr. Tushar Bhai.
Thank you very much, sir, for the kind introduction. Also, thank you to the team FPNATCON 25 for giving me this opportunity to be here, especially Dr. Pragnesh. And as rightly said, that this topic is very, very important for all the family physicians. We know that vaccination is not necessarily just the purview of pediatricians, and we have seen that we could conquer many diseases because of vaccination over last couple of decades. And after COVID vaccination came, we realized that vaccination is not just for children, but also for adults. As far as the flu vaccination concept is concerned, a small correction which I may differ from the experts is that the flu vaccination normally in the northern hemisphere, the peak is during winter months. But as far as India is concerned, it is all throughout the year, but the peak in our country is during monsoon months. So when we want to do flu vaccination, we would prefer to do pre-monsoon. So the SH strain, which sir rightly said is the right vaccine for flu vaccination in our country, comes in February, March. The one which is a southern hemisphere strain that comes in February, March, and April, May, June is the best time to do vaccination for flu. It's a yearly vaccine. The NH strain also is available in our country, which comes in August, September, and that can be given at that point of time. Suppose somebody comes in November or December to you, that does not mean that you request him to come next year pre-monsoon for the vaccination. You can very well do vaccination whenever there is the first visit. You don't have to miss the opportunity to vaccinate that individual because the disease is all throughout the year. But the next cycle, instead of doing it after one complete year, you may do it pre-monsoon so that you are going to cover him also. Overall, the effect of vaccine is only for 6 to 8 months, not just for 1 year, but we do annual vaccine because every year we have a new strain depending on the antigenic shift and the drift that is there. Based on this, WHO gives the new vaccine strain to the companies, and therefore this vaccine, which is new, fresh, is going to be available every year. There may be a time when there may not be a change and the same strain may be given to the companies for the manufacturing. Whichever brand we use, it's fine. Sir rightly said that a trivalent vaccine is good enough. The WHO latest guidelines say the trivalent vaccine is good enough, but you will be surprised to know that there is no trivalent vaccine available anywhere in the country. It's all quadrivalent right now, but maybe by the next cycle, across the world, it's going to be again trivalent vaccine. So this quadrivalent vaccine will be phased out and a trivalent vaccine may come again because of the points that sir mentioned. So I think this about flu.
One more thing I want to add. In flu vaccine, we should advocate to all the adults, not age more than 60 years. Because flu is a very notorious virus and it can kill even younger patients also. So flu vaccine is recommended to all. Pneumonia bacteria is very well since long time, and young people are a little bit take care of that bacteria also. So if we recommend pneumonia vaccine to age above 60, then it is okay. But flu vaccine to all, at any age, flu vaccine has to be given.
Sir,
you want to say something?
yeah, when you talk at the policy level, I am very much clear that flu vaccine is not for all because, yeah, as I told you, more than 65, adult having disease or pregnant ladies. The time has come to alert this. All pregnant ladies must be covered, but not on. It is not recommended for all. Not right.
Okay.
And about one thing, see, any influenza is a yearly vaccine. 6 months time passes. There are more than 266 centers across the world. One of the centers is my center also. Since 2006, the International Influenza Surveillance Network, every week we send one swab, and from across the globe, that swab will go there, and they will decide which strain is prevalent in the North Hemisphere, which in the South Hemisphere. Then the WHO committee sits in for deciding the candidate vaccine, and then the vaccine is prepared. So surveillance to ampoule in your chamber, it takes 6 months time. And that's why, make it once, whatever month is there, pre-monsoon, અત્યારે વરસાદના ઠેકાણા નથી, ગમે ત્યારે વરસાદ પડે છે. So season is also not good. What you fix up your month, preferably pre-monsoon, where you can take the vaccine and it will cover both the phases. That's a more practical solution.
Thank you. My next question to Dr. Tushar Bhai.
Sorry, all panelists. We have to conclude the
Yeah, we have to conclude, but as we have started at 9:10, so I have
okay.
a little bit liberty to complete it in
Within
at least
2 or 3
9:50.
minutes.
My request to all the speakers to talk very little thing. Some highlights on DTP and MMR vaccine, Dr. Tushar Bhai.
Right. So, Tdap vaccine, which is an adult vaccine, DPT is basically given in pediatric, but the Tdap means T capital, D small, A small and P small. So here the strength of tetanus is same, whereas for diphtheria and pertussis is less as compared to the pediatric population because of the reactogenicity. This is a vaccine which has to be given at between 10 to 12 years as one dose, and then every 10 years to make sure that you give protection against not only tetanus, but also because of the shift in epidemiology against diphtheria and pertussis, which may happen in adults. It's a vaccine also used in pregnancies. So in each pregnancy, you should give one Tdap vaccine, whether it's happening at a shorter interval or at a longer interval. It also helps for cocooning, especially to prevent pertussis in a newborn child. So you know that most of the grandparents, when they are going to US or other countries to take care of the newborn, they are asked to take this vaccine before they come to that country. So that applies to our country also, where as a part of cocooning, you want to cover all the people who are going to come in contact with that newborn baby for this vaccine. So all healthcare professionals and parents, grandparents, whosoever should take a Tdap vaccine. Another vaccine which you said was MMR vaccine. So MMR vaccine again is a pediatric vaccine where in pediatric population we give one at 9 months, one between 15 to 18 months, and one at 5 years or 4 to 6 years. So that is the way we do 3 doses. If you want to give protection against measles, 2 doses are sufficient if given after 1 year, but because we do early vaccination, 3 doses are required. For mumps, 2 doses are sufficient, and for rubella, even a single dose is sufficient. When we do it in adults who has missed a pediatric vaccination, then as a catch-up vaccination, 2 doses of MMR 3 months apart or 4 to 8 weeks apart are good enough, which gives protection against all these 3 diseases. And it's a live vaccine, so should be avoided in immunocompromised individuals, and it is given subcutaneously, this MMR, whereas Tdap vaccine is intramuscular.
My next question to Dr. Kamlesh Bhai. Give some highlights on hepatitis and typhoid vaccine.
Yeah. Hepatitis A or waterborne diseases are very prevalent in the country. So now the newer generation, starting the from breastfeeding to whole life, they are using this Bisleri. For them it's recommended, but it's not for all, number one. Then hepatitis A is producing more mortality in the adults, and that's why they recommend that hepatitis A vaccination. It should not be for all. It is for the travelers, number one, coming to the endemic areas, homosexual men, IV drug abusers, and whenever there is a community outbreak of hepatitis A during that time, and particularly food handler, all hotel business people, or a cook, they must be vaccinated with the hepatitis A. As far as hepatitis B is concerned, we know the all IV drug abuser, sex partners of all hepatitis B positive, and healthcare workers particularly, those who are at risk of the coming in contact with the body fluids. So they all must be vaccinated for the hepatitis B. Combined vaccine is also available. For HIV people, one thing I want to add is if after 6 weeks after hepatitis A vaccination, if the rising titer is not adequately observed, then he may go for the second vaccination also. That is for the HIV positive. That's all. Thank you.
And regarding typhoid vaccine.
Typhoid vaccine. Again, a typhoid vaccine in a country, it is not recommended for all. It is not recommended in the program also. One thing I'm here in Ahmedabad, Baroda. Baroda has reported 200 plus gene sequencing. I have the whole gene sequencing of 200 patients having a ceftriaxone resistance typhoid fever. So it is there in the Pakistan since 2016. Now the ceftriaxone resistant typhoid outbreak is upcoming in the country, and Baroda has reported first, number one. So again, those who are affluent class people who are using the RO or the purified water, these are the candidates, otherwise it is not recommended for all. But pregnancy is, of course, main thing. We have to take care about the typhoid. Other than this, elderly populations, immunocompromised populations can be given. That injectable vaccine is available, conjugated vaccine is there, that should be used. Oral live vaccine has practically now no one role in the typhoid management.
I think typhoid is less common after the age of
30 years,
35 years.
yeah.
So it should be recommended to up to the age of 35 years. And particularly students who are studying in 10th and 12th standard, they must take. And nowadays this conjugated typhoid vaccine is in the market. So only one single dose is sufficient. So we should recommend this to all our young patients. My next question to Dr. Tushar Bhai, give some highlights on varicella and HPV vaccine.
So again, varicella is a live vaccine, and in pediatric population, we give first dose between 15 to 18 months, a second dose preferably 3 months after the first dose, because of the issues or cases of breakthrough varicella. So there can be a primary vaccine failure, and therefore 2 doses are recommended now instead of 1 dose which was recommended about a decade back. In adult also, if somebody has not got chickenpox in past or has no immunity or not taken vaccine as a catch-up vaccination, we can give 2 doses about 4 weeks to 12 weeks apart. And it's a good vaccine, it gives protection, there are no adverse effects, but again a live vaccine, so caution in immunocompromised individual. As far as HPV vaccine is concerned, it's an interesting vaccine, I would say, especially like till now we were promoting this HPV vaccine, which is a human papilloma virus vaccine, as for prevention of cervical cancer in female. So of course it is important in female for prevention of cervical cancer, but let me tell you friends, it's a gender neutral vaccine and it should be promoted not only in girls but also in boys. So the vaccine HPV prevents for cervical cancer, but it also prevents against anal cancer, anorectal cancer, oropharyngeal cancer, penile cancer, even vulval vaginal cancer and cervical cancer in females. So it's a gender neutral vaccine when we want to do prevention for even to do cervical cancer elimination, where if you do vaccination of both males and females, it's going to help to prevent it fast. The vaccines which are available in market have different brands and different approvals for different age groups. So Gardasil 4, I'll take the brand names for better understanding, which is by MSD, is licensed for use by Drug Controller General of India, that is DCGI, between 9 years to 45 years, females only. So it cannot be used in males. Between 9 to 14 years, 2 doses, 15 years to 45 years of female, 3 doses, 0, 2 and 6 months. If you use the other brand, which is a Gardasil 9, which is a nonavalent vaccine, which gives better protection as compared to Gardasil 4 for cervical cancer prevention and other cancers, can be used in males only up to 15 years and not above 50 years because of the approval issue. Whereas the same vaccine is approved in US up to 26 years of age, but in our country only up to 14 years. So if you use in adult population only up to 15 years, not beyond that. In females up to 26 years of approval. Again same 2-dose, 3-dose schedule. A Sarvavec, which is our local Indian brand from Serum, which can be used from 9 to 26 years both males and females, and 9 to 14 years you can give as 2 doses, and 15 years to 26 years you can give as 3 doses. So that is the way it goes. If there are some questions regarding this, I am ready to answer, but I think because of the want of time, I am cutting short. Thank you.
Now, as being requested to complete it as early as possible, there are certain vaccines to be discussed still, but I would conclude by taking one or two questions, particularly in our family physician. My question to Dr. Prafulata: suppose one family physician wants to start adult vaccination work, which steps one should take?
First thing, the doctor should know, he should be aware of the vaccine, and availability of vaccine should be there. And the storage, there should be the cold chain maintained, so there should be the refrigerator. Vaccine should be stored in between 2 to 8 degrees centigrade. Adult vaccination card or diary, the doctor should be maintained, and it should be kept in the reception one notice board, so the adult vaccines is available. Doctors should aware of that contraindications and complications regarding that vaccine. And there should be one emergency kit that contain adrenaline, hydrocortisone, Avil, and other supportive medicines. And it is must. Thank you.
I want to add one thing. As we family physicians sometimes cries that our practicing is diminishing. I can say that this adult immunization is a new wing in our practice that we can expand. And if we have a full adult vaccination schedule on our notice board, one can see it and one can ask to us also that suppose so-and-so vaccine he or she wants to take, then he can take. Regarding pediatric vaccination, we can see that the most of the children are taking this vaccine either by pediatrician or at government center. We family physicians are giving very less pediatric vaccination type of work. So adult vaccination is a really new, I can say, wing we can expand our practice.
Sir, once. So, like, I agree with all these points.
In the adult. And in future, at present government is more interested in childhood vaccination. Government will definitely look after adult vaccination also. But till government is not taking this responsibility, we family physicians should take the responsibility and give vaccination to our adults. Thank you. And I conclude this session.
Now I request. Okay, sir.
That particular thing, those about 50 carpenters, they have made it a habit to come on 1st June and 1st January, twice in a year, saying that लगने के बाद ही लेना, क्यों लगते तो रहता ही है, हर 6 महीने को हम लेने वाले हैं और लेते हैं. ये कौन से भी WHO पे नहीं है, तुम्हारे बुक्स में नहीं है, कौन से भी तुम्हारे प्रोटोकॉल में नहीं बैठता. Practically, this is what is happening in my case with my patients. It looks illogical, but for me it is right. What is your opinion?
Right, sir. So you are saying that TT vaccine you are giving every 6 months to particular class of patients because they get frequent injuries, right? Right. So the answer to this is that ideally, once you have given a TT vaccine, there is no need to repeat TT vaccine till next 10 years if it's a clean catch wound and somebody who has received primary 3 doses. So if suppose a child or even an adult has received 3 doses of TT or TPT in past and boosters as recommended, then for next 10 years there is no need to give such repeated doses. If there is a bad wound and somebody has not received any vaccine in past, you may even have to give immunoglobulin at that point of time. But somebody who has received TT in last 5 years or before 5 years and a bad wound, you may give 1 TT, but no immunoglobulin.
So that is the way the schedule is for TT. The repeated TT doses causes one thing mainly, which is Arthus reaction. It's a serum sickness-like reaction. So the moment you give repeated TT doses, it's actually harmful. So according to me, if somebody has received TT and they come again and again for, say, a nail bite or some injuries because of even iron instruments or whatever, there also there is no need to give such repeated tetanus toxoid doses. So if the past vaccine schedule is complete, he has received one dose within 10 years and the wound is clean wound, there is no need. If the wound is dirty wound and 5 years, within 5 years the person has taken, then there is no need to give repeated TT doses.
I request Dr. Ashish Patel sir and Dipti Shah ma'am to honor the moderator and panelists.
Dr. Sanjay sir. Now, I request Dipti Ben to give Tushar Shah. Now I request Dr. Ashish Bhai, Dipti Ben to give Yatish Bhai and Ashish Bhai to Prafulata Ben.
There is a small announcement. Paper presentation is going on. Those who want to participate, please go to the boardroom just opposite to Marigold. Let's move forward for the next session. I would invite Dr. Rikul Shah, Vadodara, Dr. Ashok Thakkar, Gandhidham, Dr. Harish Kumar from Bangalore, and Dr. Hetal Shah from Vadodara to chair the session. Now I invite Dr. Kamlesh Upadhyay Sir, HOD, Department of Medicine, BJ Medical College, Ahmedabad, to enlighten us on rising trends of zoonotic diseases, and I request the chairperson to introduce the esteemed speaker.
Hello. Good morning all. It's my privilege to introduce Dr. Kamlesh Upadhyay. As all of you know, he is a HOD, Department of Medicine, BJ Medical College, and he is involved in many national programs as a team member. So I request Dr. Kamlesh Upadhyay to start the session. Thank you, sir.
या चेंज कीजिए या नमस्कार rising trend of zoonotic infections. These are all the doctors and nurses who have lost their life while treating the CCHF virus. So I pay my homage to all of them who have lost their life. 13 out of 18 healthcare workers have lost their life. Since I'm working for the One Health, the animals which lost their life for the nation, I pay my homage to them also. I welcome all the delegates to Gujarat. From 2020 onwards, the word zoonotic has come up in a wide way after the corona. Bird flu, swine flu, Ebola, Zika, MERS-CoV and what not. साइज सेट करना है जी.
हाँ सर नहीं साइज कम आ गया वैसे
કઈ વાંધો નહીં, જવા દો ને, ચાલશે. ચાલશે. See, there are more than 1400 pathogens which are affecting the humans. Out of them, 70% are zoonotic. What is zoonotic? When there is a transmission of infection from animal, rodents, marine life to the human, it is known as a zoonotic potentially infections. When human walking on the zebra, it is a zoonosis, whereas when zebra walks on the human crossing, it is known as a reverse zoonosis or anthroposis. There are cases where from human to swine have been infected. So the organisms move across the species. So today it's a swine flu. Tomorrow it can be from horse, it is equine virus. It may be from the fish, it is a marine influenza. So that's how the viruses, organisms, they survive by moving from one to another organisms. They also want to live. Gradually, over the years, the zoonotic infections are increasing in the whole world. And we are here, why? Till today, the concept was also less, so they were underdiagnosed. Now there are availability of the PCR and other tests, Elizabeth test, to diagnose them also. That's why and movement of the people also has increased. That's why the zoonotic infections are rising. WHO and everybody now talk in terms of the One Health. What is One Health? Human can remain healthy only if the animals remain healthy. If environment remain healthy, then only the human can remain healthy. There are many years the concept has been developed. There are more than 84 lakh yonis on this earth. Before the Homo sapiens was born, after the birth of the earth, the God has made water and lot many yonis are there. So our body, in our gene also, 97% gene are sharing with the other animals, plants, marine and all animal kingdoms. If we talk of various rashis, they are attached with the animals, either the mean or that is scorpion or something. Only one is left, that is Tula Rashi. That is for the Banyas. Otherwise, every person has some or other way link with the animal kingdoms. When the human genome was developed, 97% matching with the bandar, ape. And the difference is this only. The ape or bandar cannot do this because they don't have opponent's paralysis. Opposite muscle is not there. They can do this, but that not this. And that's why Rishi says, this is a Gnana Mudra. It's a difference of 3% only. Otherwise, same. Similar गुलाट मारते हैं सुबह में एक पार्टी में दूसरे शाम को दूसरी पार्टी में मिनिस्टर गुलाट लगाते रहते हैं. And the concept of One Health is not for us. I am a Yajurvedi. In our Yajurveda, it is written in the first adhyay, first श्लोक, प्रजमेति उन्मीव अक्षयम, हमारी गायें क्षय से मुक्त हो. हम वहां से गायों के बारे में तब से सोचते थे, टीबी के बारे में सोचते थे. So we are very much concerned. If you look at our various god, they have all the animals around them. Either Nandi is there or a snake is there or a swine itself, and we respect them. So One Health, we are committed with that, and it was a commitment for the migratory birds. We are, for last 3 years, we were holding the United Nations Environment Divisions. We were responsible for the migratory birds' health. So we are contributing for so many years. We know the One Health is what? We live the One Health. And even we become we live the One Health. And we teach the whole world also what is One Health. हंसते रहिए, हंसाते रहिए, बेटे की बहू आ जाए, फिर हंस लेना, यही जिंदगी है. So microbes basically used to rule the world. And hey man, you are missing me. And the animals say us, you are missing me. And you see from the android to forest, we have to think and we have to handshake with the animal, not only with the machines and robots. Take your children and grandchildren to the Gaushala. Let them to play with these things. Let them to come in contact with the animals. Why it is required? Because if they are not in Gujarat, 60% population is staying in a 6 metro city where 3 generations have not touched the animals. All of us, let's think, when did we touch the last cow? हम गाय को छूते भी नहीं है. When you don't come in contact with the animals, there is no potentiality of the zoonotic infections. You are virgin, and when any virus come and enter in the body, it can blast and it can kill you. Or I have my basic role has remained in a Congo virus national level policy also, the treatment guideline also. The Congo virus, they are developed in the village area, rural area where the cows are there, buffaloes are there, and they come in the ICU in the metro cities in a bleeding state, and they kill the healthcare workers, nurse and doctors and intensivists in the ICU. That's why we have to be very cautious. Take your children to the Gaushala, let them to play with the mud and cow. In a foreign, just to hug a cow, they charge $1,000 rupees. So the family physician can think of the One Health to practice One Health. There can be a common one family physician holistic health center where there can be animal exposure also. In every city, family physician can develop a common holistic health center where they can allow the exposure of the people with the animals. Time has come to think in this way. So there are family physicians are really a God for the family. That concept I have in my mind. The number of segments in the organism is important thing. The swine flu or any influenza having a 7 segments, so they mutate every year. Whereas Congo has 3 tri-segment, and Ebola and Corona has a no segment. So whenever the number of segments are more in the nucleus, they mutate very fast, and that's why yearly vaccine is there in influenza. So organisms also tell us about how it will progress in a zoonotic form. See that there are the pathogens, humans, there is the interaction, food and vector-borne, water-borne, and interaction is there. Basically there is a virus is there, it is viral, bacterial, fungal, parasitic, anything can be there in the zoonotic. The thing is, there is a reservoir of infections. Say MERS-CoV, coronavirus, the fruit bat, in the saliva of the fruit bats, there is a virus, that is a Middle East respiratory syndrome coronavirus. They are fruit bats. In a desert area, they eat the dates, khajur, khate hai. They transfer the viruses from saliva to the dates. Then, while eating, these bats, niche langur khada hai, they have a friendship. Ek do aane de. Then, they throw the dates for them. Virus come to the peri-domestic animals. That peri-domestic animal will move and come to a domestic animal, and that is a camel. And camel will have some symptoms. And when the symptom of that MERS-CoV is basically cracked lips, the bleeding occurs from the cracked lips, and that Arab person, he applied the cream with a bare-handed, and virus from bats to dads to langur to camel to that Arab person came, and that was the first case of MERS-CoV in 2012. So this is a whole cycle. When first case occurs, and then there is a human-to-human transmissions, and then there is sustained human-to-human transmissions. As per the R0 value, the MERS-CoV will last for 2.5 to 4 years, whereas COVID will not value so high that within a span of 6 weeks, you have to lock down the whole world. This is what the potentiality of zoonotic infections. In last 200 years, there are more than 10 pandemics in the world, and believe my words, in China, almost 400 coronaviruses subtype have been isolated. 3 निकले हैं, 397 बाकी है. In the coming days and weeks, we will expect all these things. Across the world, we see lot many outbreaks. I'll come to this thing. Hitler की बात है here. What is important is human-animal interface. That is important thing. You name any zoonotic infection, Zika, Congo, all of them have African origin. Why? Because they live together. See the first photo. जैसे कृष्ण में बात करते हैं ऐसी बात करते हैं दोनों. ये बाजू में एक फोटो है, उसमें दिखता कम है पर एक दूसरे की आंख में देखते हैं. मेरी वाइफ ने मेरी आंख में कब देखा मुझे पता नहीं, इतना प्यार से देखते हैं. And you can see the Zika virus, same what you see in a tiger mosquito, same chata-pata are there in this also. Before biting, he will think, oh, mari masini chokri lagesh. So he will not bite. And this is a mother, is a real mother. अपने बच्चे को भूखा रख के प्राणी को दूध पिलाती है, वो माँ अफ्रीका में आपको मिलती है. बैट्स आर मेजर ट्रांसमिशंस एंड बुशमीट. पूरे भारत में हम बंदर को मारते हैं लकड़ी से, खाते नहीं है. बुशमीट इज नॉट यूटिलाइज्ड इन द कंट्री एंड दैट्स व्हाई मंकी गॉड. आज जितने राम जी मंदिर है, इतने हनुमान जी का मंदिर है. क्यों? वी नो बुशमीट इज डेंजरस. लॉट्स ऑफ ऑर्गन्स आर देयर टू ट्रांसमिट द zoonotic infections and that's why एक यहाँ जोधपुर के पास में मंदोदरी का पियर है, वहां मंडोर का गांव है, वहां बंदर को मारते हैं पर खाते नहीं है. वो रावण को परेशान किया था ना, इसलिए बंदर को. हाँ, बुशमीट इज नॉट यूटिलाइज इन द होल कंट्री. कुछ बातें नॉर्थ ईस्ट में कहीं खाते हैं, ऐसी बात मुझे मिली है. सी बेसिकली वेस्टर्न वाई चाइना इज ए बेसिकली दे ईट एवरीथिंग. जो हलता है वो खाता है, उसका चाइनीज बोलते हैं. सो दे यू कैन सी द मार्केट, द फूड मार्केट. एंड देन ह्यूमन एनिमल, जैसे जैसे ह्यूमन एनिमल इंटरफेस बढ़ता है ऐसे कंफ्लिक्ट भी बढ़ता है. थोड़ी स्लाइड्स दिखती नहीं है, अदरवाइज गुड स्लाइड्स आर देयर. देयर इज एनिमल ह्यूमन कंफ्लिक्ट इज देयर. As I told you, we don't touch animals. Again, food hygiene is increasing, and that's why in a 2011 in Germany 180 people died due to E. coli. E. coli अभी हमारा कल्चर में आएगा तो भी हम बोलेंगे who will care of the E. coli. वहाँ E. coli से मिल गए. 25 पेड़ी से सिर्फ बिस्लरी पानी पिया. No IgA, no immunity, and some E. coli का blast and kill the people. सब पानी पूरी खानी चाहिए. बट प्रेगनेंसी में मत खाइए. और प्रेगनेंसी भी है तो फर्स्ट हाफ में खा लीजिए, सेकंड हाफ में मत खाइए. एनी प्रेगनेंसी इज अ 40 वीक्स स्पान. 0 to 20 weeks is a first half. I'm not saying trimester, I'm saying half. First half and second half. First half is basically mother's body is prepared to welcome the baby. Breast is engorged, body weight gain occurs, 10 to 12 kilogram weight gain occurs. So first half, mother body is preparing for the baby, and second half, the fetus, the zygote to 250 gram, kilo, 2 kilo, 3 kilo, 4 kilo is a gestational diabetes. So in the second half, the fetal growth velocity is more, and that's why the immunity is more suppressed. Pregnancy is an immuno-altered state, more so in the second half as compared to first half. That's why you name the disease, malaria, typhoid, swine flu, even COVID also, the second half pregnancy mortality were more. And that's why now IF is there. So single pregnancy, multiple pregnancy. Multiple pregnancy, there are multiple implants are there, embryo implants, and then it's to multiple placenta. More the placenta, more altered immunity. And that's why pregnancy and infection, mortality is more in a multiple pregnancy lady. That is to be remembered. Again, pregnancy is immunological state, more so in the second half as compared to first half. ये बात याद रखना है. So पानी पूरी नहीं खानी, मन था, प्रेगनेंसी में बहुत खाने का मन होता है. खाना है तो फर्स्ट हाफ में खाइए, सेकंड हाफ में नहीं. That's the important message. Now, lifestyle is increasing. Diabetes, Gujarat is the capital of diabetes, and that's why we see more number of zoonotic infection. Gujarat, 30% NRI coming to India, they visit Gujarat. Either they NRG or they come here for the business purpose. कुछ तो दिन गुजारिए गुजरात में, and that's why risk of human interaction also is more, and that's why risk of zoonotic infection is more. In my laptop, I have a readily available data. गुजरात में कौन सी हॉस्पिटल में कहाँ से पेशेंट आते हैं, कौन से कंट्री से आते हैं. द मेडिकल टूरिज्म इज देयर. we are cheaper in the need transplant and CABG also. So which hospital cater foreign patients? और वो कंट्री में कौन से डिजीज कॉमन है? Particularly African people are coming to for treatment in your state. Be careful. They can bring the zoonotic infection in your community. Okay. Then environmental factors. जब मानसून होता है तो हर पेड़ पे फ्लड होता है, तो क्राउडिंग वहां भी ओवर क्राउडिंग होता है among the beds. जहां समर होता है कुछ पेड़ पे फल होते हैं, वहां ओवर क्राउडिंग ज्यादा होता है. That's the season where there is a risk or potentiality of the zoonotic infection is comparatively more. Deforestation. आज आप देखो अमरेली और सब जगह पे अलायन आ जाते हैं, बिकॉज हमने जंगल में एंट्री किया, ट्रेन डाली, होटल डाली, दे कम आउट. दैट पॉपुलेशन इज ऑल्सो इंक्रीजिंग. Deforestation is one of the reasons why there is a increase in number of zoonotic infections. Today is 4th January. On any time, lakhs of people, lakhs of animals are affected in the accident on the highways. So all vehicle tires, any person who is Kerala Tire Services, those who are doing a puncture business, tires are basically a source of zoonotic infections because the tire might have passed through carcasses of these things. In a bird flu control, when I was sent in 2009 to Calcutta, what we did, whatever the ways, small street or big highway, they are entering in the Calcutta, 100 meters were covered with the jute bags, and on that sodium hypochlorite solutions was poured. So any vehicle going inside the city or going out of the city, the wheels will be desanitized so that the infection cannot go out. This is what we have to do. Wheels are the source of zoonotic infections to be kept in mind. आपके कितने लोगों की गाड़ी आप घर के अंदर पार करते हो? बाहर कर दीजिए. If you are taking the vehicles inside your home and you are going out, your grandchildren may be playing in that area. That may be a source of infections. आप गाड़ी लगाते हो, यदि वहाँ के कुत्ते सूंघते हैं या चकले the birds आके वहाँ कुछ खाना खाने आते हैं, तो मानना आपकी गाड़ी का टायर कुछ कार्केसेस के ऊपर से पसार हुई है. This can be a potential source of zoonotic infections. ये जो मैं कलकत्ता की बात कर रहा था, एक ही बात याद रखनी है, ये जो माइग्रेटरी बर्ड्स है, दे ट्रांसमिट इन्फेक्शन अक्रॉस द वर्ल्ड. गुजरात में 17 साइट है जहां विदेशी पंखी आते हैं, और साइबेरिया का पंखी है, दे कंटेन इन्फ्लुएंजा. हम यहाँ जाते हैं, आनंद के पास जाते हैं, वहाँ बर्ड्स देखने जाते हैं, या एनी बर्ड सेंचुरी जहाँ जाते हैं, तो उसके डायरिया में होता है इन्फ्लुएंजा पक्षी के, बिकॉज दे हैव 2,3 अल्फा गैलेक्टोज रिसेप्टर होते हैं. यदि वो बाहर निकलते हैं, उसके स्टूल में वायरस निकलता है, आपकी फियांसो आपने पानी लेकर लगाया, साइबेरिया का वायरस हथेली से लेके फियांसे जाता है, एंड ह्यूमन टू ह्यूमन ट्रांसमिशंस. So these are the way how the virus is transmitted, and they maintain their life in the.
Sir, 2 minutes.
For last. जैसे हमारा माइग्रेटरी बर्ड्स है, ऐसे माइग्रेटरी मरीन बायोलॉजी है. आज समुद्र में भी 5,000 किलोमीटर चलने वाली मरीन बायोलॉजी है. सो बिलो 200 मीटर्स, कहीं भी नीचे जो समुद्र में जो भी जीव है, वहां आंखें नहीं है. दे जस्ट कम्युनिकेट विद द क्वैक अल्ट्रासोनिक वेव्स, क्योंकि वहां बिल्कुल डार्क लाइट है, लाइट ही नहीं है, वहां बिल्कुल डार्कनेस है. So below 200 meters in the sea also, all the marine life is a blind. They don't have eyes. देखो नहीं दाजो नहीं, जब भाग में आवी जिंदगी निकल जाए. This is what it is, and that's why गुजरात में सबसे ज़्यादा शीशोर है. हमें जो भी पोरबंदर से आए हैं, वेरावल से आए हैं, गांधीधाम से सब बड़ी आए हैं, always think of the marine flu. If the person is coming, he's a fisherman working in the sea, and come in contact with a fish, this can be a fish, this can be a marine flu also. So time has come to think in this way. Chalo, only thing is whenever there is any unexpected, rapid, deteriorating pneumonia or bleeding or severe infections which can lead to death, or think of the zoonotic infection, it can kill you also. And that's why use the mask, gloves, and during intubation, if possible, face shield. Whenever new things come, we have to keep that thing in mind. Chalo. The one, if you are having ICU or in outside a clinic also, whenever the pandemic is going on, they are the doormats to be poured with the sodium hypochlorite solutions. And while going inside a clinic, going out of the clinic, if you clean your shoes on this thing, your clinic will be very good as far as infection is concerned. Now there are many things in pregnancy की मैंने बात कर लिया है. That's all. पसंद उसे कीजिए जो आप में परिवर्तन लाए, वरना प्रभावित तो मदाई भी करता है. चलो, thank you very much for everything. Thank you.
Thank you, sir. Your passion for the subject was evident.
Yo.
Now I request Chairperson to honor Dr. Kamlesh
Thank you.
Upadhyay, sir.
Thank you, Dr. Kamlesh Bhai. You have given a detailed information regarding zoonotic infection. I remember first Congo case in Kutch, you came there.
Thank you, Chairperson. Moving towards the next topic, I invite Dr. Girish Hirode, sir, surgeon, on the stage for enlightening us on open surgery versus laparoscopic surgery. And I request Chairperson to introduce the esteemed faculty.
Good morning, friends.
दादा नमस्कार.
Now let's welcome our new speaker, Dr. Girish Hirode. Dr. Girish Hirode is a consultant laparoscopic and general surgeon with Bilal Amin General Hospital, a premier tertiary hospital in Vadodara. Dr. Hirode has been in practice since last 35 years and was one of the first surgeons to start laparoscopic surgery in Vadodara. Currently, he is the senior most surgeon in Bilal Amin Hospital and performed advanced laparoscopic and GI surgery. Please, thank you, sir.
So while they're setting this up, a few things. Firstly, I'd like to thank the organizers for inviting me to give this lecture. The second thing is the organizers always keep me after a very, very fiery and very high-powered lecture. So last time it was the head of Reliance who was speaking before me. This time it's Dr. Upadhyay, who's the head of medical department. So now take a few breaths and lower your expectations a little bit. It's not going to be the same standard as Dr. Kamlesh Upadhyay. What I'll try to do during the course of this lecture, excuse me, where's the pointer? So during the course of the lecture is, as family physicians, if you have to advise one of your patients whether he needs a laparoscopic surgery or not, at the end of this lecture, I hope you will make an informed decision about the same. So open versus laparoscopic surgery is my topic. Now, I have a problem with that topic itself. When we use the word versus, it usually means there's a conflict of interest. But actually, there is no conflict of interest. It's not India versus Australia. This is open versus laparoscopic. Both are complementary to each other. Both are working in the interest of the patient. And at the end of the day, we have to see that the patient is going home healthy. It doesn't matter whether we do open or whether we do laparoscopic surgery. So when a patient comes to us, excuse me, how do we make a decision? Firstly, do we have this working? Let's take an example of gallstones. So, because that's an easily relatable example, so I'll talk about gallstones. So let's say a patient of gallstones comes. So first I have to decide whether I have to do a surgery or whether... Oh, anyway, so open or conservative, whether I go for surgery or go for conservative. Now, most of the asymptomatic gallstones we can easily leave alone, especially if he's within easy reach of any medical facility. We don't really need to go for surgery. So we can treat him conservatively. But let's presume that we go for surgery. Then whether open or laparoscopic. Now, this is a no-brainer where gallstones are concerned, because now we never advise open surgery. We almost always advise laparoscopic surgery. Huh? Sutra. So let's say we do laparoscopic surgery and we have a problem. We encounter a problem, there's profuse bleeding, or we can't dissect the Callet's triangle or something like that. Then the next decision to be taken by the surgeon is whether we want to continue laparoscopically or we want to open this patient. Now there are very few conditions where we need to open, because now everybody has become laparoscopically so proficient that most of the problems can be managed laparoscopy. But let's say for some reason we open the patient, then we have to decide whether we want to continue with the original plan of removing the gallbladder or cut short. What is cutting short? We do a cholecystostomy or we do a partial cholecystectomy. But anything, the first thing we have to decide, or let's say it's bleeding profusely. So first thing we have to decide is we should not let the patient die. We have to prevent mortality. That is the first thing. If he lives, then he'll live to fight another day. So even if it means your surgical ego is going to take a beating, think about the patient. Our per primum non nocere, that's the first principle that we use, and we have to prevent mortality at all costs. In preventing mortality, the next, this thing is our priority should be to minimize morbidity. So in case of a gallbladder, for example, a CBD injury is the worst thing a patient can have. It not only spoils the reputation of the surgeon, which is to me a very small byproduct, but more importantly, it harms the patient lifelong. CBD injury is the injury to the patient, and he's going to suffer its consequences for a very, very long time. So we have to minimize. So if you think the CBD is in danger, it's better to cut short your surgery or whatever you need to do and come again. In that example, now this is the gallbladder I was doing. As you can see, this gallbladder is completely necrotic. There is no anatomy seen. In such cases, you don't need to try and build up your surgical ego and say, I'll remove this gallbladder at any cost. All we do is remove all the necrotic tissue, put a drain there, make sure that he comes out of this septicemia, and then maybe 6 weeks later or 3 months later, go in again and remove the remaining gallbladder. Similarly, sometimes when we open we go in laparoscopy, we see these varices around the gallbladder. Now these varices are such high tension veins that if you ever make a hole in one of these veins, the whole abdomen will fill up and the patient can die almost immediately. Now here you should not try and push and do this. You can even abandon the procedure. You say, okay, I'm not removing this gallbladder, I'm removing my ports. I will go in, make somebody reduce the portal hypertension. There's tips, there's portosystemic shunts, whatever he needs to reduce the portal hypertension, and then maybe remove the gallbladder later if it needs to be removed. So these are the kind of decisions you have to take, always keeping the patient at the center of everything. So remember this, tell your patient, if he ever comes to you saying that he started laparoscopically and then he had to open, that surgeon was terrible, opening a patient which was started laparoscopy is not a mistake. It's just very good judgment, usually in favor of saving the patient's life. So what are the advantages of laparoscopic surgery? Now it's been around for so long, I'm sure all of you know, so I'll just run through this. Firstly, smaller scars. So it's less painful, better aesthetics, and less complications. So now we have this, whereas earlier we used to have this. Now longer scars means longer incisions, more wound infection, a higher area of wound infection, and of course a larger chance of incisional hernia. Even if there's wound infection in laparoscopic scars, the wound infection is so small that you can easily treat it even at your, we normally in fact tell that whoever is your family physician can do the dressing a couple of times and usually it'll come around. So, but the major advantage is in obesity. Now look at this lady. She underwent a TLH. Now if this lady had to undergo an open hysterectomy, then she would have been in deep trouble. She would have ended up something like this, the one on the right. Because obesity generally means that if we put an incision, there is fat necrosis, the fat gets infected. Once the fat gets infected, the wound gapes, and then they could also have an incisional hernia. So in obesity, laparoscopy is very, very advantageous over open surgery. So just to summarize, laparoscopic, less pain, smaller scars, early recovery and return to work, better visualization. This is one of the major advantages of laparoscopic surgery because it gives a 2x magnification. So if we want to see smaller structures, we can go very close and see the magnification. So this is a major advantage. And obese patients we've already referred to. But it's not as if open surgery doesn't have its advantages. Some of the advantages is familiarity. A lot of us are familiar with all the organs in open surgery, especially surgeons of my generation. The newer surgeons are directly trained into laparoscopic surgery, so they may not be all that familiar, but for us it's a very major advantage. Easier to handle certain tissues. Now, small bowel, for example, is easier to handle in open surgeries. Even the best of laparoscopic surgeons sometimes can injure small bowel when they are handling it with laparoscopic equipment. 360 degrees of movement. God has given us these hands which can move all around. Whereas laparoscopic instruments are fixed. We cannot really, there are articulated instruments now available, but they are not very common. So obviously 360 degrees of movement is a major advantage when you're doing open surgery. And the feel factor. Again, you can feel the tissues. When you're actually dissecting, sometimes you can't, laparoscopically you can't make out the plane. You want to know whether the plane is here or there, and you go one plane down, you can injure a vessel. In open surgery, I can actually feel the plane, and if I do finger dissection, sometimes I can get into the plane much faster. And it's cheaper. Now, in a cost-conscious country like India, so open surgery has a major, major role still there because it's way cheaper. Laparoscopic is all very capital expenditure of all kinds. Staples, meshes are more expensive, tackers are more expensive. So open surgery is way, way cheaper than laparoscopic surgery for most cases. So what are the disadvantages? It's not as if both don't have the disadvantages. In laparoscopic surgery, for example, the learning curve is very steep. And it's a very costly learning curve, not for the doctor, but for the patient. Now, for lab chole, they say minimum 20 cases you have to do under proctorship before you can become a good laparoscopic surgeon. Now, God forbid, during that learning curve, you injure a CBD. That's not very fair to the patient. So, it has to be under very strict proctorship that you have this learning thing. And complications could be horrendous. I have not put any videos because 20 minutes is too short for me to show videos. But the worst complication you can get is you're going in for a benign disease like gallbladder. They put in the Viris needle and it goes straight into the aorta. This has happened. It's not like this has been mentioned. It has happened, and then there's a streak of blood which hits the roof, and then the patient becomes hypertensive immediately. And then you're panicking, you have to rush, you have to open, you have to end. Then to go back and explain to the relatives that we were about to do a cholecystectomy, and we injured the aorta, and now we're calling in the vascular surgeon. It's very embarrassing. So it's not as if you have to be very, very careful when doing laparoscopic surgery. Even trocar injuries to bowel is very common. It's way more expensive and you always need general anesthesia. No laparoscopic surgery can be done without general anesthesia. So the patient has to be fit for general anesthesia, which means if he has interstitial lung disease or a very bad COPD, generally we cannot post him for laparoscopic surgery. And long surgeries cause fatigue. Now you should understand that most of the time laparoscopic means you're keeping your shoulders up, you're operating, you're going there, you're coming here. So if the surgery goes on for 3-4 hours, it can cause fatigue. Whereas open surgery is far more ergonomic to stand there and do the surgery. Hemodynamic changes take place, which is very complex, but because we instill carbon dioxide into the abdomen, we bloat up the abdomen, there is pressure on the IVC, the cardiac return is low. So the anesthetist also has to be very smart when they are giving anesthesia for laparoscopic surgery. Open surgery obviously is painful, wound complication. And in open surgery, one of the main disadvantages is when you're operating in tight spaces like the esophagus or the pelvis, it's very difficult to reach those areas because your hands are big, you go in and it almost obstructs your view, which is an advantage in laparoscopic surgery. You can actually go in with small instruments and operate. Rehabilitation is prolonged. and there are more chances of adhesions. This is a major advantage of laparoscopic surgery. It causes less adhesions for the same surgery. Because we open the abdomen and the intestines are exposed to the atmosphere, it's been found statistically that there are more adhesions when there is open. And exposure-related fluid loss, they say up to 6 ml per kg per hour can be lost when you're doing an open surgery. So all these are disadvantages of open surgery. So now if a patient comes to you and you have a patient, your lifelong family patient, they have come to you, they've been advised for laparoscopic surgery. Now they are asking you, should I get it laparoscopic or should I get it open? So I'll give you a dictum by which you can work. So you have to consider 3 factors. What is the disease? How is the patient? And who is the surgeon doing it? All these 3 factors matter when it comes to laparoscopic surgery. For disease-related this thing, I have a very simple formula which you can apply. Draw a line through the umbilicus. Everything about the umbilicus, if there's a surgeon who can do laparoscopic surgery, definitely get it done. Which means the esophagus, stomach, spleen, liver, gallbladder, pancreas, adrenals, kidney, all these surgeries, if done laparoscopically, will be a major advantage for the patient. But obviously, the limiting thing is the skill set of the surgeon. Not all these surgeries can be done by all surgeons, but if you have a surgeon who can do that surgery, laparoscopic splenectomy or laparoscopic achalasia cardia, whatever he wants to do, Heller's myotomy, if the surgeon is there and he has the skill, you have to get it done laparoscopically. The next one is between the umbilicus and the pelvic inlet. There the jury is still out. We're not sure whether laparoscopic is really that great an advantage. For example, appendicitis. Now, it's a fashion, so people come to me, no, I haven't done an open appendicectomy in ages. That's because there's a public demand. No, we wanted laparoscopy. I said it's not going to make a major difference and it's going to be way more expensive. They said, no, but Charles, you do laparoscopic only. So we go ahead and do it, but I'm not sure it's all that advantageous. So the only advantage laparoscopic has is if it's not appendicitis, you can look around and see what else it is. But if you have an established diagnosis of appendicitis, I won't really. Same thing about hernia. There's a thin, lean patient. I do hernia in local blocks also. They can be done easily open, much cheaper, much faster, same kind of recovery. There is no need to push laparoscopic surgery. But if they insist, well and good. Otherwise, I give them the option of both. Then the third area is the pelvis. As you go deeper down into the pelvis, laparoscopy again has a major advantage. So if you go for rectum, hysterectomy, any prostate even, those are the surgeries where laparoscopy will give you major advantages over. So 3 areas, above the umbilicus, definite, below pelvis, definite, between umbilicus and pelvic inlet, I'm not so sure. You can advise the patient whichever way he's. So this is exactly the same thing. And then second is patient. Then you look at the patient, whether he's fit for anesthesia or not. If he's not fit for anesthesia, if you know something about the patient which the surgeon doesn't, he has, let's say, interstitial lung disease or very bad heart, then you have to inform the surgeon. Large tumors, especially if they're malignant, are not amenable to laparoscopic surgery. Yes, there are laparoscopic surgeons who will dissect out the tumor, put it in the pelvis, make a fan and steel and take it out, but it's not basically amenable. And when patient has their own wish, they say, no, I want laparoscopic surgery, then it's a good thing to go for. What are the surgeon-related factors? Like I said, the skill set is very important. They should have the skills to do it. The setup in which they're working. Now, this is also something you have to find out beforehand. That does he have a good setup? Is the camera system, everything good? Do they have good anesthesia equipment? Do they have good backup? And in case of a complication, can they manage it? So these are the 3 things you see where the surgeon is concerned. So this is just this thing. So now, what are the common surgeries which you can definitely say you have to get it done? Of course, cholecystectomy, most important, gold standard, no issue there. All esophageal conditions, gold standard again, if possible, always get it done laparoscopically. Bariatric surgery is always laparoscopic. Now, ventral hernias, I don't do any open ventral hernias unless it's very big. Diagnostic laparoscopy is a very underused thing in trauma. Sometimes CT scan tells you that there is some amount of blood in the peritoneum. We don't know where it's coming from. Earlier, we had to open up the abdomen and see where it's coming from. Now I stick in a laparoscope, and if I see a small capsular tear in the liver, or I see a very small mesenteric vein which has kind of stopped bleeding, then I take out the laparoscope and just treat him conservatively. Saves him a whole big incision. Same thing about undiagnosed ascites. There's ascites, they don't know where it's coming from. It could be cirrhosis, it could be tuberculosis, it could be malignancy. You put in a scope, 80% of the times I can give him a diagnosis. And intestinal obstruction with adhesions, one of the top indications, because if you keep opening the abdomen to remove adhesions, you're creating more adhesions. So if you can do it laparoscopically, even if it's going to take time, it's going to be very uncomfortable, it's better to do a laparoscopic adhesionolysis than open and do it. And TLH, of course, and ectopic gestation, and any surgery in an obese patient, if you can do it laparoscopically, it's always better. And list of common surgery usually performed like lap appendicectomy, like I said, no major advantage. Lap inguinal hernia, definite advantage only in 2 situations. If he has a bilateral inguinal hernia, advise him to go in for laparoscopic because that cuts down the pain and the incision. And if they've undergone an open inguinal hernia earlier and then he has a recurrence, then laparoscopic is better because you work through a virgin area. Leaner the patients, less the advantage. If there's a thin, lean patient, asthenic patient with hernia, I never advise laparoscopic. It's so much easier to do it open. Laparoscopic, the instruments are also clinging with each other. These are all the other surgeries which should be done laparoscopically, but here the surgeon skill set is very important. Adrenalectomy is one of the best because all these require very huge incisions otherwise. So, and we do all these surgeries laparoscopically and they give very good or equivalent results. What should be done by open surgery only? Large malignant tumors. Large ventral hernia with loss of domains, which means that all the intestines have come out. There's hardly any intestine in the abdomen. This you cannot approach laparoscopically. Recurrent, now the other thing is also true. If you've done a laparoscopic hernia and the hernia recurs, then you have to convert it to open. And cesarean section. God had ordained that 85% of the deliveries should be without any surgery. And now, unfortunately, it's almost the other way.
2 more minutes.
I'm sorry?
2 more minutes.
2 more minutes. I'll be done. Thank you. So this somehow should be a no-hole surgery is now a big incision surgery. So now, just for your information, I'm giving you 3 or 4 slides. These are the new developments that are taking place in laparoscopic surgery. There's now the vanity of humankind towards looking good, looking better is taking absurd lengths. The beauty industry is now some $5 billion worth industry and people are peddling any kind of things for anything. Last I heard was potato peel juice to be applied on the face and you will get this. So all kinds of things are happening. So we are following suit. So we have a single incision surgery where we just put 1 incision in the umbilicus, put this kind of port, these kind of instruments, and we do it. Very difficult to learn. I don't know if it's all that useful. I haven't done it, so I won't know. The other thing which is actually taking it to absurd is natural orifice transluminal endoscopic surgery, which means that they put the scopes through natural orifices. So they've used the vagina, they've used the rectum, and they've used the stomach to remove the gallbladder. I think this is really absurd because you're violating space. During most surgery, we try not to injure these organs and you're deliberately making holes in those organs, 3 holes sometimes, and you're doing a surgery. I really don't know why you want to take so much risk when we can do much more easily. And lastly, robotic surgery. Now this is here to stay and it has definite advantages. It's not just a fancy tool. It has definite, especially if you want to get your radical prostatectomy, oncosurgery, it has major advantages, radical prostatectomy, etc. Because it's very precise. It has instruments which has 540 degrees of freedom against our 360. 3D visualization, 20 times magnification. And if I'm getting old, if I'm 70, I have the knowledge in my head, I know the technique, but my hands start shaking. What do? They will filter my tremor. I am at the console sitting here operating, my hands may be shaking, but there in the operative site, there will be no shake. Any limited tight spaces, it will go there and gives you additional dexterity. Thank you. I hope I kept my time.
Thank you, sir. You have very well elaborated and the advantages and disadvantages of the open surgery and the laparoscopic surgery. You have very well explained, sir. Thank you very much. Any questions from the audience? I think one or two questions I think we can take up. I think no more questions. That means they are very well understood and you have
Thank you, sir.
very well explained.
Thank you so much for
Thank
the
you,
wonderful
sir. Thank
presentation. Now I request the chairpersons to honor Dr. Girish Hirode, sir. Persons, you are requested to receive your token of honor from Point of Honor Corner for Family Physicians during lunch hour. We have an exciting lucky draw after every 1 to 1.5 hours. I request all the delegates to keep their lucky draw coupon in hand. A person will come and collect it. For the next session, I would like to invite Dr. Dipti Shah Vadodara, Dr. Abhay Borgaonkar Sir, Gulbarg, Dr. Ashwin Shah, Ahmedabad, and Dr. Prafullata Ben Patel from Vadodara to chair the session. For next talk, I invite Dr. Vibha Nayak, oncophysician, on stage to enlighten us on cancer cell immune evasion and its therapeutic implications. I request the chairperson to introduce esteemed speaker.
Hello. Actually, Dr. Vibha Nayak doesn't require any introduction, at least for people, delegates from Gujarat. But still, to follow the protocol, I have to. Madam did her MBBS and MD from Government Medical College, Surat, and DM from BJ Medical College, Ahmedabad. Madam got gold medalist from Gujarat University in DM examination in the year 1995. Madam's special interests in her practice are bone marrow transplant, all solid tumors, pediatric cancers, and hematological malignancies. Madam is mostly attached in the major hospitals of the Vadodara for oncology setup. And Madam is also a visiting oncologist at SSGH also. Thanks, Madam. I request her to start her session.
Thank you, Dipti-ben, for the very kind introduction. At the outset, I would like to thank all the organizers who have invited me here for the talk. So after your previous talks, I know that cancer is something which would not much interest the family physicians. But I just want to tell you that today I am going to highlight that you have a patient coming to you asking you that I have been prescribed some immunotherapy. So you should have a basic understanding of immunotherapy. When I did my DM in 1993, I was the first batch and we had only 4 chemotherapeutic drugs. And now we have a battery of immunotherapy drugs. So I'll just begin my talk that it is, basically I'm going to talk about immunotherapy in cancer. So what is cancer? We all know it is uncontrolled growth, evading death, increased invasiveness. Can I have the pointer, please? So these were the two scientists, Douglas Hanahan and Robert Weinberg. In 2000 only, they have published a paper where they have described the hallmarks of cancer, what actually causes cancer. So we know that there is cancer in the body, but what actually causes cancer in the body? So the hallmarks of cancer are a conceptual framework for rationalizing the daunting complexity of cancer, where you have evading growth, sustaining proliferative signaling, mutation, and one of them is immune evasion. So the hypothesis in 2011 was that these 8 hallmark capabilities of the cell were mandatory for the manifestation of cancer and for the progression of cancer and for the invasiveness of cancer. So it is very important to know why cancer occurs and how we can actually address these daunting capabilities of the cell to then manifest and progress and invade. How are these hallmark capabilities acquired? Number one is by the phenotypes, and the most important is mutation. We all know that cancer occurs because of some genomic instability and mutation. Now this mutation can occur during birth, which is a germline mutation, or it can be acquired. Acquired mutation can be because of some environmental factors, smoking, alcohol, other reasons, chemical exposure. So the main thing is the mutation which occurs, which causes cancer, and there is tumor promoting inflammation, which is causing the progression of cancer. Now, beyond the foundation set by the cancer cells are outlaw organs. So when it is like the seed and the soil theory, you have the cancer seed and the soil. The soil in which it grows also acquires the capabilities of cancer, and it also becomes the cancer part of the cancer itself. So multiple normal and neoplastic cell types are assembled to become components of tumors, helping to provide the hallmark capability. So normal cells like stromal cell, fibroblasts, pericytes, they also become cancer cells. Finally, if we know about all this, are there any applications to cancer medicine? Yes, a growing armamentarium of smart drugs. Now what are smart drugs? You know what causes cancer, and you target that part with the smart drug, which can target each of the 8 hallmarks and their enabling phenotypes. So most important now that I am going to talk is avoiding the immune destruction. So William Coley and the birth of cancer immunotherapy. In the 18th century, there was an American surgeon who found out that if you can make remedy of mixed toxin, then one disease can cast out the other. So he used it on a Italian outlaw. His name was Signor Zola. He had a tumor in his neck, and he crafted a vaccine with 2 dead bacteria, Streptococcus pyogenes and Serratia marcinis, and he found that the tumor subsided. And because of this, there was a birth of immunotherapy. Later, Ellie McIntosh and Paul Ehrlich won the Nobel Prize 3 months later for the discovery of innate and humoral immunity. So immunity is necessary not only to fight bacteria, to fight viruses, to fight disease, but also to fight cancer. So cancer treatment has shifted. If you see, in since 1800, it was only surgery. Then by early 1900, it was radiation therapy. Then late 1990s was chemotherapy. Then in 2000 came targeted drugs, and it was only in 2010. So it has only been 15 years that we have immunotherapy with us. So immunotherapy is just increasing the immunity, the cellular immunity or the host immunity to fight the cancer. So the oncology meets immunity. What happens is actually the tumor cell is shedding some antigen which is foreign for the body. This antigen is picked up by the dendritic cell, and it is known as an antigen presenting cell. It travels to the lymph node, it primes the T cell to kill the tumor cell. Now there is something that the tumor cell is doing so that the T cell cannot kill the cancer cell. What is it doing? is the cancer cell is doing something to prevent the T cells from killing the cancer cell. So how does immunotherapy work? The cancer cell is secreting some proteins like CTLA4, PD1, PDL1 so that the T cell cannot kill the cancer cell. Now what does the immunotherapy do? It blocks off this immune checkpoint. So this is an immune checkpoint inhibitor. So PD1, anti-PD1, anti-PDL1 which you give for immunotherapy, they are immune checkpoint inhibitors so that the tumor cells which secrete the protein so that the T cell cannot kill the cancer cell, these things is blocked by giving immunotherapy. So basically it is that your own T cell can kill the cancer cell. And you know, you will be like only 2018, Tasuko Honjo is a Japanese scientist and James Ellison is an American scientist. In 2018, they got a Nobel Prize for detecting the immunotherapy of cancer. So PDL1 was discovered by Tasuko and CTLA4 by James Allison. And the first use of immunotherapy was anti-CTLA4 ipilimumab for treatment of metastatic melanoma. But they found that it did not have greater survival advantage. So they found out that other drugs like anti-PD1 and anti-PDL1 were more effective to treat metastatic melanoma. Now there are plethora of drugs that we are routinely using for treatment of different types of cancer. They are all tongue twisters, anti-PD1, anti-PDL1, anti-CTLA4. And you have a broad activity for different types of tumors. But only 10 to 30% of the patient respond. Mainly it is used for treatment of lung cancer, liver cancer, melanoma, renal cancer, cervical cancer. So this is my first case, female 44-year, premenopausal, biopsy is triple negative breast cancer. So it is not secreting ER, PR or HER2. PET is non-metastatic. In this patient now you give immunotherapy because the standard of care to treat triple negative breast cancer upfront before surgery is to incorporate immunotherapy along with chemotherapy because they have a higher pathological complete response of 64.8% versus chemotherapy only 51.2%. So you give immunotherapy along with chemotherapy and post 8 cycles you see the response. So this patient which was having a very large tumor has very good response and the PET becomes negative and the patient undergoes surgery. Now this is a second case. We are seeing a lot of head and neck cancers in Gujarat because we are the global capital of head and neck cancer, I think, in the world. And they come in very advanced stage. So this is a male, 64 years, multiple lines of chemotherapy, poor performance status, nutritionally compromised. And there's a very good trial from Tata Memorial Hospital which uses low dose immunotherapy with oral chemotherapy. And in this patient we had a very good response. Even I was surprised with the response. Another patient also, multiple lines of treatment, very good response. And there is this patient of CA lung, treated with chemotherapy, post 6 cycles, the middle PET scan is showing incomplete response, only partial response. Now what do you do beyond this? This patient was PDL1 positive, so you added immunotherapy and this tumor completely disappeared in 6 months. The top one is the post chemotherapy and the bottom of the CT scan is after immunotherapy. You continue for 2 years and patient has very good survival. So 5-year outcome with pembrolizumab versus chemotherapy for metastatic non-small cell lung cancer, the 5-year overall survival and the progression-free survival is better than you give along with immunotherapy rather than giving only chemotherapy. And the only hematological malignancy where you can use immunotherapy is high-grade Hodgkin's lymphoma. So this patient, 68-year-old, bulky stage 4 classic Hodgkin's lymphoma, high score, you give 6 cycles of immunotherapy along with chemotherapy. So in 1975, the standard of treatment for Hodgkin's lymphoma was ABVD. Then came antibody conjugate in 2018. And in 2024, recently, they have introduced immunotherapy and along with chemotherapy in treatment of Hodgkin's lymphoma. So what is most important is to identify the patients who will respond. Identify who will respond. And what is the method used? The method is immunohistochemistry is used to detect and there is a progression score, you have a TPS and a CPS score, which will tell you from the lab which patient is going to respond. So patient who have a score less than or equal to 1 will not respond, and patients who have a high score more than or equal to 1 will respond to immunotherapy. And others are the next generation sequencing. You have MSI and FDA approved immunotherapy for those who have high MSI or high tumor mutational burden. So now you want to identify the combination that extend the depth and breadth of chemotherapy. So future is you use the combination, which is the target and which will benefit the patient. So if you are going to combine immunotherapy with chemotherapy, with targeted drugs, with other drugs, which will help us to conquer cancer. So basically, if you have an enemy, you are going to attack by land, by sea, and by air. Similarly, if you have cancer, you have your first chance is your best chance. You hit hard so that evo jorthi thappad maro ke cancer ubbo na thai. So what do? You combine, you use different combinations, and there are trials which will help you give insight which combinations work best for your patients. So you can combine immunotherapy with anything and everything. So if you use combination, this is a hypothetical Kaplan-Meier curve where you use combinations and your survival is better. And when you combine chemoradiation with immunotherapy, you are increasing the tumor cell killing, improved tumor recognition, immune priming, and overcoming the immune resistance. That is why it is important to combine immunotherapy with chemotherapy or radiotherapy to treat your patients. So what happens is when you have an innate response or the tumor is having immune response, those respond better to immunotherapy. But those patients who don't have an immune response, the T cells have not been primed or the T cells have been primed but they are not able to kill the tumor cells, in those patients the response is poor. So what do is you combine it with different chemotherapy or radiotherapy to achieve a better response in such patients. And what is the sign of light? There are successful clinical trials which are hallmark co-targeting of immune evasion and the tumor vasculature. Most important is in progress is pembrolizumab, which is an anti-PD-1 plus fecal microbe transplant. So what is fecal microbe transplant? The fecal microbe transplant is that you have to enhance the T cell killing by giving you're transplanting the fecal mycobacteria into the patient. So what happens is the current approaches largely address patient with pre-existing immunity. But there are some patients who will not have a pre-existing immunity. So they are known as cold tumors. They are immune deserts or immune excluded. Now how do you make those patients kill the cancer cell? So you are going to help prime the T cell by doing certain things, by giving chemotherapy, by giving targeted treatments, by giving other vaccines or T cell priming agents to help them enhance the effect of immunotherapy. And response rate is correlated with the mutational frequency. So smokers who develop lung cancer have better response with immunotherapy because they have more mutations. So more mutations, more hot tumors have better response to immunotherapy. So cancer immunotherapy, diet is very important. Like other diseases, diet, microbiome and patient genetics plays a very important role to determine which patient will respond to immunotherapy. So what happens is that you have role of gut microbiome in cancer immunotherapy from predictive marker to a therapeutic target. So you have beneficial microbiome. So now the whole world is shifting towards microbacteria. So how many microbacteria reside in our body? 10 raised to 14 million. Now these microbacteria will decide not only cancer but other diseases as well. So what happens is if you can modify, there are intrinsic factors which you cannot modify, but your your microbacteria, microbiome in the gut can be modified. Now how do they do it? What they do is they take healthy flora from the donor and they inject it or they inject it into the gut of the person who is suffering from cancer to have better response to immunotherapy. So different types of cancer like lung cancer, liver cancer, melanoma, where you want better response to immunotherapy, and they study the microbiota of the patient. And if it is lacking in those healthy microbiota, they are then passed on to the patient through the fecal route from the donor. And these healthy microbiota, so that is now forming the backbone of all types of diseases. I believe not only cancer, but all types of diseases. That is why they say that gut health is the most important backbone to treat any disease. Whether it is cardiac disease, whether it is cancer, whether it is diabetes. That is why came the year of the millet, where you have high fiber diet, complex carbohydrate, prebiotics, probiotics. So that is very important backbone of any disease treatment, and that is also the backbone of cancer treatment and immunotherapy. So response to immunotherapy, now I am coming to my few last slides. They are CAR T cell therapy. You must have read in the newspapers what is CAR T cell. So what they are doing is they are just genetically modifying the T cells from the patient, and they are engineered with a fusion protein which is known as chimeric antigen receptor. This is then given back to the patient so that the T cells become more stronger and more robust to fight the cancer. So it was main use was to treat leukemia, relapsed leukemia, and this is the first child, Emily Whitehead from US, who had a relapse of acute lymphatic leukemia, and she underwent, this was a trial time, that was in 2012. So this was just in trial, CAR T cell, and she successfully responded to the treatment, and now she is beyond, see, like 2025 this year, and she underwent CAR T cell therapy in 2012. So take home messages that in the past we didn't have the understanding of the immunotherapy. Now immunotherapy is the backbone of cancer treatment. We don't know which patients will respond. Only 10 to 30% of patients will respond. So we have to do something to help the patient respond to the immunotherapy. So that is by changing the gut bacteria, by doing fecal transplants, so that the patient has a more healthy gut to fight the cancer and to get better response from the immunotherapy. Now this is my last slide. We all know the battle of Mahabharata and how Abhimanyu.
So there are my inputs. Of course, there is no major data management. So the scope of presentation is, we'll try to discuss prevalence of herpes zoster in comorbid conditions, the efficacy and safety of Shingrix vaccine, and the indications of Shingrix vaccine. Well, so this is how we'll go. We'll go as far as herpes is concerned with comorbidities like diabetes, COPD, a cardiovascular disease, the efficacy after the age of 50, the trials supporting this efficacy of Shingrix vaccine, and the safety of Shingrix vaccine, and the recommendations of international bodies about herpes Shingrix vaccine. So we all know that herpes manifests and gives a very disastrous time to a lot of patients. I'll start with 3 cases that I saw in last few days. A 65-year-old female had pain in left lumbar region, for which she was rushed to a urologist by the relations, considering it was a calculous disease, sent her to a gastroenterologist to rule out a GI issue. The gastroenterologist did upper GI endoscopy and found out that there was hiatus hernia and advised treatment for hiatus hernia. This was day 1 and day 2 of the disease. She had comorbidities like ischemic heart disease, hypertension, obesity, cholelithiasis, uremia, and so on. Typical patient with obesity. Day 3, the patient had rashes starting from lumbar region, developing severe pain, rashes. She was diagnosed to have herpes zoster, treated with acyclovir, still continues to have severe pain and is gradually recovering. This is the second patient. She returned from USA and she had severe left leg pain which was attributed to there is a decrease in specific cell-mediated immunity, and there is a decrease in specific cell-mediated immunity, and this in turn leads to zoster virus reactivation. There is an increasing prevalence of herpes zoster because of age, comorbidity, immunotherapy, and various other factors. The common complications, as we see, are post-herpetic neuralgia and herpes zoster ophthalmicus. If you see this data across world, if you see there is a very high prevalence of herpes as the age advances. Right from the age of 50, there is a peak in incidences of herpes, and that goes to a peak in the 70s and 80s. So as age advances, there is a higher prevalence of herpes zoster. Therefore, a senior citizen is more likely to have herpes zoster. This is the data from Asia. If you look Taiwan, Japan, China, again, there is a peak in incidence of herpes after the age of 50. So roughly 50 and early 50s is a trigger for herpes zoster reactivation, symptomatic presentation, and therefore we need to be very cautious and vigorous in detecting and treating them. If you look at comorbidities and psychological stress affecting herpes, disease like depression, asthma, diabetes, chronic kidney disease, cardiovascular conditions, COPD, each of them can increase prevalence of herpes zoster by 1.29 to 1.41 times. So typically a patient of diabetes is likely to have more incidence of herpes zoster, so a patient of cardiovascular disease, so a patient of COPD. In fact, psychological stress and physical trauma itself can double the incidence of herpes zoster. So comorbidities do create problem. If you have two coexisting comorbidities, diabetes and hypertension, COPD and congestive heart failure, diabetes and a cardiovascular disease or heart failure, there is almost doubling the incidence of herpes zoster. So if you look at herpes zoster in a patient just with one morbidity like a diabetes, the chances are 2 to 2.5 times. As there are two diseases like a heart failure or ischemic heart disease or a COPD, this becomes double. In short, one disease can lead to high incidence of herpes, and if there are 2 or 3 comorbidities, the prevalence of herpes goes up remarkably. Lots of patients come to us and say that I had herpes zoster 20 years back, 30 years back. Are there chances of me having a recurrence of herpes? Do I need relapse? And if it is seen that in patients of chronic kidney disease, dyslipidemia, diabetes and hypertension, there is almost 22 to 35% or 40% high chances of getting a herpes recurrence at any age. And as age advances, after the first episode of incidence of herpes zoster, around 5 years down the line, there is a very high chance of patient getting a recurrence of herpes. So herpes is not a disease which gives you lifelong immunity, and therefore it's very important that we be very vigilant about recurrence of herpes, even in a non-immunocompromised, that is a patient having reasonably good immunity, but having comorbidities. So if you look at diabetes, just how diabetes can predispose to herpes zoster. We all know the immune system, the adaptive immune system and innate immune system containing of physical, chemical barriers, and the adaptive immune system consisting of cell-mediated response and humoral response. So typically we have cellular immunity and humoral immunity which protects us against viruses, bacteria and infections. Now in a patient of diabetes, there is disordered humoral immunity and impairment of cell-mediated immunity. There is a T cell imbalance, there is high CD4, CD28 cells, low CD4 cells, leading to adaptive immune system dysregulation. Long-term hypoglycemia leads to polymorphonuclear cell apoptosis, increase in inflammation, pro-inflammatory cytokines, and therefore there is dysregulation of innate immune system. And there is a diminished innate immune response system because of various dysfunction of polymorphonucleosides, monocytes and macrophages. Therefore, a diabetic is typically having a high risk of having herpes zoster. There is an insulin degrading enzyme which is now considered to be one of the causes of insulin resistance, and that the enzyme itself can lead to a higher incidence of herpes zoster. And therefore, if you look at various meta-analyses, large cohort of patients, million patients, if you see here, in type 1, type 2 diabetes, and these are meta-analyses, 14 and 32 diabetic studies in patients of type 1 and type 2 diabetes. The pooled risk ratio showed there was 1.30 and 1.24 times. So that is 30% and 24% higher prevalence of herpes zoster when there is diabetes as a coexisting morbidity. Now, if you look at complications of post-herpes, that is post-herpetic neuralgia, and this is a large cohort in Asia. If you look at more than 100,000 patients, those having diabetes had very high prevalence of post-herpetic neuralgia to the tune of 19 to 70% more. So roughly 1.5 to 2 times higher prevalence of post-herpetic neuralgia, showing that diabetes predisposes to herpes, number one, and there is a very high chance of post-herpetic neuralgia. Herpes zoster itself may also lead to disruption in glycemic control with worsening of A1C, worsening of fasting and PP2 blood sugar. So, patients with diabetes are more prone to herpes and more prone to herpes complications. If you look at a typical care of a patient of diabetes or herpes, in United States, for example, a patient of herpes may end up requiring budget of 25,000 because of various reasons, the drugs, the hospitalization, the rest, and so on. If there is
to the society. So all these 3-4 aspects should come together if one person's mental health has to be optimum. And like physical illnesses, mental illnesses also are there. And there are so many kinds of mental illnesses. Mental health is getting a lot of, coverage, and the due it is worth. It is, of course, after COVID, we all came to know, the mental health consequences. In fact, it was also called as the mental health pandemic in addition to the infectious virus, because the number of people that were affected were actually 3 to 4 times more than the COVID infections themselves. The lockdown and the kind of psychological consequences it had, and so many people losing their job, migrants, this, that, everything, they led to psychological and mental health consequences. So when it comes to how commonly these mental disorders are there in the country, of course, the reference goes back to the National Mental Health Survey. National Mental Health Survey 1, 2015-16, the data says about 11% of the Indian population, they do have one or the other, psychiatric disorder, diagnosable psychiatric disorder. So which translates to about 15 crores. So at any given point in time, there are about 15 crore people in the entire country who require, some kind of, diagnosis and treatment for psychiatric disorders. Also, when it comes to the primary care setups, repeatedly over the past 50 years, it's shown. Thank you. Repeatedly, what has been shown by research, not once, many times, that at least 30% of the primary care attendances, I am sure you also are aware of this on your day-to-day practice, that up to 30% of the attendances in primary care clinics, they do have psychiatric disorders and not physical disorders. So when you look at the treatment gap, it is about 75-80%, as high as 75 to 80% in National Mental Health Survey. And if the gap comes down in the primary care clinics, I think it will go a long way for reducing the gap. I'd like to stop here because time is less, and if there is more opportunity, we'll talk.
Thank you. I think the key point takeaway is 70 to 90% of the persons with psychiatric illness do not take treatment. It can be for several reasons. Primarily what we can say is we have possibly not been able to identify who has got that illness. Now, which is where NIMHANS tried to look at a pilot study. It was done sometime in 1990s. It was called as a Mandya study. When patients who were coming to the district hospital in Mandya, they tried to find out how many of them had got an alcohol-related problem. The problem was the physicians there did not ask about the problem. So after they were oriented, the number of people who could be detected increased from 10% to 40%. So in that sense, just asking that question becomes important. We developed on that model. Now we have got the Karnataka telementoring model, which has also got the National Innovation Award. And the person who coordinated that whole thing was Dr. Manjunath. Dr. Manjunath, kindly tell us what is this telementoring model and how do you relate it to the primary care physicians?
Thank you very much, sir. Thank you for all of you given an opportunity for us to come over and talk some of things. I'll just take few minutes. The moment you people hear psychiatry, you feel we have to spend a lot of time with the patient, right? That is the one. So that on that, nobody can think on that. It should not be. Actually, we hardly takes 2 to 3 minutes or maximum 5 minutes in our Niman's OPD when we see first consultation. This is the reality. Based on this, we have developed a primary care psychiatry program in last 10 years, which is a digitally driven. And I will give you how we have worked out in India. And we have implemented in many states in India. One is that psychiatry, we have a lot of big books that is not helpful for family physician. We have just made a psychiatric small manual which is called Clinical Schedule of Primary Care, which is 6-page manual. If you read 6 pages, that is enough for you, any MBBS doctor, to practice psychiatry in their general practice. That is the first thing. Next, coming to training. I am a psychiatrist here. You think that all of your family physician, I will talk about psychiatry for 1 day, 2 day, 3 days. The moment you go and start seeing your patient, do you think these 3 days knowledge which you heard is implementable? No. So what we did is something like this. We have trained family physician in their live OPD. In their, not mine. We used to go and sit in their live OPD in general practice, general patient. We have trained them how to ask question, how to diagnose psychiatric disorder, how to write prescription, how to, most of the time it is a replacement of symptomatic treatment which family physician has given. So what kind of training program which we are given? First and foremost, the on-consultation training means live consultation of general practice, family physician is doing, I am sitting with them, I trained. Then how did I train? See, for example, I just go in a first session, I will say that, can I see your first 10 patients, general patients? I will see and I will give it to you and I will tell my opinion. Okay, then you see what you can do. Then after 10, I will say that, okay, why don't you try in this way? The way I examine the patient, you also do it and see, discuss with us. Then final 3 is you are independent, I am just observer. What we called as a Acharya training method. It is something like that. I see your patient, you just see it yourself. Next, you try it yourself in front of me. Then at the end, you are independent, you do it yourself. I am just seeing, if you ask, I will open up my mouth, otherwise I will not open up. So that is the kind of training program we have done. Then this was inpatient, this is on a general patients. Then another model which we have developed is a collaborative video consultation. It means whenever family physician is seeing patients, he gets some doubt about psychiatric issue, immediately he will connect to us in a video and show his patient and discuss with us in the on-spot live. So this is called collaborative video consultation. This is the way we trained and we have found very interesting phenomena across the India. And at the end, all of us will say how much effective it is. And to assess the effective, one of the method which we have used is, in their live patient, we have, one of the psychiatrists who has not trained him, assessed in 5 to 10 patients and found out whether he has used psychiatric skill or not. Without that, he would not be passed in the diploma in primary care psychiatry program. 1 year course we have designed and we have implemented in many states in India. That is a flexible course, part-time course. Doctor doesn't need to come to Niman's or anywhere. He will be trained in his own patient, own clinic, kind of thing. Thank you very much.
Thank you, Dr. Manjunath. The key take-home message is just asking the 2 or 3 questions in a different way from what you're already doing, you'll be able to help the patient much better. Let me use one anecdote told by Dr. R.P. Joshi, who was the Chief Medical Officer in CGHS. We at Niman's had got a very good collaboration with all the CGHS health and wellness centers. After taking the training, he said, Dr. Girish, if we had included just a small dose of antidepressant to our patients with diabetes, their compliance would have been much, much better. They would. So why don't you call many of the antidepressant doses also as anti-diabetic agents? That is different. But the issue is this is again systematic review, meta-analysis. 19% of those with diabetes have got a diagnosable mental disorder. nearly 32% of those with hypertension have got anxiety-related disorders. So identifying them is an issue. Identifying them is a challenge. Now that is where I come to the point. I request Dr. Bhavesh. Dr. Bhavesh, what are the challenges for looking at primary health care and mental illness? Over to you.
Thank you, Dr. Girish. As you know, I am faculty at AIMS along with the many programs. So usually teacher asks question, and our MBBS generally this question is asked as a first question: what is health? Definition of health, can someone tell me? Physical, mental and social well-being, not merely absence of disease of it. And all our patient work ends up only in physical, blood tests, parameters, we are not looking at. And if we look at India's disease profile, we know before 20 years, any fever, malaria, then any fever, any flu, Tamiflu, things keep on changing. Earlier, maximum of our practice was diarrhea, ARI, TB. Now our practice is mostly diabetes, hypertension and mental health. And that is the challenge for us because we don't know what to do or what to ask. Right? Like if you have a patient coming with 2-week cough, what will you do? Send it for sputum or contact district TB officer. If there is child, you will ask for vaccination. But someone comes with anxiety or stress, what should we do? What are we doing right now? Ignoring it? Or if possible, refer to psychiatry, but patient will accept that? No. Why? Stigma. But they will come to you. If you can solve out at your level, they don't have any problem, right? Like initially when HIV clinic started, it was running in isolation. They were saying it is confidential, but in that room only HIV positive patients were going. So it was not successful. Then the name changed to integrated counseling testing. So antenatal mother also going there, TB patient was also going there, undernutrition is also going there, and HIV positive also going. So if we talk about primary health care, solution only family physicians can provide. Even government, we have a huge system of PHCs, sub-center, health and wellness center, but only less than 20% patient go to government setup for OPD. 80% goes to private, right? So purpose of this when we were doing brainstorming, that how to move forward. First we need to know what are the challenges and then we need to provide the solution. And if we know how to manage this patient, at least 80-90% as Manjunath sir said, can be easily managed at your level. Then if required, they can be referred to psychiatry but further. But there is a lot of patients are coming, but because we are not knowing, your eye sees what your mind knows, right? So that is the purpose of bringing all of us together. And as we were just discussing, usually CME conference pata etle, we say it is done. But here what we thought is, it is a beginning. So how to move forward with this, I request Dr. Pragnesh to throw some light about possible future plan and collectively how we all can help each other to move forward. Thank you.
Thank you. We all know about AIMS. But the NIMANS, National Institute of Mental Health and Neurology Sciences. So today we officially declare that NIMANS and FPI will do survey and research work for the betterment of the Indian population in future. And one more thing, that you all are the part of that survey. What I mean to that, there are 10 to 12,000 members of the FFPI. They all are the part of that survey, and whichever survey we will publish, for example, Dr. X has submitted his data as per the designed by the team. Their name is there in that paper that it is contributed. Doctor, for example, Dr. Manish is a contributor of that survey. So like that, and it's time to contribute for the mental health. Thank you very much.
Thank you, Dr. Pragnesh, for the sweet news. Thank you for that sweet news. That is why we have got some sweets from Bangalore. I'd request Naveen and Manjunath to please hand over that box of sweets to both the Pragneshes. That is the famous Mysore Pak and the Dharwad Peda. I could not afford to give it to all of you. No. We should have a photo together. I'll come back to the photo. The whole thing is, there are three things which we are planning. One, as Dr. Bhavesh said, Government of India in 2012 accepted that nearly 69% of the patients in India are being seen at the primary care level, not just at the government sector, but at the private sector level. That is there as an annual report of Health of India in the Government of India, Ministry of Health and Family Welfare website. Till such time we had not seen. 2012 it was brought in. We need to now look at adding that towards the data. That is why we have got a short form. We would give it to you so that we want to know how many patients you are seeing per day, per month, old cases, how many, new cases. Even if it's a approximate number, that is okay. How many of them have mental illness? As per your own definition. As Dr. Naveen said, there could be several. But you think this person has got a mental illness, some psychological issue, something which you think you are not able to handle. Please write that number so that we will try to collate that with whoever is here today. Plus also we'll do an online form so that we'll get that data so that it can become part of officially the National Mental Health Survey. That is one. The second one, we did not want to have a very detailed PowerPoint presentation. We wanted to share with you, plus also take some questions from you so that we can practically show how things can be made different. Two things can happen after immediately next 1 minute. We will open up the floor for discussion, for question answer session. But also keep in mind the Telemanus number 14416. It's available. We'll post this also onto the WhatsApp group. Any person anywhere in India can call up this number. Help is available 24/7. Help is available in 20 languages of India, including Gujarati. They can call up this number and get support. Not just the patients, in case you wanted some guidance, assistance, you can call up that number, tell them that you're a doctor. They will immediately connect you to the local psychiatrist, dedicated psychiatrist for Telemanus, so that they can support you to make a diagnosis. Third one.
Please, sir. Sir, please conclude.
Oh, last slide. Okay. Oh, timing. Sorry. Noted. I was wondering where the voice is coming from. We're just winding up. Third one is, as Dr. Manjunath was saying, we want to open up the primary care psychiatry diploma course. We would like to share that with you so that anyone who would like to get formally trained, you can become part of that. Along with that, we would like to have a specific training program which could be supported in some manner. We will work with the organization so that this could become a reality. With that, I will just stop here. We could take 1 or 2 questions. I request the organizers if that is convenient. I will request Dr. Naveen and Dr. Manjunath. Only technical questions, please. Any other things we can always handle later. Yes, madam. Yes, definitely. We'll do that. We'll do that immediately. Anything else? Any other question? I saw some hand out. Okay. This is the survey questionnaire. The hard copy is being distributed. Please take 1 minute of your time, fill it up and immediately return it to me so that we will be able to collate it and then use it for analysis. It shouldn't take more than 30 seconds. With that, please give a big hand to the whole team. Please give a big hand to all of you. because what we are about to do is make a history differently, because most of the time we talk only about public sector. For the first time, we are trying to look at public sector, private sector, forget about all these sectors. We are trying to look at the citizen of India who can be helped in as much better a manner possible. Thank you very much.
You are requested to give the form at the registration counter after filling. That form is distributed right now.
Dr. Girish Rao. Dr. Manjunathan sir. Dr. Naveen Kumar sir. Lastly, Dr. Bhavesh Modi sir. Please give a big round of applause. For the next session, I would like to invite Dr. Manandani from Vadodara, Dr. Mehmood Merchant sir from Mumbai, Dr. Suryakant Pandit sir from Mumbai, and Dr. Ramesh Jain from Surat to chair the session. For next talk, I invite Dr. Chirag Seth sir on stage to enlighten us on palpitation, managing palpitation for a healthier tomorrow. And I request the chairperson to introduce the esteemed speaker.
Hello. Dr. Chirag Seth, sir, Chief Interventional Cardiologist, Head Department of Cardiac Catheterization and Intervention, Director, Cardiac Science, Rhythm Heart Institute. Please welcome, sir.
Thank you. So, very good afternoon to everyone. And it's an impressive meeting, impressive talk, especially the session on mental health. Really impressed with the initiatives that the FPI is taking. And going forward, a talk on palpitation, what can be a better talk after the talk on mental health? There is so much of close correlation. A lot of patients also would, those with mental health might have palpitation. Those who have palpitation ultimately suffer from mental illness also because of the chronicity of problem. So I think, can I have my slides, please? It's there. Fine. So I thank Dr. Pragnesh for inviting me for this talk, which is ultimately going to back to our MBBS days probably. We might have been taught about palpitation way back in second year, third year of clinical postings. So with kind permission of chairpersons, we'll go ahead with the talk. So we'll try to stick to basics and put in diagnostic intricacies in the talk. So as we know, subjective perception of own heart beating is described as palpitation, and we know that altered chronotropy or altered inotropy both may cause it. It is commonly equated to fast heart beating, but we must understand that it may not be that fast always. One can have slow palpitations also or not very fast heart beating as well. And therefore, whenever we approach a patient with a history, we should look into it. How fast was the palpitation? So commonly, the heart rate beyond normal limits, but when it is proportional to physiological needs, palpitation may be there. Common examples are exercise and mental stress. There can be heart rate which is disproportionate to physiological needs, like in presence of supraventricular tachycardia or atrial fibrillation, sympathomimetic drugs, commonly cough syrups, which can lead to tachycardia and palpitation. Then there can be irregular heartbeats because of ectopics happening, which can be ventricular, atrial, or junctional beats leading to palpitation. And there could be conditions with increased cardiac output, mainly in the conditions like aortic regurgitation, anemia, thyrotoxicosis, complete heart block. All those things can also present with palpitation. These are common associated overlapping symptoms many patients with palpitation would come with. That can be syncope, pre-syncope, fatigue, and dyspnea. So we need to assess a patient in totality and not just focus on the history of palpitation. Let's deep dive into the topic with some case examples, which are real life scenarios. So this is one class 10 student who was attending a class at a coaching center. So class 10, everyone can relate to. They are mentally stressed out. Teacher yells at the student as he was sleepy. Maybe he has not slept well previous night. He was sleepy in the class and the teacher yells at him to wake him up probably. Others note that he shivered and passed out for a while. He was sent home with a note that he has attention issues. And because he passed out, he was brought to a checkup. On interrogation, he said that he did have some palpitation before passing out, and that history is important. Not just related to the history that he just passed out because of lack of sleep. Clinical examination was unremarkable. Echo was structurally normal, and this was the ECG. I think Dr. Pragnesh is there, and many of you who have a ECG machine with you will be able to see that this ECG practically looks to be normal, right? It looks to be fine. There is some variation in RR intervals, which is physiological at this age, because these patients do have a good amount of vagal tone also at this age. So it could be sinus arrhythmia, which is otherwise normal. So this is entirely normal looking ECG when we have a first glance of it. But when we look at close, what is important is someone who has passed out, we cannot really allow him to go like this. We need to look closer. And what we see here, focus on T waves. T waves are showing bifid nature. That bifid nature of T wave alerts us that this is not normal. A bifid nature says that this patient is at high risk of developing ventricular arrhythmias. And his repolarization, cardiac repolarization, is at fault. A normal T wave is rounded. It's never peaked. It is rounded in contour, single peak, never bifid. So a broad bifid P wave raised the suspicion that that event was malignant. And what is that malignancy? This. It is torsade de pointis. It's called polymorphic ventricular tachycardia. These patients are prone to develop ventricular tachycardia and sudden cardiac death. This was typically a type 2 long QT syndrome in which the QT intervals may be labile. They may be exercise related. They may appear after exercise. They may not be evident on first surface ECG. So long QT always may not be evident on first ECG. It may be labile, and therefore it is important that all of suspected patients need to have a Holter monitoring. They should be undergoing stress testing if and when required. And important is that a family history also should be asked about, whether they have any family history of sudden cardiac death, right? So important here in this patient was that this particular type of long QT syndrome is precipitating arrhythmias because of auditory stimuli or loud noise or thunder or even sudden waking up, right? So these kind of things also bring about triggered activity in patients who have vulnerable QT interval prolongation leading to palpitation and syncope, right? Most these patients are well on beta blockers, mostly propranolols, and resistant cases will need cervical sympathectomy and AICD implantation. A second 30-year-old male recently changed his job, again temperamental issues and marital discord. Came with palpitation and fatigue when he was pulling his bike at roadside. And the ECG showed this. I mean, now everyone would be able to answer this. A deeply inverted T wave, evidence of LV hypertrophy. Yes, apical hypertrophy, typical, right? When you do echo, it is showing hypertrophic cardiomyopathy, right? So exertional palpitation in hypertrophic cardiomyopathy is largely because of tachycardia leading to fall in cardiac output. But some patients can have exercise-induced arrhythmias also, which can be fatal. Cardiac MR is recommendable in all these patients to detect myocardial fibrosis, and beta blockers, and again, implantable cardiovascular defibrillator are the treatment of choice to prevent sudden cardiac death. Again, a 22-year-old female, pregnant, and has severe mitral stenosis, pulmonary hypertension. So palpitation is very common in all these patients, right? But this patient had a spontaneous palpitation at rest, not only exertional. She had palpitation at rest, right? So commonly we would feel that it could be atrial fibrillation, right? But what the surface ECG showed was, I'm sorry about the resolution, but yes, it shows a WPW syndrome, right? It shows delta wave, pre-excitation, broadening of QRS, telling that it is not only rheumatic heart disease which is making her symptomatic, but she has associated SVT happening, supraventricular tachycardia because of WPW syndrome happening. A 60 years COPD becomes worse after nebulization. What does it show? Again, it shows tachycardia, which is showing right bundle branch morphology, and there is equal number of P waves with equal number of QRS and a typical right bundle branch morphology looking like atrial tachycardia. So at times, sympathomimetic drugs as a part of nebulizer therapy can precipitate tachyarrhythmias, and COPD having hypoxia and increasing pulmonary pressures also can give rise to arrhythmia, and you can have presentation during COPD exacerbation, arrhythmia as a pathology which can make their condition worse. Largely nebulizers are not majority problems, but salbutamol group of drugs can cause tachycardias, right? 52-year male with exertional palpitation, mind well. So resting ECG was normal, no diabetes, hypertension, normal resting ECG, resting echo normal. So we made him subjected to treadmill. That since everything is normal and your symptoms are only exertional, better you go ahead and do a treadmill. What do we find on treadmill? So treadmill shows, what do you see? Treadmill shows again every QRS has a preceding P wave, but the QRS duration, the width of QRS changes. At times it is narrow, at times it is broad, at times it is intermediate. If you look at the first panel, you can see that there is P wave followed by QRS, but all QRS complexes are having different width. Why is it so? Because this patient has associated again WPW syndrome. So part of conduction is happening through node, part of conduction is happening through accessory pathway. So ventricle is activated by two different inputs, node as well as pathway. If it is dominantly through node, QRS is narrow. If it is partial through both things, QRS becomes broad. If it is only through pathway, it is absolutely broad. So because of increasing sympathetic tone, conduction across pathway as well as node increases, and therefore this gives you different degrees of fusion, leading to narrowing and broadening of QRS. So picked up on treadmill, this is WPW syndrome. Again picked up on treadmill, not on surface ECG. So it is important to evaluate based on history what the patient has, and that can give you a clue to diagnosis, right? And lastly, a patient on pacemaker complaining palpitation. Like pacemakers are put for what? Bradycardia indication, right? That patient does not have his own rhythm. He has problem with AV block, or patient has a sinus node disease, so patient is unable to generate their own cardiac activity. So what if that patient complains of palpitation, right? And if we see here, the rate is pretty high. And this patient did receive every antiarrhythmic drug before coming to us. Like he had amiodarone given, beta blocker given, digoxin given. It does not change the clinical profile, right? So this was nothing else but a pacemaker mediated tachycardia. Like, so pacemaker, we have to program the rate, and we have to program refractory period of the particular lead also, atrial lead and ventricular lead. So if refractoriness is short, you can have pacemaker mediated tachycardias happening, and it is not amenable to medication therapy. You have to prolong the atrial refractory period in the atrial channel. That can improve overall, it can terminate the tachycardia. So I think I'll not go into the details of everything because the time won't permit, but I would end the talk with this, that we have a broad spectrum of differential diagnosis with palpitation. Important is history, and history. ECG, in carefully selected cases, even treadmill, echo, and extended Holter. Cardiac MR and FDG PET are important evaluations for ventricular arrhythmic disorders who present with history of palpitation. And lastly, genetic testing is important in those with suspected disorders of inherited channelopathies. Thank you for a patient hearing.
Thank you.
Yeah.
How many cases you have seen AVNRT? According to treatment, whether it's a lifelong beta blocker or cerebral AVNRT?
So AVNRT is very common. let's say out of 100 patients seen in OPD, probably 5 would come up with SVTs. And the first treatment of choice definitely is rate-limiting drug. But yeah, if they are symptomatic of syncope, pre-syncope, or young patient who do not want to be on therapy, in all of these patients, ablation is a treatment of choice. Radiofrequency ablation is a low-risk procedure, easily available, and they can give good cure in 98% of patients. They do not need to be on medication for lifetime. Yeah, majority of times a typical AVNRT single ablation is fine. 1 to 2% of people may have recurrences and they may require repeat ablation. Brugada syndrome is pretty underdiagnosed. Brugada pattern is more common. So pattern is when you have ST elevation in V1, V2 with a right bundle branch block morphology and a downsloping ST segment shift with a J point elevation. That Brugada pattern ECG is very common. You find in many cases, but Brugada syndrome, meaning thereby those who have history of aborted sudden cardiac death or family history of sudden death, that is relatively rare. We see more commonly drug-induced arrhythmias more commonly. Let's say hypokalemia, worsening QT syndromes and causing VT. Ischemia causing Brugada-like pattern. Aluminum phosphide poisoning producing Brugada-like pattern. So it is more common than classical Brugada syndrome, but yes, they are under-recognized, under-diagnosed entities, and your attention goes to those patients only when they have history of aborted sudden cardiac death and you evaluate with ECGs and then find out.
Thank you, sir.
Yes. Yeah. Yeah. I think it is better to use beta blockers rather than ivabradine. Reason being, see, corona is no different than any other viral infection which can cause dysautonomia. You can have autonomic tone disturbances with viral infections. It is possible, it can happen. And therefore, the best drug is when you see a sympathetic parasympathetic imbalance, when the issue is tachycardia, chronotropic incompetence, patient having symptoms, it is better to put them on beta blocker rather than ivabradine. Ivabradine does not change sympathetic tone per se. It acts on sinus firing and reduces the sinus firing rate. So patients, and ivabradine will bring down pulse to the tune of maybe 5 to 10 beats. So if the pulse rate, let's say your patient comes at the rate of 130, it may go down to maybe 115. Still he will continue to have tachycardia. So it is better to use a potent drug and give them a better symptomatic relief. I would prefer a beta blocker. So either of them, either metoprolol long acting or a propranolol long acting, either of them is fine. No, most often not. Most often they are self-limiting. But the thing is, when the patient is elderly, he is likely to have comorbidities. So try to avoid drugs which are potential sympathomimetrics. And be aware that this could happen, that's all.
Now no more questions. We are running out of the time.
Thank you so much. Thank you.
Thank you, sir. You made a complex topic accessible and interesting. Now I request chairperson to honor.
Some comment, if you allow. Yeah, please.
Hello, good morning. I thank the organizers who requested me to chair this session. Before Dr. Avni takes over it, I appreciate the scientific committee of taking this particular topic. In last 1 month, we attended some 2 lectures in Mumbai and Rahija, and there are indications for obstructive sleep apnea to do, what is that? Madam, sonography. And second, we attended on colon cancer. So what the doctors advise their consultant, above the age of 40, one should do for MRI. So all of us as a family physician, we believe in clinical practice, but in our armamentarium, we should know what other investigations are required. And I feel Dr. Avni Jain is going to take a very interesting topic. Non-oncological PET and PET and gamma. So I appreciate that scientific committee has thought about it, and we should know what other than oncology, non-oncological, where it's required. Dr. Avni Jain is consultant at Zydus Hospital. She's got a rich experience of 10 years. And I think her lectures will definitely benefit us in our clinical practice. So I'm here since morning, and the organizers are, all the topics they are putting up, which are relevant to us in our day-to-day practice. Thank you.
Welcome.
A very good morning to all of you. A tracer which actually traces the physiological mechanisms in the body. So, what are the main aspects of nuclear medicine, right? So, we have gamma imaging, we have PET, and then we have theranostics, right? So, initially, when nuclear medicine was in its nascent stage, gamma imaging formed the bread and butter. Conventionally, thyroid scans, renal scans, right? They used to be the bread and butter of nuclear medicine. Now, since last 2 decades, with the advent of PET, right? PET first brought a revolution in the field of oncology, and recently, if we see the applications of PET in non-oncology fields like cardiology, neurology, and of course, infection and inflammation, they are increasing. And then we have theranostics, wherein we have radiopharmaceuticals which are used to treat the diseases. So it's a very important and interesting field wherein we treat what we see. So what I mean by radio tracer is, for example, if I want to do a bone scan, I want to image my bones. So I have a tracer called as technetium MDP, right, wherein technetium is the radioactive material and MDP, methylene diphosphonate, goes and binds to the bones. So I am able to image the osteoblastic activity in the bones. Likewise, I have different tracers for different organs. So we are able to image all the organ systems with its various indications. So for example, if you want to assess for Parkinsonism, we have a Trodat scan. If you want, of course, thyroid scan, everybody will be aware. If you want to differentiate between Graves' disease versus thyroiditis, thyroid scan is the imaging of choice. Right? Likewise, for parathyroid adenoma, we have MEBI scan. Similarly, for esophageal transit, we have esophageal transit studies. Then myocardial perfusion imaging, very commonly known as stress thallium. So stress thallium has been used, it's an age-old imaging technique which is being used to stratify the patients, whether they need further revascularization or not. Likewise, VQ scan for pulmonary embolism. And then we have GI bleed scan, gastric emptying scan, HIDA scan, So basically with nuclear medicine, we assess the function, right? We assess the physiology and the function. Whereas with radiology, we majorly assess the morphology. That's the major difference. And then you have lymphoscintigraphy for assessing the lymphatic channels. So every organ in the body, you name it, and we have a scan to trace its function. So I'll show you the images of few of the commonly done scans and how it helps us in routine practice. So whenever you have a patient with hyperthyroidism, the immediate DD is either Graves or thyroiditis. So in order to differentiate between the two, right, the thyroid scan, a simple technetium pertechnetate thyroid scan will help. So in Graves' disease, you will have increased uptake in the gland, whereas in thyroiditis, there won't be any uptake. So we can differentiate it easily. Likewise, suppose if you have a hyperfunctioning nodule in the thyroid gland, so that nodule alone will appear hot on the scan, whereas there will be relative suppression of rest of the gland. So this is for hyperthyroidism. For hypothyroidism, like congenital hypothyroidism, if you want to look whether there's an ectopic thyroid or not. So if you have a look at the image, here in the neck, there is no thyroid gland. Normal thyroid gland isn't seen, but there is a lingual thyroid here. So it helps in detecting ectopic thyroid. Then coming to renal scans, DMSA, DTPA scans, we are very well aware, right? So DTPA scan mainly helps you in assessing the function, that is for GFR assessment. Or if you are suspecting a obstruction to drainage in babies, like there was antenatally diagnosed hydronephrosis and patient has congenital PUGO, you want to assess the obstruction or drainage pattern, then DTPA is the imaging scan of choice. DMSA, you want to assess the morphology, like patient has multiple episodes of culture positive UTI and we want to see whether there is any scarring or whether there is any inflammation. Likewise, suppose if we want to assess for ectopic kidney is not present in its normal location and we're searching for ectopic kidney, DMSA is the scan of choice, right? Similarly, multicystic dysplastic kidney and we want to see how much % is the functional volume of the kidney, then DMSA will help. Then coming to cardiac stress MPI, so cardiac myocardial perfusion imaging, right? In this, we basically use a tracer called as SESTA-MIB, right? Which goes and binds to the mitochondria of the myocytes. So what do we do in the nuclear stress test? There are two parts of it, stress and rest, right? We stress the patient either with the help of treadmill or a pharmacological stress either with adenosine or dobutamine based on the indications. Suppose if patient is able to physically walk, he is exercising, he doesn't have any LV outflow obstruction, we can do a treadmill test. Suppose if patient has knee pain, he cannot walk, right? Or there's an LV outflow obstruction, then we look for adenosine, but we need to rule out that patient shouldn't have asthma. So likewise, we decide on the mode of stress. So when a patient comes in the department, we prepare the patient with ECG lids. We make the patient walk on the treadmill. The target is to achieve 85% of target heart rate. Once the patient achieves that, I will inject my radioactive medicine. So the beauty of that tracer is it binds to the myocytes and it reflects that state at the time of exercise. And then we image after 1 hour. This completes the stress part, and likewise we do a rest part. So the funda is when we stress the heart, there should be, suppose if there's a stenosis, right, the flow distal to the stenosis may or may not increase. So in order to assess the hemodynamic significance of the stenosis, cardiac myocardial perfusion imaging is helpful. And the negative predictive value of the test is very high. So if you have a normal test, the chance of a positive cardiac event is as low as 0.4%. But if we have an abnormal test, the cardiac rate event is 6.7%. So what would be the indications for myocardial perfusion imaging? So unequivocal TMT with high risk probability. Likewise, stable symptomatic patients, or you have a borderline stenosis on CT angio, right? Like say for example, 70 to 90% stenosis in 2 vessels. Or you have 50 to 70% stenosis. So we want to assess whether it is hemodynamically significant or not, whether we need to intervene or not. In such cases, it will be helpful. Before any major surgeries to assess for inducible ischemia, myocardial perfusion imaging is helpful. Likewise, CT calcium scoring more than 400, you can consider doing a stress MPI.
2 minutes, ma'am.
2 minutes. Okay. So then I will quickly rush through the slides. So, as I mentioned, to look for parathyroid adenoma, we have SESTA-MIB scan, and then we have HIDA scan, wherein we want to assess the patency of the biliary tract, the major indication being neonatal jaundice, right? So we have to differentiate whether it is a biliary atresia or it is neonatal cholestasis. So in biliary atresia, right, the extrahepatic biliary tract is atretic, so the tracer will not come into the intestine, you won't visualize the intestines. So I'll quickly jump to PET. So the prime indication in non-oncology is pyrexia of unknown origin, wherein you want to assess the sites of occult infection. Right, you have initially worked up the patient, you are unable to localize the source of infection. PET-CT helps because one, it's a whole body imaging, whole body cross-sectional imaging. Right? Sometimes you have an occult abscess, or you might have an infected aneurysm, or you might just have one small patch of ground glass haziness in your lung. So PET helps in picking up the active diseases, and it helps in further managing, like for example, you can target the most avid area, you can take a biopsy from that, and further histopathological confirmation will help in clinching the diagnosis. So, like this is an example of vasculitis, wherein you can see that the entire aorta, then the common carotids, the subclavians, they are beautifully seen. So there is actually vessel wall inflammation. So vasculitis, infected aneurysms, occult abscesses, these are all well picked up with PET-CT. Deep-seated infections, which are not picked up on the routine imaging. Then imaging viable myocardium, right? So patient had a chronic total occlusion and sustained a MI. We want to check whether there's any viable myocardium or not. In order to decide on the further management, we must do a FDG PET. FDG PET is a gold standard for assessing viable myocardium. So if you are able to, what happens whenever there is a perfusion defect on my rest myocardial imaging and correspondingly I have FDG uptake in that, that means that there is an insult to the myocardium, but still it is viable, it can be salvaged. So revascularization can be done and we can save that part. So that's how FDG PET-CT forms the gold standard for viable myocardium. Coming to is imaging cardiac inflammation. So cardiac sarcoidosis, patient with idiopathic sustained VTEC, right, or new onset AV block, or you have histological diagnosis of extracardiac sarcoidosis and you want to find out whether there's cardiac involvement or not, PET-CT helps us in localizing the focus of active inflammation. Quickly rushing through the neuro, right, differentiating between various forms of dementia, right, Alzheimer's dementia versus frontotemporal dementia or diffuse Lewy body dementia. We have specific patterns of hypometabolism. So in this neurodegenerative disorder, what happens? There's a gradual neuronal death. And brain is an obligate glucose user. The tracer which I am using with PET is fluorodeoxyglucose. So when my neurons are dying, there will be no glucose uptake in that area. It will appear as cold or reduced uptake in those areas. So the purpose of doing it is to diagnose Alzheimer's early. So we can kind of halt the progression. It's not that we have a total cure for it. Then Parkinson's disease. So for every disease, we have a special tracer. Like for example, in Parkinson's disease, there is presynaptic degeneration of presynaptic dopaminergic neurons. So I have a tracer which reflects the dopamine metabolism. So if we do a dopa PET, I can see that in the striatum, there will be decreased uptake. Likewise, imaging neuroinflammation. Suppose you have a patient with rapidly progressive dementia, just 2 minutes, and you want to see whether there is any autoimmune encephalitis or not, right? So PET will help. For example, in limbic encephalitis, we have characteristic hypermetabolism, that is increased uptake in the mesial temporal lobes, in the striatum, basal ganglia. So likewise, we have specific patterns of FDG uptake which actually help us in suggesting the possible diagnosis, which has to be eventually confirmed. And as I told, for parathyroid adenomas, conventionally we use sestamib, but we have a far superior tracer called as fluorocholine PET, which has a sensitivity of say more than 95%, and it helps us in picking up even subcentimetric lesions. So I will skip the other slides. The only thing which is remaining is theranostics, right? So say for example, we have a metastatic inoperable neuroendocrine tumor, right? And I have a specific tracer called as DOTA-TATE or DOTA-NOC PET-CT, which helps me in targeting the somatostatin receptors. So in this, I can see that there are multiple areas of abnormal uptake. And now, because I have the evidence that it is taking up my tracer, I will treat with lutetium DOTA-TATE, where lutetium is a heavier radionuclide and it emits heavier radiation particle. So I inject that intravenously. It will go and settle in these places. It emits those radiations, beta radiation, which induces internal tumor kill. So likewise, with multiple cycles of lutetium, I am able to achieve partial response or stable disease in otherwise those patients who would have progressed with conventional lines of treatment. Likewise, for prostate, we have lutetium PSMA therapy. Prostate cancers, they overexpress prostate-specific membrane antigen. We target that. So that's it. I mean, because of the shortage of time, it wouldn't be possible to go into detail of each of them, but this was just a quick overview of what we have to offer with nuclear medicine.
Thanks, Dr. Avani. It's very interesting. I'm in Mumbai for practicing almost 50 years. In Vasai, where mushrooming hospitals are coming up, and all of us in Gujarat also. But we changed our gear in the practice. We prefer not a next door nursing home. We prefer institution hospitals, where all the facilities are under one roof.
Yeah.
And Dr. Avani Jain belongs to such hospitals,
Yes.
where all things are under one roof. We give enough time to the patients. Like she said about the thyroid. I'll prefer a thyroid nodule to be examined by her than the endocrinologist. I would like, before patient go for bypass, let her see her. And if you convince to the patient, it makes a lot of difference, because the patient understands that you are sending to him or her to a right place, and his life is of interest to you like your family members. Thank you. Thank you so much, Dr. Avani.
Thank you, sir. Yeah.
Thank you, madam, for an excellent presentation. Now I request chairperson to honor Dr. Avani Jain, ma'am. Dr. Avani, ma'am, please pick a chit for lucky draw. Ma'am, can you announce the number?
320.
320.
Ma'am, can you pick any other number?
He's available.
Okay, he is available.
320.
For the next session, I would like to invite Dr. Kirit Kanani from Rajkot, Dr. Neha Gohil from Bhavnagar, Dr. Nilesh Makwana from Vadodara, and Dr. Anuradha Parmesh from Bangalore to chair the session. For next talk, I invite Dr. Ruchir Gohil sir on stage to enlighten us on interesting cases when symptoms peak. And I request chairperson to introduce the esteemed speaker.
Good afternoon, everyone. It's our proud privilege to be chairpersons for this session. So on behalf of all four of us, I sincerely thank the organizing team for giving us an opportunity to chair this wonderful session on when symptoms peak, and the other very, very important topic of the day is lipidology. So to start with, our first speaker is Dr. Ruchir Gohil from is a renowned gastroenterologist. To say a few words about him, he's completed his undergraduation from Karamsad and MD General Medicine from SSG Hospital and DNB Gastroenterology from Manipal Hospital, Bengaluru. Incidentally, I'm from Bangalore.
Yes.
Okay. So, just a few more points. He has several publications and presentations to his credit, and he has done more than 10,000 UGI diagnostic and therapeutic procedures and 24-hour pH-metry studies. Over to Dr. Ruchir Gohil for a talk on interesting cases.
Yes,
that
good
he has
morning,
come
everyone.
forward.
Thank you for providing the opportunity. So today I will present about a few interesting cases which I come across. So, first of all, I will just like to highlight what are the common symptoms in the gastroenterology. So, mainly sometimes the most common symptoms like heartburn, constipation, nausea, on and off loose stools. But in this, sometimes patient can present with some of the red flag symptoms. Patients like can have difficulty in the swallowing, bleeding per rectum, weight loss, anorexia, jaundice. So we have to evaluate throughout in detail. So here is the case number 1. She is a very young girl, 23-year lady, presented with complaint of occasional stucking of the food and heartburn for say about 3 to 4 months. She was taking on and off PPI and the antacids, but one day suddenly she has complaint of blood in the vomiting, which was a very small amount. No other complaint. Vitals and the other histories were not significant. On the blood routines, hemoglobin slightly on lower side, rest of examination was normal. So, what it can be? So, the young lady, reflux disease, first we should keep, let patient might have severe reflux disease, can have the Sats's ring. Other thing, in the young girl, can have eosinophilic esophagitis, can present with the ring, furrows, and can have the blood in the vomiting. Sometimes reflux can present with the ulcers, mallory waste tear, or lastly, we can keep malignancy. It's a rare occasion. So, what I found out on upper GI scopy, you can see there is a diffuse infiltrative friable lesion in the lower esophagus, just above G junction. The similar kind of friable patch was also present in the mid esophagus. On narrowband imaging, on endoscopy, which found to be an invasive lesion likely to be malignant. So I've taken the multiple biopsies, and the biopsies showing it is moderately differentiated squamous cell carcinoma. So it is very unlikely that young patients without any, you can say, risk factor present with malignancy. But sometimes we ignore the common symptoms like heartburn, where we consider it is a reflux disease, but suddenly one red flag symptom like blood in the vomiting, and we diagnose as a malignancy. Later on, the patient lost the follow-up. The second case, similar, but it is an elderly patient, 65-year male, chronic alcoholic, has a complaint of progressively difficulty in swallowing of the food and also the pain while swallowing. No other significant history, but yeah, patient had similar complaint 2 years back, and endoscopy was done showing a reflux disease. Other thing that on examination when patient came has tachycardia, and he had both the lower limb poliomyelitis. So patient mobility was restricted, examination wise normal. On the day of examination, slightly higher counts, CRP was high, and SGOT was slightly higher side. This was on the day of discharge, which came to be normal. But on endoscopy, so what it can be? So patient has already GERD, now is complaining of progressively difficulty in swallowing. So maybe patient developed stricture. Other thing, the pain. Pain could not be explained with the stricture, so it might be some infections like Candida, CMV, HSV, or it can be the malignancy. But surprisingly, what I found, it was completely blackened mucosa. It's a necrosis. So the risk that whether to go ahead with the endoscopy or should I stop here. But this finding was not present in the proximal esophagus. It is seen in only mid and distal. I again asked, I stopped the endoscopy while doing because there is a risk of perforation. I asked the relative whether patient has consumed any caustic ingestion or patient has any poisoning, but he denied. So with the risk of small perforation, I went ahead, found out G junction below the cardia level was normal, stomach was normal. So the thing is, we have to diagnose that why so much necrosis has happened. I taken the multiple biopsies for fungus, CMV, and which all came negative. So it was just acute esophageal necrosis. So this entity is usually very rare, mostly occurring in chronic alcoholic patient, mostly who are like bedridden, immunocompromised state. So I given the treatment with broad spectrum antibiotic, IV PPI, sucralfate, antacids. Just after 2 weeks, when patient came on follow-up, the repeat endoscopy showing the pinkish mucosa, that all the necrosis has gone. But the thing is that patient may develop future in stricture, so we have to just keep the follow-up. The another interesting case, 33-year male patient came with diarrhea, say about 3 to 4 months, semi-solid, with nighttime frequency, occasional blood, with periumbilical pain, and weight loss, significant weight loss, about say 10 to 12 kg. No other significant past history, addiction history, vitals were stable. On the blood reports, even the hemoglobin was also surprisingly normal, except the CRP was high, rest of thing was okay. Stool showing plenty of pus cells with very high calprotectin, CT suggestive of terminal ileal, mild wall thickening. So I did the colonoscopy. So before that, on looking at this, most likely that patient might have some chronic small bowel or with large bowel inflammatory diarrhea, likely to be inflammatory bowel disease, or it can be the tuberculosis as patient has significant weight loss. On rare, it can be malignancy. So lower GI scopy on terminal ileum found out multiple aphthous ulcer even in the right-sided colon and the transverse and descending colon. So it looks like Crohn's related aphthous ulcers. So I did upper GI also to see whether the similar kind of ulcers were seen in the duodenum. So stomach and duodenum, the similar finding, and the biopsy find out to be Crohn's disease. So young patient nowadays, we are seeing rising trend with Crohn's disease. I have given the treatment with budesonide and the mesalamine, and patient has improved. Now the patient has normal frequency with regained the weight. Another interesting case, 64-year male, diabetic, alcoholic, recently detected cirrhosis of liver, came with black color stools, melena. Say about 1 or 2 days. When patient came, apart from the mild pedal edema, rest of examination was okay. On routine investigation, HB was fine, slightly lower platelet, SGOT is more, INR was borderline. So first, in the cirrhosis, everyone was thinking it may be varices. But sometimes varical bleed has very, you can say, very moderate or high amount of blood loss. So hemoglobin slightly to be lower side. Here the hemoglobin was not so much drop. So varices, yeah, we should always keep the first, but it can be less likely. Patient can have GAVE, ulcers, malignancy, or sometimes the colonic diverticuli or vascular ectasia or colopathy. So on an upper GI scopy, I found out only just reflux disease, no varices, fundus was normal, no GAVE. So I did the colonoscopy, and the colonoscopy they found out 2 large pedunculated polyp, out of which one was showing the recent sign of bleeding. So I cut it out both the polyp with and the polyp was showing tubulovillous adenoma with high grade dysplasia and low grade. So the thing is that nowadays, usually the polyps are asymptomatic. Polyps doesn't cause bleeding, but in very rare case, it can present with the bleeding. And all these polyps are the precursor of colonic cancers. So after the 50 years of age, the risk is high with colonic cancer. So this was the last case, 70-year male complained with progressively increasing painless jaundice with itching about 1 month, no any prodromal symptoms, no any addiction, no any past history. On examination, just icterus, rest of thing was normal. Lab value showing cholestatic pattern of jaundice, very high bilirubin, alkaline phosphatase, viral markers were negative. So at this point, we have to differentiate it between the whether it is intrahepatic cholestasis or extrahepatic. So first line investigation now, it is ultrasound abdomen to look for any biliary tract dilatation, which was showing a dilated CBD and intrahepatic biliary radical. So MRCP was done, which showing very likely to be periampullary lesion. So I done the side viewing, which showing a very large ulcerated and proliferative lesion over periampulla. So with clinical examination, looks like it's malignant. I've taken the multiple biopsy, and due to his very high bilirubin and maybe requiring neoadjuvant chemotherapy and the surgery, patient will require ERCP and CBD stenting. With difficulty, I done the stenting, and subsequently his bilirubin came normal. Now, patient is undergoing chemotherapy. But the biopsy suggestive of very poorly differentiated adenosine. So the take-home message that every single symptom and the sign in the we must have to evaluate it. Even the neoplastic disease can present with only single symptom. Even the younger patient can have malignancy, and whenever it is indicated, we have to do the endoscopy, ERCP, or imaging evaluation. Thank you.
Thank you very much, sir.
Thank you, sir. So you did speak about the, not the regular patients, uncommon conditions. Common conditions also, could you just touch on a few points?
So the common conditions, like whenever the patient with the, we can say the reflux disease, gastroesophageal reflux disease, usually the saying that the patient with the GERD should respond with routine PPI, we can say pantoprazole, on 4 weeks treatment. If patient will not improve on 4 weeks of PPI, we have to evaluate it. We have to find out that whether, apart from the gastroesophageal reflux disease, whether patient can have eosinophilic disease, or patient can have candidiasis, patient might have other thing, patient might have functional heartburn, patient. So the thing is that simple thing on just this, that 4 weeks not responding, have to evaluate it. The another common thing is nowadays we are seeing as that out of 3, the 1 person is getting is fatty liver. The fatty liver is nowadays the most common condition which I am facing in day-to-day practice. The thing is, we called fatty liver as a silent pandemic because it doesn't present with any symptoms or sign. We just find out on routine USG, ultrasound, or sometimes the blood report that mild SGPT and SGOT was high. So whenever I was doing my MD, we were taught that the fatty liver, it is a normal finding. We should ignore it. Diabetic patient can have fatty liver, hypertension can have fatty liver. But now the fatty liver is becoming the most common cause in the Western world as a cirrhosis of liver. That fatty liver with mild inflammation, SGPT, we can say last for 10 years, 15 years, and they go into the stage of F1 fibrosis, F2, F3, F4, and ultimately develop the cirrhosis. And this non-alcoholic steatohepatitis can present with the, even without cirrhosis, can present directly present with the malignancy, HCC, hepatocellular carcinoma. So this was the fatty liver. I can say the treatment part, few words. Fatty liver, main treatment is lifestyle, weight loss, about 7 to 10 kg weight loss can reduce your score, can reduce the inflammation also. Control the sugar, avoid junk food, processed food, fried food, avoid sugar, and all this lifestyle along with some medication like saroglitazar, vitamin E, we usually prescribe. So this was the another common thing. Anything from audience?
Any questions? No questions. Sorry. Okay. Sir, one word about elastogram when you have to do for fatty liver.
Fatty liver.
Time is going on.
We'll speak. I'll ask you later.
Oh.
Thank you.
Thank you, sir. Your
Dr.
findings
Ruchir
are not just interesting, they are transformative. Now I request chairpersons to honor Dr. Ruchir Goyal, sir. Moving towards the next topic, I invite Dr. Nirav Bhalani sir on stage to enlighten us on.
Welcome, sir. Dr. Nirav Bharani. He has done consultant interventional cardiologist, MBBS and MTM for Vadodara. He has done more than 5,000 coronary angiography and 3,800 coronary angioplasty. He is working with Banker Heart Institute, Vadodara. Over to sir.
The timing of my lecture is very interesting, just before the lunch. It is advantageous as well as disadvantageous. Disadvantageous because magajma gulab jambu ne khandvi ne dokra chali raya and I'm going to talk about lipid. At the same time, advantageous because હું ગમે તે બોલું કઈ ખબર નથી પડવાની ને. So I think it is a good place to be and at the same time a bad place to be. Can I have my lecture started? So I'll stick to my timer of 20 minutes. And so that તમારા બધાનો attention આવે. So the most beautiful lady on the world નો photo પહેલે ચાલુ કરીશ. We all know her. She is Mona Lisa and her real name was Lisa. The surname is this. Now why did I put it over here in a lecture of lipidology? Because she had xanthelasma and she had xanthoma. So the cholesterol levels in her and her family were high and she actually died because of atherosclerotic heart disease. Some other cholesterol findings in physical examination would be, as I said, xanthomas and xanthelasma. We all know why do we need to focus on lipidology, because the high cholesterol level is associated with coronary artery disease beyond doubt. The problem is the confusion. Lot of guidelines, lot of data, and there is no uniformity. There were many guidelines, but the most extensive and well documented guidelines were the 2018 ACCHA guidelines. And after that, I think there is a lot of uniformity. So I think we will discuss how to treat a case of dyslipidemia according to the guidelines. So first of all, the screening. When do you do your first lipid profile? So there is this ATP3 guideline which said that it should be done at the age of 20. But this is too aggressive. So normally we follow what is the United States Preventive Service Task Force recommendation that all male more than 35 and all female more than 45 should have their lipid profile screened. Fasting lipid profile for aged 35 plus and 45 plus is a must. Now, in some patients, you can screen before, that is men between 20 to 35 and women between 20 to 45 if they have diabetes, hypertension, heavy smoking history and a family history of cardiovascular disease. You can do it prior also. So this is whom to screen. Now once you have your lipid profile results, what should you follow? You should follow the 2018 ACC-AHA guidelines. So when you see the guideline, it is very confusing. You'll see a lot of this kind of charts which actually confuses us all. But ultimately, I would give you the gist of the guideline. This guideline says that there are only 4 classes of patients. Majority of our patients, 80 to 85% of our patients would fall into these 4 classes for whom cholesterol treatment with statin is recommended. The first and the most important class is individuals with established ASCVD. Now what is ASCVD? Is atherosclerotic cardiovascular disease. So any patient who has established ASCVD, for example, history of heart attack in the past, becomes established ASCVD and he needs to be on statin. The second group is individuals aged between 40 and 75 with an LDL cholesterol of more than 190. LDL cholesterol level more than 190, 40 and 75 years. The third group is diabetic people, the aged between 40 and 75. Mind you, right now the guidelines are not clear if the patient is less than 40 years or more than 75 years, but between 40 and 75 years, and if the patient is diabetic, you need statins. And the fourth one is individuals with a predicted 10-year ASCVD event risk of more than 7.5%. Now, how do you calculate this? There's a calculation. So we will keep into mind this 4 categories of patients. Now let us start with the first case. So this gentleman is a 58-year-old gentleman, known case of hypertension, non-diabetic, non-smoker, had a minor stroke 3 years back, and his total cholesterol is 182, LDL is 92, and HDL is 38. How do you manage his lipids? So first question, as we saw the categories, the first question that I would ask is, does my patient have ASCVD? Yes, because he had stroke. So my patient is ASCVD and therefore I need to treat him with statins, no questions asked. So the answer is yes, we start statin. Now what is the target? So coming back to what is ASCVD, history of MI, ACS, stable, unstable angina, stroke, other arterial revascularization and peripheral arterial disease. So these patients, because he has a history of ASCVD, he should be treated with statin. Now they are further classified into very high risk ASCVD and stable ASCVD, because that would give us the target of LDL. Whether we should get the LDL to 70 and below or we are happy with 100 and below. So how are they classified? The very high risk ASCVDs are MI within 1 year. So MI, stroke or symptomatic peripheral arterial disease within 1 year is major. And the other high risk features are past history of bypass, angioplasty, diabetic, hypertension, CKD, heavy smoking history, and LDL more than 100 on therapy. So if you have very high risk, that is 2 or more major or 1 major plus 2 or more high risk condition. Otherwise they are stable ASCVD. So when the patient is very high risk, your target of LDL should be less than 70 and in some even less than 50. But if your patient is stable ASCVD, I would be happy with a LDL level of less than 100. As I said, the guidelines are for patients between 40 to 75. So whenever it is less than 75, you should start high intensity statin. Now what is high intensity statin? High intensity statin means lipid profile reduction, LDL reduction by more than 50%. That is achieved by a dose of 40 milligram atorvastatin or 20 milligram rosuvastatin. And if the patients are more than 75, you should go with moderate intensity. So as I said, high intensity, your target should be lowered by more than 50% from baseline. And that is by 40 or 80 of atorva and 20 or 40 of rosuva. Moderate intensity statin would be 10 or 20 of atorva. This category of very low intensity statin is practically not used. It is only used for patients who cannot tolerate high intensity or moderate intensity. So guidelines are very clear that these are not to be used unless the patient is not tolerating the moderate or high intensity statins. So now coming to case 2. 54-year-old male with diabetes and hypertension. He had CAD more than 3 years. So again, more than 3 years back. Atorvastatin 40 milligram is what he is on and other medications. And his LDL is 120. Are we happy? We are not happy. So what is your advice regarding the lipid treatment? High LDL despite statin. So our target should be to get it down further. So we have to add ezetimibe. Nowadays a new molecule bempedoic acid is also available. So we can add. And if not controlled, we should then add PCSK9 inhibitors. That is inclisiran. Now case 3, 52-year-old male, routine health checkup, no diabetes, no hypertension, non-smoker, and for the first time his LDL is 240. How do you manage this lipids? So again we go to ask our questions. Does my patient have ASCVD? No, he does not have, because no past history, no diabetes, no hypertension. So now let us go to question 2. What is the LDL level? LDL level is 240. Anything more than 190, hands down, no questions asked, start treating the patient. So in this patient, it has severe primary hypercholesterolemia, LDL more than 190. So no need for any other questions, and immediately start high intensity statin. Again, lifestyle changes, everything to be emphasized. Case 4. 60-year-old male with diabetes and hypertension. So we have risk factor, diabetes. Non-smoking, pressures are normal, lipid levels are 92. How do you manage? So again, we ask the 3 questions. Does the patient have ASCVD? No. Is the LDL more than 190? No. But the patient is diabetic. Does the patient have diabetic and age more than 40? Yes. So he should be on therapy. Now there is a bit of confusion here because there are 2 guidelines. So there is no doubt that we should start statin. How? So there are 2 guidelines. One is the ACC-AHA, American College of Cardiology, and another is ADA, Diabetic Association. They differ slightly. In the age criteria. ACC says 40 to 75 and ADA says anyone more than 40. Any diabetic more than 40 should be prescribed statins. And they also differ on how to decide on the type of statins. For example, ACC, I will put the chart. So what does the ADA say? Anyone more than 40 and diabetic, if the risk is high, that is 10-year ASCVD more than 20% and multiple risk factor, go for high intensity statin. Otherwise, only moderate intensity statin. Now, what does the ACC-AHA say? 40 to 45, multiple risk factor, high intensity, otherwise moderate intensity statin. So this is a slight difference, nothing significant, but we can say that any diabetic more than 40 years of age should be on moderate intensity statin, right? Now coming to the question that if the patient is diabetic but less than 40, or if the patient is diabetic and more than 75, what is to be done? So here the guidelines are different. The ACC-AHA says that you should assess other risk factors. For example, is the LDL more than 160? Is there family history of premature ASCVD? Is there elevated CRP levels? What is the ABPI index? And what is the calcium score on the CT scan? So if any of this is positive, then less than 40 diabetic should be, otherwise he may not be on statin. Very clear. Case 5, 58-year-old non-diabetic, non-hypertensive, non-smoker, and the LDL level is 123. How would you approach? So again we ask the 4 questions. Is there ASCVD? No. Is the LDL more than 190? No. Is he diabetic and age more than 40? No. So the age is between 40 and 45. What is the 10-year ASCVD risk? It can be easily calculated from the Google. If anyone wants to try, they can do it on their phone. So when you say ASCVD calculator, they will ask to put in certain demographic data like what is the age, what is the smoking, or what is diabetic status, and then they would give you a 10-year risk. So for example, this gentleman has a 10-year risk of 10.8%. So it is not more than 20. And therefore, whenever it is more than 20%, you should start high intensity statin. But this gentleman does not fall into that risk category. And therefore, you have to then evaluate whether he has any other risk enhancers. And these risk enhancers are LDL more than 160, which he was not because he was 132, CKD, family history of premature ASCVD, and persistently increased triglyceride. So we will not go into the details of this. If this gentleman does not have any risk enhancers and the patient is very apprehensive, कि सर मुझे लेना चाहिए कि नहीं लेना चाहिए, you can ask for him to get a CT coronary calcium score. If the calcium score is more than 100, statin is recommended in this patient. If the calcium score is less than 100, no statin is required, right? So in this case, the 10-year risk is 10.8%, so you need to assess for risk enhancer, and if there is no risk enhancer, you can just advise lifestyle changes and you may not give him statin therapy. So I think I'll go with the last case because there is 7 minutes left. 34-year-old healthy lady, no family history of ASCVD. The total cholesterol is high, 212, and the LDL is also high, 140, but not definitely more than 190 or 160. She is concerned about her LDL levels. There are apprehensive patients which we see in our OPD daily who says कि cholesterol 200 ऊपर થઈ ગયું સાહેબ કંઈક કરો. And then what is your advice? So again we go back to our 4 questions. Does she have ASCVD? No. Is her LDL more than 190? No. Is she diabetic with an age more than 40? No. Is her age between 40 to 75? Yes. So, no. So she does not fall into any of the high risk patients. And in these kind of patients, in the age group of 20 to 39, the risk calculation is not studied. So we just advise lifestyle changes and consider statin only if LDL is more than 160. Only in her case it was 140, so it is not more than 160. And if there is family history of premature ASCVD, yani her brother, her father, her mother had a young coronary event, again, still this is not a very strong indicator. If she is very apprehensive, we should ask a coronary calcium CT score, and if the CT score is less than 100, we can reassure her that she may not take statins. I think so with this, I have broadly discussed how do we approach. I would not take the SGPT high and muscle this thing. I will just go to my recommendations. So I'll go to my summary. So the summary is, so statins for all patients of ASCVD, you classify them into very high risk or stable ASCVD and target your LDL levels to 100 or 70. Statins for all patients with an LDL more than 190, and these both group would receive high intensity statin therapy, that is 40 or 80 of Atorva and 20 or 40 of Rozua. The other group is diabetic patient with age more than 40, generally use moderate intensity statin, but if there are additional risk factors or the ASCVD risk as we calculated from Google is more than 20, you go with high intensity therapy. For non-diabetic patients between the age of 40 and 75, do the risk calculation. If it is more than 20%, high intensity. If it is between 7.5 to 20%, look for risk enhancer. If there are any risk enhancer, give them moderate intensity. If there are no risk enhancers, do not give them any statin. And the last, for age less than 40, there are no clear-cut guidelines. So statin only if LDL is more than 160 or there is family history of premature ASCVD or the calcium score is more than 100. So with this, I think I conclude. I open the session for questions.
Sir, interesting question. If you permit, I ask the question in Gujarati.
100%, sir.
Okay, thank you, sir. સર આ છેલ્લા 10 વર્ષથી આ ડિસ્લિપિડિમિયા વિશે, કોલેસ્ટ્રોલ વિશે ઘણું જાણીએ છીએ, વાંચીએ છીએ, ભણીએ છીએ, લેક્ચર ભરીએ છીએ, કોન્ફરન્સમાં આવીએ છીએ. એટલે ઘણું જાણવા તો મળ્યું છે ને ખાસ અત્યારે આના લેક્ચર હોય જ છે ને એ અત્યારે પાછું આપણે જાણ્યું. પણ હવે સાહેબ બહાર જઈને જમવું કે ન જમવું કે સાથે શું લઈ આવું કે એવા ડરાવી દો છો. અને કોન્ફરન્સમાં સવારે જલેબી ગાંઠિયાથી ચાલુ થયું હતું, અત્યારે બપોરે પણ સરસ સરસ હશે, રાત્રે ગાલામાં સરસ હશે, તો કરવું શું સર?
There is one thing, જ્યારે પેલું નવું આ સ્ટેટિન્સ ને બધું ફૂલ ફ્લેજ ચાલ્યું હતું ત્યારે બે કહાવત હતી, સ્ટેટિન, સ્ટેન્ટિન. If there is no statin, there is a stentin. અને યસ જેન્યુઅનલી મારા કોલેસ્ટ્રોલ લેવલ્સ જો 100 થી નીચે હોય તો હું અત્યારે બે તો હું ખાઈશ, બે તમે મને ખવડાવજો જલેબી. બટ ઇફ માય કોલેસ્ટ્રોલ LDL levels are more than 100, I would say કે મારા પ્લેટની હું તમને આપી દઈશ. Thank you.
Thank you, sir.
So basically, pre-diabetic again would be classified as an early diabetic. Same rules apply if the patient is pre-diabetic, that is HbA1c around 6.5, but definitely more than 5.5, and age between 40 to 75, you should treat with a moderate intensity statin. Age less than 40 or more than 75, you should look for other risk factors. If there are other risk factors, yes, you should start. If no, avoid. So basically, this scope is different in a different lecture, but because the question has come up, I'll tell you. What is the importance of apoprotein, ApoA, ApoB, as you said, VLDL, lipoprotein small a. So these are very specific subgroups. When you talk about generality for routine patients, this is more than enough. Now, lipoprotein small a is important for young coronary and cerebrovascular diseases. So any patient who has a young MI, young stroke, they should have their lipoprotein small a levels assessed. And if it is high, we should target them with high intensity statin. And now inclisiran, which is Cybrava, if you know, it is an injectable anti-cholesterol medicine which is to be given twice a year. The cost is 1 lakh per injection. So that has to be given in such kind of patients. But that is a very select subgroup. So we have right now, as I was coming here, I did an angioplasty for an acute anterior MI. The gentleman's age was 32 years. So these kind of aggressive atherosclerotic disease needs more atherosclerotic lipid profile lowering and also lipoprotein small a lowering. I would target the LDL less than 50 if the patient tolerates less than 30 in him. So these are very specific subgroup. Thank you.
Sir.
Thank you, sir.
Now I request chairpersons to honor Dr. Nirav Balani, sir. Thank you, Chairperson. You are requested to receive your token of honor from Point of Honor Corner for Family Physicians during lunchtime. For the next session, I would like to invite Dr. Manish Shah from Vadodara, Dr. Dinesh Gohil from Bhavnagar, Dr. Janak Shah from Mumbai, and Dr. JD from Rajkot to chair the session. For next talk, I invite Dr. Dhrumil Patel on stage to enlighten us on shoulder pain beyond analgesics, and I request chairperson to introduce the esteemed speaker.
Hello. Dr. Dhrumil Patel is a consultant orthopedic surgeon practicing as a joint replacement and sport medicine surgeon at Navrang Hospital, Vadodara. Dr. Dhrumil is a national faculty for sport medicine in knee and shoulder. Dr. Dhrumil has pursued advanced training in arthroscopy, sports medicine and adult reconstruction through national and global fellowship at USA, Germany, South Korea, UK, Italy, and Pune, India. I welcome Dr. Dhrumil.
Thank you. Thank you, sir. Thank you, the organizing committee of Family Physician Association. This is a national meeting, so thank you for the invite. I'm going to talk about shoulder pain, which is very relevant because I see a lot of middle-aged people here and some who are even more aged. So shoulder pain is very common. When a patient comes to you, you definitely treat them with pain medicines and physiotherapy. But the only message that I want to have with this talk is that don't overtreat with analgesia, don't overtreat with pain medicines. There is always scope beyond analgesia, and that is some surgical intervention when it is needed. Shoulder is a very, very complex joint. It has maximum range of motion. When you see shoulder, it has more range of motion than any other joint in your body. So it is intrinsically unstable, it is very, very lax, but when you age with time, it becomes stiff. So to manage a shoulder, it is very, very difficult, very, very tricky. To understand shoulder, you need to know the anatomy. There are three main bones. One is clavicle, that is the collarbone, the beauty bone. The other one is the scapula, which is the bone which is behind, that is the acromion process of the scapula. And there is the main shoulder joint, which is the humerus, the head of the humerus, which forms the shoulder. So any pathology in any one of these joints can lead to shoulder pain. The important thing that you need to know in shoulder is the capsule, which is there in between the head of the humerus and the glenoid. That capsule becomes stiff as you age, which leads to frozen shoulder. And there are muscles in the shoulder which are responsible for stabilizing the shoulder at 90 degrees, at 150 degrees, at 180 degrees. These are called the rotator cuff muscles. These are the important muscles that you need to know about shoulder. When you talk about shoulder, mostly I examine patients, and history taking is the most critical part. Patient tells you with the palm that I have pain in the shoulder, and that is palm sign. That is a classic sign that the patient tells you. And when you examine the shoulder, always stabilize the shoulder near the trapezius and then see the passive range of motion at the shoulder. Without stabilizing the scapula, without stabilizing the trapezius, if you check for the range of motion, it is a pseudo range of motion. So true range of motion at the shoulder is very, very important. The other thing is testing of the strength of the shoulder muscles. So elevation, forward flexion. Some of the important tests for impingement of the rotator cuff muscles are very, very important. It's just a 2-minute examination which will tell you what the patient has. Palpation of the joint from front and back, and then the acromion joint, and trying to feel for the crepitations, cut that you have in the knee. That is again crucial when you are examining the shoulder. Most of the time, it is just a small steroid injection in the subacromial region, which is diagnostic that the patient has pain arising from the shoulder. If you give an injection, the patient is 50% happy within 2 or 3 minutes of the injection, it means the pain was from the shoulder and not from the neck. So that is a very, very simple diagnostic test that you can do in your clinic itself. It is just 10 ml or 5 ml of lignocaine. Sometimes you combine that injection with a Canacort, a triamcinolone, water-soluble triamcinolone steroid. So that is very, very important. This patient immediately started having full range of motion after an injection. So that means that this patient had shoulder pain and not neck pain. A lot of young patients, when they come to us, they don't have arthritis, they don't have stiffness, they have instability. So when you're treating with younger patients, you need to see whether the patient has some kind of clicking, some kind of noise coming from the shoulder, or if he feels unstable. So completely different approach when you see a younger patient. You need to see the strength because a lot of them are gym athletes. They believe that losing weight, the best way to lose weight is to go to the gym and not do diet. So that is the reason when you go to the gym and try to lose weight, you end up with pain and injury in the muscles in the shoulder. So that is a different patient. This patient had instability and crepitations. When you have a patient with neck pain, most of the time, patient has radicular pain right of the same upper limb. So that is a patient with cervical spondylosis and not shoulder. So very, very important to see clinically whether the patient has pain from the neck or from the shoulder. It is very disguising when you see a patient with pain in the upper limb to differentiate it straight away. If the patient has good range of motion in the shoulder and the patient has radiating radicular pain in the right or the left upper limb, it is mostly arising from the neck, from the spine, and not from the shoulder. And when you see their x-rays, you see that there is a lot of arthritis. So it is a patient with neck pain with cervical spondylosis. So very, very important to differentiate shoulder pain from neck pain. Shoulder, again, I tell you, it is scapula, it is clavicle, and the shoulder joint. The patient usually tells palm signs, this is what is paining. This is what is paining. It is not relieving with medicines. Night pain, when the patient sleeps on the same side in the night, that is when the pain aggravates. Because the head of the humerus, when you eliminate gravity, it is because of the gravity when you're standing, the head is down. When you eliminate gravity in the supine position, the head hits on the acromion above, and that is what aggravates your pain. Clothing, unclothing, unhooking your bra for the females, that is most difficult. Going up to the back pocket, trying to remove your wallet is most difficult. And bathing, cleaning your body is again difficult. So that is shoulder pain. A classic young lady with frozen shoulder, the most important thing here is there is loss of elevation, there is loss of abduction, and there is loss of rotation. When you have loss of rotation, that is when this patient has frozen shoulder, remember. So very, very easy to diagnose. This patient will not be able to rotate. Getting the arm on the side will be difficult, and that is frozen shoulder. You just treat her with a local steroid, intra-articular and a subacromial injection, and she will be good within 3 to 6 weeks of physiotherapy. If this doesn't help, then some patients do require surgery. Well, the surgery is not a major surgery. It is a manipulation, simple manipulation under anesthesia. Remember, manipulation will always improve your elevation, but it will never improve your rotations, because the loss of rotation is because of the tight capsule, which is anterior and posterior. For that, you require arthroscopy. You read multiple portals, go in at various places where there is tight capsule, and then try to release it. We see this young patient who has biceps tendinitis, red biceps, lipstick biceps is what I call. There is lipstick on the biceps, and there is all the red inflamed capsule. That is what is frozen shoulder. So that is why she has lost her rotations. And just go in with a small probe, a 4 millimeter probe, a small incision less than 1 centimeter, and release the entire capsule. And this patient, within almost 2 days of surgery, will get 80% relief in her range of motion. So that is what is frozen shoulder. When you talk of another shoulder entity, there is subacromial impingement, where the patient has pain when doing this, but the rotations are okay. So elevation is good. And this is a patient, again, who has good range of motion, but when she abducts her shoulder, that is when she has pain. So she will not be able to abduct. That is subacromial impingement, where the patient has swelling in the bursa, which is beneath the acromion, and there is a spur on the acromion. This bone, which is there, acromion, is either flat or either inclined in some patients, and when it is inclined, it hits on the head of the humerus and it causes pain. So that again requires a local injection. What about patients with arthritis? Patient will classically come and tell you, sir, this is what is paining, with a finger, not the palm. When it is a palm, it is shoulder pain. When it is a finger, it is the acromioclavicular joint pain, because that is finger test positive for this patient. And that requires just an injection, or sometimes you go in and then remove the biceps. Remember, biceps, when we see in the movies, it is not the arm, it is the shoulder, because biceps arises from the shoulder. This patient had pathology in the biceps. That's the lipstick biceps that I tell you. It is that is the cause of pain in this patient. And then you remove that biceps, you fix it with an anchor. The biceps has been released from the top. It has been fixed on the head of the humerus with an anchor like this. These are absorbable anchors. And then you decompress the acromioclavicular joint, create the space between the acromion and the clavicle which is there, and you remove the bone which is there, and these patients, they really do well. So that's the space, and that is the acromioclavicular joint decompression. And these patients immediately start getting better with rehab post-surgery. So that is crucial. What about rotator cuff? This is the most important part. When the patient has pain and weakness in the shoulder, X-ray is not diagnostic for most patients. So you do an MRI and you see a big tear in the shoulder, and the patient is not able to lift up the shoulder, which is affected. Again, you go in with your scope, and the best way to treat a rotator cuff is to actually clean it up, then grab hold of it and try to see. This is the tear which is there in the muscle. Ideally, it should be on the bone. It should be on the bone, on the surface of the bone, attached to the head of the humerus. If it is not attached, it is better to repair it and fix it with multiple anchors. And most of these patients, once you repair, they start recruiting their shoulder. They start lifting their arm. Anything above 90 is a good range of motion for the shoulder. So these are the patients, when you repair them early, when they come early, they present early, they really do well with rehab. This is a patient from London who just came for the surgery because he did not get an appointment there for the rotator cuff. The appointment was given 6 months later, and he just came and got it done. Within 6 weeks, he flew back. So that is how it is. What about acute shoulder pain? You have a lot of patients who come with acute, immediate shoulder pain. Sir, I was normal 3 days back. All of a sudden, I woke up in the morning and I started having pain. And that is tendinitis, means there is calcific deposits in the rotator cuff. Normally, shoulder pain is chronic. Patients tell us, sir, it's been 3 months, it's been 6 months, not relieved. I've taken medicines, I've gone to the physio, nothing is helping. But when a young, relatively young or a middle-aged female comes to me, usually it is calcific tendinitis. And how does it occur? because of vitamin B12, D3 deficiency. Most of us are vegetarians. Most of us work in offices which are air conditioned. We don't have good exposure to sunlight. That is when we have vitamin D deficiency. And this, what happens is vitamin D is a carrier for the calcium that you take in your food. Vitamin D is needed for the calcium to go into your bones. When you have vitamin D deficiency, what happens is all calcium tablets you take, all the oral calcium that you take goes into the muscles and the tendons, and that is what causes pain. So that is a patient who is even not able to lift the shoulder. This is acute shoulder pain, and she's not able to lift up. It's a completely pseudo-paralytic limb. You might feel that this is like a stroke. No, it is not stroke, but it simulates like a pseudo-paralysis. And when you give an injection in the shoulder, she immediately feels good. She's like, sir, you gave me a steroid injection, it helped. Or give an oral steroid if you don't want to give an injection. Just give Vizolone 5 milligram or 10 milligram depending on the weight, and she will immediately start feeling better. So analgesics, normal analgesics will not be helping this patient. Remember, if you give diclofenac, she will come back within 5 days. You need a steroid. You need something to dissolve the calcium, the inflammation. That requires either a local steroid. Sometimes there are resistant cases where this patient, a 33-year-old young lady, whom I gave a steroid thrice, who did not get better, and then you go in, remove the calcium from the rotator cuff. That's the inflamed rotator cuff, the red inflamed tendon which is causing a pain. She was planning her pregnancy, but because of pain, she came for the surgery and then planned for the IVF. So she was on treatment for IVF, but she was in unbearable pain, not able to sleep in the night. So the standard of care today for calcific tendinitis is give an oral steroid. Don't be worried about steroid. Most of the people here who had a coronavirus infection, they are alive only because we gave them steroid timely. Steroid does have side effects, but it also has good effects. So when you give it at the right time to the right patient, it is very, very helpful. Just remove everything, all the calcium that was there, that was removed, and then the suture was taken in the rotator cuff and the cuff was repaired back to the bone. So that is something which is removal of the calcium from the shoulder. When you have younger patients, I told you that the stiffness is not the problem. When they are overhead athletes, badminton players, a lot of us, they go for gym training, do a lot of overhead weightlifting, and that really causes injuries in the labrum. Labrum is the capsule which is around the shoulder, and when you have a biceps which is torn at the insertion, it's called a slap tear, which is superior labrum, anterior, posterior. Classic test is overhead pain or pain on forward flexion. Most of these patients are overhead athletes. We go in and then we repair with various anchors. So remember, this is a very, very small hole surgery, a keyhole surgery, wherein you go in and repair the labrum back to the bone with multiple sutures. And now you see, nowadays we use tapes. Instead of sutures, we have tapes which are 1.3 millimeters thick, and they really have good hold on the issue. That's a biceps repair with the labrum back onto the bone. So that is what is labrum injury. When you have instability, this is something that you really see commonly, that patient comes with a traumatic fall and the shoulder dislocates. So when the shoulder dislocates, it always causes some damage to the capsule, remember, and that damage to the capsule is called a Bankart tear or a lesion in the head of the humerus, usually diagnosed on MRI. So that's the patient, young patient with a defect in the head of the humerus and a labrum injury in the front. The best way to treat this is go in with a scope and treat the defect. So that's the defect in the head, and that's the entire labrum which is torn, and that is why that's the soft tissue injury that is causing instability. So go in, remove all the dirty stuff that is there in the joint, put an anchor, again an absorbable anchor, these are 4.5 millimeter anchors, put tapes, and then tie those tapes back onto the bone. So the defect has been addressed so that he will not dislocate, and then that's the labrum, the capsule in the front which is away from the bone, that's torn. We put in multiple anchors. Again, these are 1.7 millimeter anchors, very thin. You can't even identify on an X-ray. Screw nahi. You don't screw in. You put in anchors. These are tapes. These are collagen-coated tapes. Collagen is something that God has given us. They are coated tapes, and eventually these will transform into the tissue that the patient has. So that's the final repair, and the shoulder is centered back on the glenoid. So that is how you treat instability. And most of them, as I told you, they go to the gym. They are back to their routine activities. They don't feel unstable. They don't feel that they're afraid the shoulder will slip out. So that is something. Again, in the best of the movements, this is one of the movements where the shoulder can dislocate. When you do this, or you throw a stone on someone, patthar maro to open shoulder can dislocate. So that is where it is. Overhead activities, overhead smashing, in badminton and tennis can cause instability in the shoulder. But this is a patient who has recovered completely with just a soft tissue procedure. I have, I think, 6 minutes left where I'm going to just show you some cases of fractures because that is also important. You do see domestic falls nowadays. Every injury is not a road traffic injury, and domestic fall cases will come to you first. They will come to us later on. So when you have an injury in the shoulder, the best way is to take an X-ray. That's a proximal humerus fracture. Most of the time, the fractures are treated with a plate, but the dynamic movement of the shoulder requires the muscle to be repaired to the plate. So that's the plate with the rotator cuff muscle repaired onto it. This is a relatively middle-aged female diabetic who was treated with a fracture plate with a muscle repair who recovered at 3 months. So fracture doesn't involve only fixation of the bones, it requires a soft tissue repair as well onto it. When you have a bad fracture of the head of the humerus, where I tell head of the humerus is like an eggshell. Usually in older patients, the inside of the bone is very soft, it is osteoporotic. And when you fix it, it is most of the times it is going to fail. So then you end up with either a hemi-shoulder replacement or a reverse shoulder replacement. So most of the older patients, they do better with replacements rather than fixing the fractures because of osteoporosis, because of post-menopausal osteoporosis in females, which is mostly undetected. Most of the patients, they are taking calcium supplements, but without measuring their calcium and vitamin D levels. So that is one of the reasons why they have osteoporosis. I think the best way to take calcium is natural source, that is your diet. Again, when you have a bad fracture, how would you treat it? Not with a shoulder replacement, with the reverse shoulder. So what you do here, the recent advances in arthroplasty are that you put the head on the glenoid. So that's the ball which is on the glenoid and the cup on the humerus. So we have reversed the entire mechanism that the shoulder works with. And that is so easy for the patient to do rehab. That's called a reverse shoulder replacement, where you only use your superficial muscles, the deltoid and the trapezius, to lift up the shoulder and not the rotator cuff. And that really helps with easier rehab in older patients. So remember the treatment, the standard of care for a bad fracture today in an older patient is reverse shoulder and not a total shoulder or a plate. So this is a patient, again, with domestic fall. The X-ray looks normal, but the patient had severe pain. And when we took a CT scan, that's when we realized the shoulder is normal, but the scapula, we forget the scapula, the bone which is behind, that was fractured. So that again requires fixation. So this patient was treated with multiple plates in the scapula and the muscles were repaired over it. It's a domestic fall, but still he recovered well because it was diagnosed in time. Otherwise, most of the time they end up with a frozen shoulder. You have an acromioclavicular joint, I told you. Sometimes when you fall on that shoulder, it can dislocate. Well, AC joint requires reconstruction of various ligaments which are around the acromioclavicular joint. These are small ligaments. But what we do these days is we harvest the hamstrings. Patients have good hamstrings, most of them. And then we reroute that hamstring between the clavicle and the coracoid process of the scapula and fix the AC joint back to where it is. So completely biological fixation with muscle. There is no implant. The patient will have excellent range of motion at 3 months. When you talk about clavicle, that's a mid-shaft clavicle. Remember, most of us, we know clavicle can be treated conservatively, but the standard of care today is that we need to fix it with a plate. The length of the pectoral girdle on one side should match the other side. Otherwise, you'll always have a dyskinetic shoulder, a cosmetically deformed shoulder. You don't want that for the patient, so that's the standard of care. What about scapula? This patient came to me with just shoulder pain, not able to lift up the shoulder and do overhead activities. Well, the problem is not just shoulder, it is the scapula. And it is the dyskinetic scapula which is preventing the range of motion. The moment you stabilize the scapula, this patient will be immediately able to improve his range of motion. So that's the dyskinetic scapula, that's the winging scapula that this patient has, because of which the shoulder range of motion is compromised. So remember, always and always, always undress your patient if it's a male. In India, it is easier to miss the scapula. It's always on the back side of the shoulder. With that, I would want to just give you some take-home messages for shoulder. Every shoulder pain, remember, is not frozen shoulder. I showed you various entities that the shoulder has. It has subacromial impingement, it's a labrum injury, there is acromioclavicular arthritis, everything. So don't treat every shoulder pain with frozen shoulder. Don't treat them with pain medicines. Give them pain medicine for 2 weeks, it's okay. Give them rehab for 4 weeks. Otherwise, any shoulder pain beyond your analgesia requires a reference to a specialist. Examination is the key. I think you just spend 2 minutes with the patient and realize that this patient doesn't have neck pain, it is a shoulder pain. Modern techniques that we have to treat shoulder pain are arthroscopy, minimally invasive, small incisions, less post-op pain, easier recovery, easier rehab. Modern implants, we have plates, we have nails and replacement, which I told you, which was reverse shoulder processes, the game changer in the shoulder. If there is any surgery in the shoulder that has modernized shoulder rehab, then I think it is the reverse shoulder. Like you have a hip replacement. A patient after a hip replacement will never complain of hip pain for 20 years of his life. A patient with reverse shoulder will never complain of shoulder pain for 15 years of his life. Take that from me. And rehab, remember, rehab is not home rehab. It is supervised rehab with a specialized shoulder therapist, because you always and always need to stabilize the scapula when you are rehabbing your shoulder. Thank you.
Thank you. Sir, a rapid fire round. Role of IFT.
I don't treat patients with IFT. I just tell them ghare hot water fermentation at home. And really core strengthening of the back and the abdomen muscles.
And role of ultrasound.
I don't treat them with any of the modalities.
Sir, can it be treated with the PRP?
I don't treat them with PRP. Remember that PRP is a sham. 50% of the time, patients don't get better. They get better with the medicines that you give. And most of the surgeons, they combine PRP with a steroid. So, if you have treated a patient with a repair and you want enhanced healing for that repair, that is when you put the PRP. PRP is a growth factor. It is not going to modify your disease.
In case of the degenerative changes, if you give the PRP, does it help?
I have given PRPs and I have failed miserably. That is why I tell you that PRP is not going to modify your pathology, your repair. If you want that your repair heals faster, that is when you give PRP post-op at 6 weeks.
And what about the hyaluronic acid?
Hyaluronic acid is good for knee. I would say it is really good for knee because it is 10 ml, but when you want to give in shoulder, for shoulder arthritis, give it 2 ml or 3 ml. Don't give it the 10 ml that is commercially available for knee, otherwise the patient will start having shoulder pain. Why do you give hyaluronic acid? That is for a stiff shoulder. The shoulder joint has a very minimal volume as such. When you give a thick 10 ml injection in a shoulder, it is going to aggravate your pain. So give a 2 ml hyaluronic acid if you want to.
Can it be given with along with the steroids, or it can be given in a single shot?
Usually give it alone if you want to really see the efficacy of the injection that you give. Give it alone, stand alone. I don't treat them with all these injections, fancy injections that you told me. It is just a small local steroid, Canacort hexatonide molecule of triamcinolone, which is more water soluble, less systemically absorbed. It is just 40 milligram, 2 ml, and that helps.
Problem is that, sir, to treat the knee joint is very easy with the TKR, but reverse arthroplasty is very difficult. Almost it is considered the rare surgery.
Yes,
so that is why
it's very expensive. So knee surgery, average knee surgery would cost you around 2.5 lakhs in a good hospital, sometimes 3 lakhs in a suite room, but a reverse shoulder average would cost you 4.5 lakhs, with the implant itself is 2.85 lakhs. So it is an expensive surgery, but it is the game changer in shoulder. Take my word, 5 years from now, you will have more reverse shoulders than plates in the market.
It happens. That is why people used to come. Many a times incidences are increasing like anything.
Yes.
So that is why I want to just ask.
50% of my plates used to fail in old patients, and that is when we realized that we need to change the modality of treatment for patients. Anyone above 70 years, a reverse shoulder.
Calcium with D3.
Yes.
No rule.
It is great. I would give
in case of the degenerative changes, I am talking about when the patient is above the 50 years.
I would always give calcium and not painkillers for any patient above 50 years.
Okay.
Always calcium with vitamin D. And if you have low bone stock, your bone mineral density shows that you have osteoporosis, better to also give teriparatide injections and denosumab injections. They are really helping well, even post-surgery.
Okay, sir. Thank you so much.
Thank you, sir. To conclude this.
It was a well-structured presentation that kept everyone engaged.
Just we conclude the session here.
Yeah.
Really very nice talk.
Thank you.
I would like the chairperson.
Thank you.
So I would like you all to please honor Dr. Moving towards the next topic, I invite Dr. Nimesh Patel sir on stage to enlighten us on minimal invasive surgery in brain and spine. I request the chairperson to introduce Dr. Nimesh Patel sir.
Good afternoon, everybody. This is the last talk before lunch.
Sir, shall I introduce Dr. Nimesh Patel? He is the lead consultant working in the Department of Neurosurgery.
Sir, I'm sorry to interrupt. Just 1 minute. I request all the delegates to be seated, please. This is the last session, and after that we are going to have lunch. So please be seated. Continue.
He is an endoscopic and skull-based neurosurgeon. He is expert in the minimal invasive spine surgeon, neurovascular surgeon also. He is working in the Bhailal Amin Hospital in Baroda, Brain and Spine Clinic, Vadodara, Gujarat. Over to you, sir, please.
It's not showing. Yeah. Good afternoon, everybody. Thank you, organizing committee, for having me here as talking on the advances. Pragnesh has actually asked me for the advances in the neurosurgery. I thought I will be talking something a little bit basic. Now, covering entire neurosurgery advances in 20 minutes is beyond scope of the time limit. I'll try to cover something which probably you might be encountering in your regular practice. There are so many advances in neurosurgery, talking from brain hemorrhages, as aneurysms, AVMs. We do a lot of intervention, coiling, stenting, a lot of advances into the epilepsy surgery. We do a lot of robotic surgeries into the lesioning. But I believe the commonest issue which still bothers in my branch is brain tumor and spine surgery. So I am basically national faculty for the endoscopic neurosurgery and minimal invasive spine surgery. You would be regularly coming in your practice that these patients with a headache and backache and everything. The moment the name neurosurgery and brain and spine surgery comes in picture, everybody start thinking, including non-neurosurgical medical personnel, that the branch is predominantly involved with the morbidity and mortality and deficits and everything. But let me tell you, the branch has significantly changed over past 3 decades, and especially in last 2 decades. The entire focus of neurosurgery is mainly not just to save the life, but to give a better and quality into the post-operative period. And hence, the concept of minimal invasive surgery is significantly involved in neurosurgery for last 2 decades. As you would have come to know about laparoscopy in the morning lectures, Dhrumil has presented a wonderful talk on the shoulder arthroscopy. You have come across about the knee arthroscopy. Same way, neurosurgery has changed from just routine craniotomy and open surgery and a kind of head injury and intracerebral hematoma to the level of pure endoscopic surgery, apart from a microscopic surgery. So when we talk about minimal invasiveness, the first thing comes is the scope. So anywhere you have a scope, in neurosurgery we have endoscope apart from a microscope. You all probably would have come across about the pituitary tumor has been operated since ages by transnasal endoscopic route. So that is something not very new to any of you. And we do extensive transnasal endoscopic surgery for the pituitary tumors. And that is one of the early minimal invasiveness in neurosurgery, that you don't do craniotomy. You go through the nasal route and you don't disturb the brain. The entire concept of minimal invasiveness in brain is to minimize the brain retraction, minimize the normal brain damage. And that is where you basically treat pathology and give the best possible outcome post-surgery. Hence, the minimal invasiveness is very important in brain. But apart from transnasal surgery, we now regularly do intraventricular tumor surgery through endoscope, no craniotomies, lateral skull-based surgeries. The topic which probably interests you is more of a trigeminal neuralgia, acoustic schwannomas, and all lateral-based tumors. Transcortical endoscopic surgery. So these are something probably you might not have come across very regularly. Most of the general medical people know endoscopy in neurosurgery is related with the pituitary surgeries, which is transnasal. As I already mentioned, stitchlessness, आपको कोई stitch नहीं होगा, that is not the minimal invasiveness surgery. That you cannot sell those things on those. You can have stitchlessness even in the large open wound also. So the concept of minimal invasive has nothing to do with the stitch, or stitch is there or stitch is not there. After 8 hours of my acoustic surgery, the patients at the end of a discussion, they asked me ki taanke kitne the, which literally annoys me actually, because they are not asking the real questions. And there are a lot of people who are, marketing the things on the basis of, so stitchlessness has nothing to do with the minimal invasiveness. It is the retraction of the tissue, it is the damage of tissue when you are doing a brain surgery or a spine surgery. That is very important. Shorter hospital stay, decreased pain, everything is a collateral advantage, not the main advantage. The inner work has to be done properly. So as I mentioned, transnasal endoscopic surgery has been done routinely. We have a large series of transnasal endoscopic surgery. This is one of the earlier phase of my career. A large pituitary tumor, you can make out both carotids are involved, the cavernous sinus is also involved. He has lost his vision, he came with the acute loss of vision. And what we did, this is our endoscopic this thing. I'm not going to go in detail of the entire video. So this is a transnasal route. I'll just quickly, so we open the sella, as you would have been able to brush, the pituitary gland stays into the sella. So you open the sella, you open the dura, and that's opening of dura, and we are removing the tumor. So it is after removal of tumor, the entire thing is transnasal. All pituitaries now we do is predominantly transnasal. So this is, the upper one is the pre-op and the lower one is post-op. He regained his full vision because the compression over optic nerve is gone. We have removed tumor from the cavernous sinus. As you can make out, there is no lesion on the cavernous sinus. So all this is possible if you have a minimal invasiveness. Can we do, so we do large size of the pituitary through endoscope. But any good neurosurgeon should know when not to do minimal invasive or when to do open, or you have to combine minimal invasiveness with the endoscopic. So this is one of the largest pituitary which I have operated, you can make out. So through endoscope you can't reach here, so you have to do combined approach. So any minimal invasiveness, you should know when to stop or when to go further. These are the same patients. We have a large series of pituitary. So can we do, apart from pituitary, any other tumor through nose? Yes. We do now many skull-based meningioma through nose. There are aneurysms, like ACOM aneurysms been done by nose. So this is one of the meningioma which first time anybody has attempted in Gujarat. This is almost 11 years back I did, and I'm trained for the extended. So the difference is not just the sella. Here the sella is normal, so you have to drill literally this area and then to approach. So when you have to do open surgery in this, you literally have to retract, dissect many brain fibers. So the advantage of minimal invasiveness in this is you basically don't disturb your normal brain. So the initial steps are same. I'll just quickly show you why these cases are important. So I'm actually using a high-speed drill through the nose, and I'm drilling the bone, because you can't cut the bone with any instrument. So you have to drill the bone, you have to thin out, and then you will see the dura, and then you basically remove the tumor. So that is the tumor which I'm removing. So all these are transnasal. We do CSF rhinorrhea repair. Previously it is craniotomy which is to be done. Now everything is endoscopy. So this probably you all might be aware what is minimal invasiveness and endoscopy through the nose. But things have changed significantly in last 20 years into the branch of neurosurgery. All our trigeminal neuralgia, you all would have come across about trigeminal neuralgia, severe lancinating pain in the distribution of fifth now. And the standard care of treatment is carbamazepine. We all start carbamazepine, even at the general practitioner level. That's the line of treatment. If it comes to me, I'll also start carbamazepine. That's the standard treatment. You continue with them. You probably increase the dose, you decrease the dose, you add on the medicine. But trigeminal neuralgia is a condition where eventually they have to go for the next level of treatment. There is something called as apoptic phenomena. Means after some time, either they will be resistant to the medicine dose, or they'll have a side effects like drowsiness and other things, even with the other medication. So the best treatment, and it is one of my favorite surgery, is called as endo-assisted or full endoscopic microvascular decompression of fifth nerve. So we basically put Teflon between the fifth nerve and the loop which is causing compression the fifth nerve. The moment you do, the pain will be completely gone. They won't need any medicine. Problem with the same way you might have seen hemifacial spasm. In hemifacial spasm, there will not be pain. They will have a constant contraction of the muscle. Unfortunately, no medicine will work in that. So since the time minimal invasiveness is, so when we say minimal invasiveness in brain, our entire intention is to reduce retraction over the normal brain. So when we do any trigeminal surgery, it is behind the ear. Okay, so we open up this area. So when you don't do endoscopy, you create a larger craniotomy. When you do endoscopy, you basically reduce the endoscopy. I mean the craniotomy size. So this is one of the case with hemifacial spasm. This is the 7th now of MRI. This is the vertebral artery which is anomalously gone, and it is compressing the root entry zone of the 7th now. And this is the intraoperative picture actually, endoscopic. So this is vertebral artery, that is brainstem, that is facial now. When you have a hemifacial spasm, you look for the facial. When you have a trigeminal neuralgia, you look for the trigeminal neuralgia. So this is a pure endoscopic decompression, and that's the video. We have put a Teflon between vertebral artery, brainstem, and facial now. The patient did absolutely fine. So that is the first thing. You can see that twitching over the face. You also might have seen hemifacial spasm in your regular practice, and that is post-surgery. She's completely relieved. Believe me, when you type suicidal pain tendency into Google, the first 5 diseases which will come is trigeminal neuralgia. The pain is so bad. Or a hemifacial spasm where pain is not there. But most of the hemifacial spasm will go in a depression because they cannot go in a social function because of this symptom. It's a blessing. The surgery is actually a blessing to any of them. And it's one of my favorite. All acoustic tumors, all CP-angle tumors, we use endoscope. The entire purpose is you don't retract the cerebellum. More you retract the normal brain, it gives more and more morbidity. And that is why the minimal invasiveness is significantly important in our branch. Another tumor, now here it's a large tumor, but this is left side. And as you know, left side is a dominant hemisphere. You have a speech area. So you can't cut the brain here. You can't retract the brain here too much. Otherwise, it will lead to a speech deficit. So I cannot have that, gigantic ego that I have removed the tumor, but patient eventually end up with a speech problem. That is never the way of doing surgery. So that is where the endoscopy makes significant. I'm not going to go quickly. I'm not going in detail of this video. This is pure endoscopic video. So sorry. So this is basically a pure, we haven't done any retraction on the speech area, and the entire surgery is done endoscopical, and that's the normal brain. Patient did absolutely fine, no speech deficit. This is already 7 years post-surgery. So can we do anything from above also through the brain? You all would have come across hydrocephalus, and biggest issue in hydrocephalus is in a pediatric age group. And when I ask you, you all would be saying that the treatment for hydrocephalus is VP shunt, right? You all would have come across that. The biggest issue with the VP shunt in pediatric age group is shunt block and shunt infection. This surgery is a blessing. So what we do is called as endoscopic third ventriculostomy. And I'm glad that we are the one who started endoscopic intraventricular surgery in central Gujarat and in Vadodara actually. That is almost now 9 years back. So we go through brain parenchyma directly into the ventricle, and all intraventricular pathology we can do surgery through the scope. So this is my system. Here, as you know, in VP shunt, you basically divert the fluid from ventricle into the abdomen. The problem is shunt. It's a foreign material, so it leads to a lot of infection and everything. Here we don't do any shunting. So what we call is as an endoscopic third ventriculostomy. So we create internal opening. This is a patient who already shunted twice, blocked, eventually referred to me, and we have removed the origination. This is the lateral ventricle. You can see the choroid plexus. Now through foraminum mundo, we are entering into the third ventricle, and we are creating another opening. We are bypassing the aqueduct. So directly from intraventricular, it goes into the subarachnoid space, as you know the system of CSF. And this patient is shunt-free now. Intraventricular tumors, I won't be going in too much detail of the technicality. All these tumors we do. So if you don't have an endoscopy, you basically go through the brain fibers here. And that leads to a lot of issues in terms of morbidity. So this is all same patient. I'm entering through the scope, and that is the choroid plexus into the lateral ventricle. You trace down to the foramen of Mundo, that's the tumor. So you decompress the tumor. In neurosurgery or neuro-oncology, we first decompress the tumor, so you don't retract brain too much. And once you take it out, you connect both the ventricle. This is almost 7 years. This patient actually presented with migraine and everything. And now he's absolutely fine. He's working in one of the MNC, and that all is through a small incision. But still, this is not the main point. Point is, I'm entering and disturbing minimum brain fibers. So that is the importance of minimal invasive. That is post-op CT, another cystic lesions, working in one of the MNC, came with the monoparesis, and we have done endoscopic surgery, did absolutely fine. All arachnoid cyst, we don't do any craniotomy. It's all endoscopic surgery. So I won't be going in technical details. As young as 3-month child we operate. This is one of a very close patient to us, actually been operated almost 8 years back, and it was mainly infective hydrocephalus. You cannot do shunt. So what we do is a simple one. What we did basically was an endoscopic lavage and debridement. Child survived that situation, and then we did PP shunt because it was not possible. The ATV won't work in these patients. So this is the youngest child that we operated endoscopically, and he's still surviving. It's all pus in the ventricle. So same way, whenever we talk about a spine surgery, even probably in a crowd, it's a common issue like a shoulder pain and a knee pain and a TKR. Still the acceptances more come with the TKR. But when we talk about the spine and a spine surgery, सब ऐसे 10 फुट पीछे चले जाएंगे कि चाहे कुछ भी हो जाए, we are not going to do the spine surgery. That is completely changed in last 20 years. It's not the, the fear which people used to carry now. And that is because the equipment and instruments and the skills have significantly improved. Again, when we talk about a minimal invasive spine surgery, the purpose is not कि टाका नहीं आने वाला है. It is not the purpose. The entire purpose is basically to prevent your back muscle. As you know, on either side of midline, you have a bulging of the muscle, which is the supportive muscles to the spine, erector spinae. When you do open surgery, you basically dissect both the side of the spine muscles from the lamina and spinous process. Okay, so this is open surgery. And you basically denervate those muscles. So it leads to a lot of back pain related issues even after surgery. When you do minimal invasive surgery, you basically don't dissect anything here. You go through the muscle, you dilate the muscle, and you use those channels for your surgery. Same way, either for the tube or for the endoscopy. So we do both. So as this figure mentioned, this direct injury causes a lot of issue in post-op surgery. It's not about the incision size or the length and everything. It's about disturbing lesser muscle fibers is the key for minimal invasive surgery, and that is the major advantage in minimal invasive surgery. So all this surgery we do, these are the markings. I'm not going. So this is a quick large extruded disc patient came with a foot drop, and this is how our assembly is. A small scope is being used. The tubular dilator is used, and that is a tube. So initially we use 22 mm. The diameter of that tube is 22 mm. Once you are more and more master, you basically reduce your tube size so that you dilate muscles less. So this is our dissection, that is dura, and that is large disc fragment. And the entire disc has been taken out through the tube only. So that's a dissection. So, and that's the large fragment of disc which has been out. That's the final picture, root and the dura. So as you are more trained, you do a lesser size of this. So this is an 18 mm tube. So you are dilating lesser muscles, you are damaging lesser muscles basically. And that's the incision. So any incision or stitchlessness is always a collateral advantage. It is not the main point. Internal work has to be correct. All these things needs a surgical screen learning curve apart from the instrument. So we can do recurrent disc surgery with the minimal invasive through the tubes. We can do 2-level decompression. You can imagine, like if you have a 2-level surgery, you have to put large incision. All this through a small incision. So 2-level decompression. You can do spinal canal stenosis through the same tube. I won't be going in detail of the video. And we can put screws also. So till now you might be knowing about the screws and everything,
1 minute,
listhesis.
please.
So it is
1 minute, please.
yeah, sure. I'll conclude. So that is a large listhesis with, and all the screw goes through percutaneous incisions. No opening of the muscle, no damaging of the muscle. And the entire decompression, you can see the figure, entire decompression is through the tube. So I'm just skipping the thing. So all screw fixation we regularly, you need a lot of equipment for that thing. It's not simple as it is seen. So a high-grade listhesis has been done with the same. You can make out a large listhesis been corrected, and that is all through a percutaneous wire only. Two-level fixation has been done with the same, so you are not opening any muscles in between. That is the advantage. So I'm skip this cervical surgery we regularly do. Aspirant IIT student, we did minimal invasive C2 vertebral fracture, and we preserve the motion. That is the most important. Rotation has been preserved. That's the intra-op technique, and he had a good fusion. He's now doing IIT. A kyphoplasty osteoporotic fracture, you all would have come across. We don't do any open surgery. What we do is called as vertebroplasty. So I'm skipping. And the final thing, what we regularly do is now the tumor also. So all spine tumor, we regularly do minimal invasive techniques through the tube only. And that is a big advantage. I'm glad that apart from a national faculty, I was fortunate to be representing Gujarat Neurosurgery at the World Congress of Neuroendoscopic Conference, which was held a couple of years back in Singapore. And any tool in neurosurgery will definitely give a positive outcome. But the skill has to be there. You cannot, any good tool cannot make a bad surgeon a good surgeon. But if it is there, a good surgeon will obviously give a better result. So that is the first, our department is the first Gujarat's neurosurgery department to have a robotic visualization system a couple of years back. Thank you. Thank you very much.
Thank you, sir.
I hope I am able to change a little bit of view towards my branch of neurosurgery, apart from morbidity and mortality.
Absolutely.
Definitely, you have changed the full modality and this thing of ours. And it was really too good.
Thank you.
Covering the full neurosurgery, which is very difficult to cover in half an hour.
True.
So it's really too good, sir.
Thank you.
Thank you.
Thank you very much. Sorry? Yes, so as I said, there are a lot many advantages in neurosurgery, but beyond the scope of discussion here. So when a selected patient of Parkinson is there, there are criterias. If that patient is matching those criterias, particularly for the bradykinesia and the tremors, what we do is called as deep brain stimulation. It is a blessing in a selected patient. The problem, all patients cannot go for the DBS. So DBS is basically, as a little bit of theory, if I don't go in detail, it's mainly somewhere the problem at the substantia nigra related with the dopamine. Itself is a big, but what we recommend is deep brain stimulation in a selected patient. But it is good if it is selected correctly. It should be done. Problem is cost.
Thank you so much,
you.
sir. Now I would request the chairpersons to honor Dr. Nimesh, sir. All the chairpersons can receive their token of honor from the point of honor corner for family physicians. Now I would request all the respected doctors to gather for lunch and then come back here around 2:45. Cancer prevention, role of lifestyle beyond diet and exercise. And I request chairperson to introduce the esteemed speaker.
Now I request chairperson to introduce the Dr. Chirag Shah, sir.
Hello, good afternoon. Dr. Chirag Shah is the Director of Department of Hemato-Oncology, Apollo Cancer Center, Ahmedabad, and Director of Shyam Hem Onco Clinic, Ahmedabad. He is a renowned specialist with more than 20 years experience in cancer and disease of the blood. He has done his MBBS from Baroda Medical College.
Thank you, chairpersons. Thank you, organizers. And I think one of the most important introduction point for me is that I am a Baroda Medical graduate. We have had a very nice lunch, and now I'm going to talk about what is beyond lunch. With cancer growing day by day, a lot of people ask me, and I'm sure they are asking you also in your daily practice, as to why so many cases and what we can do to prevent cancer. And every such discussion stops at diet primarily, shu khao, shu na khao. Whereas in the modern medicine, there is a lot of research already done in last about 15-20 years, published, covering thousands of patients, lakhs of patients, as to what are the reasons for cancer. We don't know all the reasons, but we know many of them, and they are far beyond diet. So we will talk about those today. It's a very big topic, lifestyle, so I will not be able to cover every aspect, but important ones which we can convey, you can convey to your patients and families in practice as to what they can do, what is in their hand. Okay? So first, I think, everybody thinks of lifestyle as something when they are ready for lifestyle. Means after about 40, people have settled in their career, then they start thinking. But lifestyle starts before birth. Okay? We know some of these data that in utero CMV infection can lead to blood cancer. Certain myeloproliferative neoplasms, again, the first mutation happens in utero. Early life exposure to infectious agents can lead to cancer development. Not related to cancer, but also known very well, is that the maternal obesity increases the risk of cardiovascular diseases in children. Okay? So lifestyle starts way before when we start actually thinking. The other is that adolescent exercise is associated with reduction in mortality from all causes in middle age. So because most of the cancers occur after middle age, people start thinking of cancer prevention only at that age. But you should know that the seeds of good health are, from before birth and in the young age also. A woman's risk of breast cancer is primarily determined by her lifestyle before the age of 30. Now, we start mammogram after the age of about 40 to 50. That is when the cancer actually starts showing up. But the risk is determined by your lifestyle way before that time. Okay? And this is probably true for many non-communicable diseases. So the point is to start early, younger the age for risk factor, bigger the impact, and same for preventive efforts. So when you are talking to the families that you take care of, you can tell them to take care of the children lifestyle and not wait for adulthood. This is based on several studies, as I said earlier. It would seem, at the end of the talk, it would seem like what I'm talking about is what our grandparents were already doing. So actually it is nothing complicated. After billions of dollars of research, we have figured out that our grandparents were very, very smart. That's the one-line message of the whole talk actually. Okay? MD Anderson Cancer Center, which is the largest cancer center in US and in world, they have this review article from September 2008. The title is Cancer is a Preventable Disease That Requires Major Lifestyle Changes. Okay? Very clear message. So it is not about lot of other things, but primarily lifestyle. And what we know about the cancer is that tobacco, of course, 30% of cases, alcohol about 5%, lifestyle is about 30%. What many people don't know is infections, not just human papilloma virus, but other also. The hygiene also is related to about 20% of cancers. Obesity, as of today in US, 40% of cancers are linked to obesity. That is a huge number, a fairly preventable issue. Okay? And of course, lifestyle is very closely linked to the obesity. Air pollution and others are smaller factors, and hereditary is about 5 to 10%. Most people are hung up on the idea that cancer is a genetic disease, so it has to come from the families, but that is only 5 to 10%. So rest is all acquired. Now, when we talk to families about good lifestyle, it is very hard for most people to follow it. That must be the experience of all the doctors, that you tell them good diet, good exercise, wake up early, do this, do that, follow that, but they cannot do that. Motivation doesn't come, or as we have seen many memes on the WhatsApp recently that January 1st to 6th, there will be a lot of people going for walk, the New Year resolution. From 7th, everything will be normal, right? So how do we get that drive, motivation, to continue and implement good lifestyle? For that, you need good EQ, emotional quotient. The mental balance is very important. And I would strongly urge for every one of you, for your children, grandchildren, and the families that you take care of, to ensure that they focus on this part a lot, that maintaining a good mental health, a good emotional quotient. Because if that is there, then this knowledge or whatever they read, they will be able to implement. If that is not there, then in spite of knowing, they would continue to eat unhealthy diet. They would not be able to exercise. Even when they are gaining a lot of weight, they would not be able to control their diet. So what gets you to a happy state of mind, a good EQ? That is a very important question. And this is again research-based answer. Largest study from Harvard, known as Harvard Study of Adult Development, going on for 3 generations. In fact, just 2 days ago, Divya Bhaskar on the, I think, 1st January, front page, they have quoted this study. This study is showing that the number one factor determining how long we live and how happy and functionally well is the relationships, the quality of our relationship, not the number of relationship that we have on Facebook or whatever WhatsApp, social media, but the true high quality relationships. And what they say is the feeling that you can count on that relationship is the main test of the quality of relationship. Okay? So this is a very, very important factor. And this is just one study, but I'm quoting, but there are several studies which are now showing that the social factors are equally or more important than the organic factors that we as doctors keep talking about, like cholesterol or blood pressure, etc. how the longevity is determined is based on the social factors also. So how that works we don't know much, but there are theories that during our lifetime we have lot of stresses and injuries, and that body, how it handles, is determined by how happy, content, in good relationship we are. Okay? So that inflammation injury, now in cardiology, oncology, everywhere you would hear about inflammation, and that can be reduced by having good relationship. Loneliness, as per these studies, are the biggest killer in today's day and age. And this is again proper allopathic research we are talking about. Okay? So coming to the next point of hygiene. So dental hygiene is linked to not only oral cancer but esophagus, breast cancer, skin cancer also. And you may be aware that it is also related to the cardiovascular risks. Similarly, the ovary and uterus cancer related to the hygiene's microbiome in the genitalia, in private parts, if it is not healthy, then there is a higher risk of cancers. One important part in the practice is prescription of antibiotics. I think the pediatrics have improved a lot about not writing antibiotics, and I think there is more awareness among public also, but it is important to note that too much antibiotics have many unintended consequences. One of them is cancer. By changing the microbiome of the gut unnecessarily, frequently, you lead to formation of adenoma, which is a very well-known precursor of colon cancer. Okay? Then comes high-dose vitamins, because everybody thinks that if small amount of vitamin is good, then larger amount is better, and if I take this much vitamin, I'll become a superman or superwoman. Okay? So lot of high-dose vitamins are going around, and those are clearly shown to increase the risk of cancer in multiple studies. None of the studies have shown them to be beneficial for anything. Okay? Either the studies are showing neutral or risk to health. So please remember that if you or your patients are taking high-dose vitamins regularly, advise them to take only the regular, the RDA, recommended daily allowance, not more than that. Then comes night shift. So night shift is now almost an everybody's lifestyle. So sleeping very late is especially in the children and young adults, and that has been linked to multiple cancers including breast, GI and lung cancers in women. Night shift work, a risk factor for breast cancer. There are many studies you can look up on the internet. So what is night shift definition by the Center for Disease Control USA? CDC is the primary health body of government of US. So when they quote something, it is not without lot of research. It is very authentic when they come out with that. So night shift definition for them is at least 3 hours of work between midnight and 5 a.m. Remember how many of our children are awake between this time? 3 times or more per week. Long-term shift, that is 10 or more years, started very early age and continued very long. This is the story of many youngsters. This is a highly preventable lifestyle factor for several diseases. You can read on the CDC website the list of the NCDs that this night shift leads to. It practically covers 80% of our outpatient today. If you read that list, your 80% OPD is covered by that. How it does this lead to cancer, it is not very clear, but one of the theories is that melatonin is one hormone which is produced at night, primarily between 10 to 2 a.m., 10 p.m. to 2 a.m. That is why sleep early, wake up early. So it is not just sufficient to sleep from 12 to 8 hours, or 2 to 10, which many youngsters argue with us, that I am sleeping 8 hours, you told me. Okay, I slept at 2, I woke up at 10. That's what I'm doing every day. That's not sufficient, because 10 to 2 is when you are making the most of melatonin, and this hormone has been shown to prevent the tumor growth in many biological models. Okay? Next comes the sedentary behaviors. This is not a surprise, of course, but very focused studies showing that if you are watching 14 hours per week of television, then your risk of colorectal cancer is 70% higher than somebody who is not using that much television. And when these studies were initiated, we did not have the smartphones. So add to that, there is additional sedentary behavior. So these are things which are in our hand. The good news also coming from these studies is that people who don't have time or motivation to exercise every day, like this formal 45 minutes of exercise, sweating, increasing heart rate this much, for them also there is a good news, like people like me, that you can have only weekend activity, weekend sports, cycling, cleaning the house, walking, running, whatever you do. Just Saturday, Sunday also is a fairly good protection. And similarly, other minor activity levels, 3 to 4 minutes of activity burst, like in the various day times. So going up the stairs, okay, not taking a lift, elevator, going up the stairs. Or park your vehicle far away from the shopping place. Instead of, we all like to circle around and find the closest parking spot. Instead, go far and you walk, 3-4 minutes. Many such activities, gardening, helping, family, so many little activities also provide very good protection. The formal 45-minute exercise protection is here, and what I mentioned is here. So it is not even all the way down. So the protection level is pretty good. Okay? So this is a good news which you can also convey to your patients, that they don't have to be discouraged that if they are not able to wake up early in the morning and after 1st January to 6th January, if their drive has died down, don't worry. There are many other things you can do. Okay? Dry fruit consumption also reduces certain cancers, including colon cancer. Light to moderate drinking is linked to some cancers in women. And important point is that the risk for the women is double than the men. So if the risk for one drink for men is say 2%, for women it is 4%.
Sir, please, 2 minutes left.
So lastly, chemicals. A lot of people ask about this. Now, it is difficult to study all the chemicals, but what you can remember is that there are many chemicals around us which we cannot, replace everything, but avoiding packaged foods is most important. These are known to be a very important risk factor for cancer and obesity and many NCDs. Cosmetics also have at least 10 level 1 carcinogens. So last slide, lifestyle take home messages. As my elder uncle used to say, one line lifestyle, पैर को रखो गरम, पेट को रखो नरम, सिर को रखो ठंडा. This includes everything. So this is what I do in my busy practice when people ask me about lifestyle, because I don't have time to explain all these slides. Focus on children to encourage healthy habits. Be socially close. Reduce your screen time and increase your people time. A little bit of spirituality, I think, is important to improve our EQ. Sleep early, wake up early. Stay physically active even if it is no formal exercise. Diet we haven't covered, but in one line it should be as far as possible home cooked, hygienic, reduce packaged foods, eat early and less fried food. maintain a daily routine. This is very important because our biological clock, many hormones are connected to our daily routine. So when we change the routine too frequently, the system gets disturbed. Personal hygiene and weight control. Thank you.
Thank you very much, Dr. Chirag. You explained it very well, what our ancestors were doing. They were also maintaining work-life balance, as we would say. Any questions from the audience? So all of them are having a very healthy lifestyle. They're just all slumbering after the post-lunch.
After a healthy meal.
After the heavy meal. So I would just like to extend upon that. How much of extension have you seen results? Like people who have followed lifestyle, of course there is research, but what have you seen? And what about the natural, like nowadays they say turmeric, all these natural things, what are the results?
So, I would say that all the studies about lifestyle have shown improvement in reduction of many NCDs, and I think to some extent we also have seen in our own field to the patients or the families that we are following. When it comes to various food items, there is no one food item that we can say is a magic cure or something that one thing will prevent all cancers. Okay? We have to remember that health is a very complex interplay of many things, and the diet across the world is very different. Even within India, there are many different dietary patterns. So I think more important than some very specific elements of diet, rather than that is these other factors and how you eat. I think more than what you eat is how to eat is very important. So eating early works in Japan also and India also, right? So this intermittent fasting, in spite of diet being so varied, works everywhere. So I think that is more important. What we need to teach our patients and families is that how to eat is a lot more important aspect than what to eat.
Thank you, sir.
Thank you, sir. Your passion for the subject shone through and left a long-lasting effect on all of us. Now I request...
Sir has one question.
Okay.
Sir has one question.
Yes. Yeah. So lot of reasons, and some of these are not something we can change. For example, having first child before the age of 20 is the biggest preventive factor against breast cancer. Now, yes, I know this based on the science because we have been studying this for 30 years. Even when I was in fellowship, we were taught this. We know this for that long. But with the modern lifestyle, I cannot advise this to anyone, let alone my children. Okay? So there are some things which are beyond our control, but we need to focus on what is in our control. So I think what happens that whenever we are talking about prevention, whether it is cardiology, oncology, anything, people get a lot of focus about what is, what not to do. They get worried when they listen to such talks. I think more important is to be positive about these things, that what is in our hands, focus on that, rather than આ નથી કરવાનું. Even to our patients, I think we should be telling more of this, that what they should be doing rather than what they should not be doing. I think that is a very important message.
Now I request the chairpersons to honor Dr. Chirag sir. Moving towards the next topic, I invite Dr. Sonia Dalal ma'am on stage to enlighten us on cophology beyond allergies to infection. And I request the chairperson to introduce the esteemed faculty.
It is my proud privilege to introduce Dr. Sonia Dalal. She is a consultant pulmonologist, founder director of Kalyan Hospital, Vadodara. She is a unit of Dalal Sleep and Chest Medicine. Her areas of expertise are sleep medicine, intervention pulmonology, obstruction airway disease, and interstitial lung disease. Academically, she has been conferred the fellowship by American College of Chest Physicians, presented multiple posters and papers and lot of research work. She will talk about how we see day-to-day practice, how allergies become infections. When allergy turns to infection, we just follow up. Over to Dr. Sonia Dalal.
Good afternoon, everyone. I'm sorry, I always have a problem because when there is a huge podium, I'm never seen. So, but anyways, big shout of thanks to Pragnesh and the organizing team of FPNATCON. What I'm going to talk today is, it's beyond inflammation and infection, cough. So as a general practitioner or a private practitioner, how are you going to approach a patient who comes to you for the cough? So we all know what is cough. Cough is basically, a reflex mechanism, right? What it helps is to prevent aspiration. In Gujarati, what we say that antras jai, right? So that's preventing aspiration and also taking care of any clearance of the airway secretions or maybe some sort of a foreign sensation. Pathologically, excessive and protracted cough is common and it's a very disabling complaint. Most of you would probably get a patient to you 50 to 60% of the times in your OPD for a cough, right? Severe cough causes major decrement in the quality of life because it hampers quality of life. It causes cough syncope. You probably might be coming, itlu badhu khasi khadu and a chakkar aaya na padi gaya. So that is cough syncope. Dysphonia, social isolation, they cannot take part in a lot of social activities, depression, long-standing cough, and we have been observing this post-viral, post-COVID, post-H1N1 patients having cough for a long time. And cough is one of the most common factor for a long COVID, right? So we had a lot of patients who came with cough for a long time after COVID. And they have social isolation, they are in depression, so on and so forth. So this is the slide which is probably the crux of me and the whole talk. If you look at it, more than 50% of the times, patient going to a general practitioner is because of respiratory symptoms. Either there is cold, there is cough, breathlessness, wheeze, or a fever. So fever with cough, this is the most common symptoms that a patient would come to you, right? Out of which, if you look at it, the cough is a predominant symptoms in 59 to 60% of the times. So what is the pathophysiology of the cough? What causes cough? Right? Cough is basically a reflex mechanism whenever you have an irritation in anywhere in the respiratory symptoms. So my talk is for 20 minutes, which has been given to me. But if Pragnesh allows, I would probably, in fact, also teach you where the irritant is when the patient comes to you just by the quality of the cough. So after my talk, if I get 5 minutes extra, I would probably tell you how the quality of the cough is and where exactly you can diagnose where the irritant would be, and that is how you can chase the patients. So what normally we have is, we have a deep inhalation whenever there is an irritant anywhere in the respiratory system, where there is a cough receptor which gets stimulated, and then there is a stimulation of the vagus nerve which would go to the cough center in the brain, and then there is a deep inspiration, and then a compression, and then what happens, that will the vagus nerve and the spinal nerve through an efferent pathway stimulate the respiratory system and the patient would cough. So it's something like this. If I have irritant anywhere in my body, right from the pharynx up to the alveoli, what the first thing would be, I would inhale first, like this, right? Because there is an irritation. The moment I inhale, and then there is a compression from outside because of the positive intrathoracic pressure. And then I will just cough out. So this is how there is a signal which goes to the pons and medulla, and then through the vagus, it would come back to the respiratory system, and then you will have a forceful expiration. So what are the types of cough? So we have a productive cough and a dry cough. So whenever you have cough followed by a phlegm or a sputum, it's a productive cough. And when you have only cough which is making noise or just not bringing out anything, no wheeze, nothing, then it is a dry cough. And then you have 3 types of cough depending on the duration. So you have an acute cough, then you have a subacute cough, and you have a chronic cough. So acute cough is cough which lasts for anywhere around 6 to 8 weeks. 3 weeks. Subacute cough is 3 to 8 weeks, and any cough which lasts for more than 8 weeks is a chronic cough. So what are the causes of acute cough? They are upper respiratory tract infections, laryngitis, pharyngitis, bacterial, viral, fungal, tuberculosis, so on and so forth, pneumonia, asthma, congestive cardiac failure, pulmonary embolism, foreign body aspiration. And what are the red flag signs? So when would you refer, when a patient comes to you, when would you refer that patient to a physician or a pulmonologist like us? In case of an acute cough, if the patient comes to you and says that he has a cough with blood in the sputum, which is hemoptysis. If the patient says that I become very breathless, I'm wheezing terribly, right? If you look, the saturation is falling down. If the patient has got hoarseness of voice, which is lasting for a long time along with cough, if the patient is a smoker, or if the patient has a cough syncope. So these are the red flag signs where you need to act fast. Let's now talk about chronic cough. So what are the causes of chronic cough? And this is how you are going to approach as a general physician. So causes of chronic cough are basically cough variant asthma, it is psychogenic cough, it is neurogenic cough, congestive cardiac failure, gastroesophageal reflux disease is very common these days. So any patient who says that I have a heartburn and he is coughing, which is a dry cough, probably you need to rule out gastroesophageal reflux, because we get a lot of patients who have been treated as asthma with a lot of inhalation therapy, and basically if you take a proper history, it is just a reflux disease, and we send it to a gastroenterologist. Just one pill is going to take care of all those symptoms. So those things are very common. Chronic lung infections like tuberculosis, pneumonia, so on and so forth can be probably a cause of a chronic cough. And the other thing would be cardiac origin, which I said. So now, whenever a patient comes to you in your OPD, the first thing he says that I've been coughing for a long time. The first thing you need to find out the history. The history is very pertinent. You have to be very meticulous when you take them. Are you taking any medications? If they say yes, then for blood pressure, what medications you are taking? Can anyone from the crowd tell me any blood pressure medication which can... Perfect. So that's what. If a patient is on any ACE inhibitor or a patient is on a beta blocker and the cough is not coming down, that's the only thing you need to do. Right? You just don't have to go on getting a battery of investigations for that patient. That these are the things that I'll get it done, and you give them a lot of medications. So that is very important. As Madam rightly said, it's the ACE inhibitor which probably causes the cough. And this is the pathophysiology, how the ACE inhibitors would cause. It causes the stimulation of some of the receptors, and that causes a efferent vagal stimulation and cough. So now I have made some of the cases to make it more interesting, so that how do we approach to the cough which is going to probably be understood well. So this is a 40-year-old female. She's a known case of bronchial asthma. She presents with fever off and on, excruciating cough with mucopurulent phlegm. So this is a productive cough. She has a weight loss. She was treated with anti-tuberculosis medications for 6 months, were treated with various antibiotics, course of steroids, and in spite of that, there was a partial improvement. Hemoglobin was 12.8, total count was 10,000. IgE was 5,767, absolute eosinophil count was 814. So this is going in favor of allergic cough. where the IgE is high, eosinophils are high. So this patient has got a post-infective allergy, which is called atopicity, is going in favor of the same. But why does she have a mucopurulent cough? That should come to your mind. If she has an allergic cough, why is she bringing out so much of sputum? Why the flame is coming out, right? We did her pulmonary function test. She had severe obstruction. And when you look at the CT scan, I'm sure if you look at this, she had some amount of bronchiectasis, right? So the reason for her having lot of mucopurulent flame, she had cough with bronchiectasis, which was getting infected again and again. So this is a pulmonary cause of a chronic cough, right? So as I said, when you approach a chronic cough, you have pulmonary cause, you have cardiac causes, you have drug-induced causes, you have neurogenic causes, you have psychological causes. When you have such a history, it is a pulmonary cause of a chronic cough. So asthma, COPD, upper airway cough syndromes are one of the reasons for chronic cough. The other one which is very common is bronchiectasis in our country. We see a lot of patients having a sinopulmonary diseases as well, right? That's a cause. Interstitial lung disease, pulmonary edema. So these are basically a pulmonary causes of chronic cough. Let's go to case 2. This is a 51-year-old male tobacco chewer working in the city corporation, diagnosed as allergic rhinitis for 30 years. He is on Montelukast, intranasal corticosteroids. As and when required, antihistaminic, has a seasonal variation. Again, the eosinophil is 14%. Absolute eosinophil count is 850. Aspergillus specific Ig 0.1, Ig 140, and spirometry shows nearly a normal lung function. X-ray shows bilateral maxillary sinusitis, and HRCT thorax is normal. Can anyone tell me what might be the cause of the cough of this patient? Perfect. So this patient has got an upper airway related cough where the sinus is causing a post-nasal drip. And this post-nasal drip is so high during the nights. So if the patient comes to you and he says that I cough the moment I lie down, I have irritation in my throat, something is sticking, and I need to clear that off. That's the reason, that's the post-nasal drip because of upper airways. Look at, if I don't treat this upper airways and post-nasal drip, this patient eventually would become asthmatic. Case 3 is a 55-year-old male is referred for evaluation because of persistent cough for 6 months. Cough is not associated with exertion or shortness of breath. Non-smoker, not on any drug, which can cause cough. No rhinitis, no sinusitis. Has occasional heartburn in past 3 years. Exactly. X-ray chest is normal lung functions, right? So can this be GERD? Yes, it can be. Right? So this patient who has got a cough for 6 months, right, only one history, whether do you have a heartburn? Does the cough increases after meals? What is the time you take your meal? If you said I take meal at 10 o'clock and sleep at 11 o'clock, there's going to be a great huge reflux. A simple PPI is going to help. Right? In this patients, no need for inhalation therapy, no need for anti-allergics, no need for steroids, nothing. In fact, steroids and all those things are going to worsen the GERD. And when would you refer the patient to a gastroenterologist? After giving a PPI for at least 2 months, it does not improve, then only you can send the patient. And if you are suspecting a hiatus hernia, then of course, Pankaj Bhai is there. So, and if the patient needs to be operated for the same, you need to refer the patient. But before that, you need to give a trial of a PPI for at least 2 months.
2 minutes, madam.
Yeah, I'll be fast. So this is a 17-year-old female diagnosed as exercise-induced asthma, dyspnea, cough, which lasted several hours of exertion, had frequent panic attacks during the situation. She was given salbutamol, she was given, fluticasone, Montelukast, steroids, bronchodilators. We did her pulmonary function test, which was, okay, not bad. But if you look at this, she had got fixed airway obstruction in upper airways and lower airways. Can this be psychiatric disorder? Because she had panic disorders, right? Lung functions were normal. Patient was given lot of medications. sending to a psychiatrist, we found out that she is having anxiety and panic disorders, and she had a vocal cord dysfunction. So only counseling and sending her to a speech therapist helped. So just looking at the pulmonary function test curve, right, you can decide that this patient has got a psychiatric or a psychogenic cough. So, what is a psychogenic cough? It's a cough without obvious medical etiology, where everything has been ruled out and still the patient is coughing and all the reports are normal. And this cough is refractory to medical management, and you are eliciting a history of psychiatry or psychological basis. This is a 46-year-old diabetic man admitted to the hospital with a dry cough and shortness of breath. He has undergone PTCA, had COVID during the first wave and was on NIV for 7 days. When he was admitted, he had, he had a blood pressure of 95/60, oxygen saturation of 89%, bibasal crackles, bilateral extensive edema, puffed up face. Echocardiography showed an ejection fraction of 30%. A patient had a paroxysmal nocturnal dyspnea. Can anyone tell me the reason for cough? The patient has congestive cardiac failure, right? So you just need to, refer it to a cardiologist, or probably treat the congestive cardiac failure with a diuretics, non-invasive ventilator, and symptomatic treatment. So, the cough can be treated with antiarrhythmics if the patient has got arrhythmia. You can treat the patient with diuretics, and you can take care of those type of chronic coughs where the patient is telling that the moment I lie down, I'm coughing and the ejection fraction is low. And this is my last case. Is a 41-year-old male diagnosed as allergic rhinitis for last 5 years. I'm not sure whether really allergic rhinitis or not. Dry aching cough on Montelukast, intranasal corticosteroids. All investigations are normal. Had constant cough after talking, laughing, and strong smells. Can this be neurogenic? Was treated, all ruled out, right? Can you think that this patient can have a neurogenic cough? It's a dry cough, hacking cough, not treated with, not controlled with any of the medications. How do you evaluate such patients? So, neurogenic cough is a type of a cough where it is related to overtly sensitive nerves in the upper airways, a voice box and the larynx. The nerves that control sensation in the throat becomes very sensitive to very sensory stimuli. So, laughing causes cough, smells cause cough, right? A recent cold or upper respiratory illness would probably have that cough last for a long time. How do you treat these patients? After you rule out all the types of cough, if the cough is not going, you can give them a trial of amitriptyline. Giving them an amitriptyline, all methylcobalamin or a gabapentin is going to take care of a neurogenic cough. But before that, you need to rule out all the causes of the cough which I have elucidated before. So this is the Indian consensus on the algorithm of the approach of the cough. I'm not going to go into the depth of it because I've already said first rule out drugs, then a pulmonary cause, then upper airway cause, cardiac cause, GERD, and the moment you come to each and every one, you need to chase that and treat them. So the take-home message, ladies and gentlemen, is distinguish between acute, subacute, and a chronic cough. History is very, very pivotal. Physical examination are usually adequate for diagnostic workup of patients with cough. Chronic cough, patients need immediate further diagnostic measures. Therapeutic suppression of cough may be either disease-specific or symptom-related. First, consider causal treatment of the patient with cough if possible. If not, a proper approach to the cough is mandatory, and proper algorithmic approach will help in correct diagnosis and a therapeutic approach. Thank you very much, and I'll be happy to take the questions. And if I have 2 minutes, I can... if I have 2 minutes, I can show the quality of the cough.
That is better, I think.
Yeah, all right.
Question you can ask after the lecture,
all right. So,
personally.
If a patient walks to you in an OPD, normally the cough is from the respiratory system. You have larynx and trachea, then you have airways, large airways and mid airways. And then you have small airways, and then you have interstitium and alveoli. So now let's go, if the trigger is either in the interstitium or in alveoli, right, then the patient is going to cough continuously without even inhalation. And the cough quality is going to be very, very low. The frequency is going to be low. There won't be much of a noise. As we said, in upper airway, we have barking cough. In this, the patient will not inhale and there is a continuous cough. So if patient has got interstitial lung disease, if the patient has got pulmonary edema, if the patient has got pneumonia, the cough is going to be continuous expiration. Something like this. Now, if there is an irritant which is there in the small airways, most of the airway disorders like COPD is a small airway disorder where the patient will have a long expiratory pause because there is a air trapping in the small airways. We all know COPD is a disease of air trapping, right? So what they will do is they'll do so there is a long exhalation because they want to empty their lungs because of the air trapping. So when you have a coughing like this, it is a airway disorders. Now, if the patient has got a little higher frequency of the cough with 3 or 4 expiration after one inhalation, right, then it is a middle airways. And that is very classical of asthma. So patient would cough like this. This is classical of a middle airway cough. And if the patient has got laryngitis and tracheitis, we have normally one inhalation and one barking cough. So they will inhale and bark, inhale and bark. So that is upper airway. So inhale, bark, inhale 3, inhale and long pause and long exhalation, and no inhalation but continuous exhalation. So that is larynx, trachea, small airway, middle airways, small airways, and interstitium. Thank you very much.
Excellent, excellent, madam.
Thank you very much, madam. Too good. Especially I think we're running short of time. Madam, we need you.
Thank you so much, ma'am. I request the chairperson to honor Dr. Sonia, ma'am. Dr. Sonia, ma'am. Ma'am, I would like you to pick 2 lucky draw coupons and announce the number.
4541. 4541. I'm sorry. 454 and 315. Three, two, three. 323. 231. 231. I think I'm not that good, lucky enough. You can ask to the next speaker.
460. બધા લાસ્ટ પિકઅપ કરીએ છે પછી કોઈ નહીં હોય તો 274. બધા ઊંઘી ગયા જમીને.
Okay, so for the next session, I would like to invite Dr. K.N. Sheladia sir from Surat, Dr. Manish Jain from Indore, Dr. Mehul Desai sir, and Dr. Kedar Mehta sir, Dr. Mehul Salat from Ahmedabad to chair the session. I consider it a great honor to welcome Dr. Raish Manyar sir to bring some focus on laughter clinic, light-hearted talk. And I request the chairperson to introduce the esteemed faculty.
Yeah, good afternoon to you all. As we know, laughter is the best medicine. And that applies to all of us, we as physicians and to our patients as well. And the topic today is well chosen by Dr. Rais Maniar. He is a well-known poet, playwright, novelist, and eminent speaker of Gujarat. He has written 25 books. He is a recipient of prestigious Kalapi Award and named Narmad Award. He is youngest achiever in both of these categories. He has written more than 60 songs in Gujarati movies. So, great. He has written one background song in Sanjay Leela Bhansali's movie Ram Leela. So, which was the song?
It was a Gujarati song.
It was a Gujarati song. One of his books was inaugurated by none other than Amitabh Bachchan. Wow. 5 of his plays have won state-level awards. He has written one web series, Tari Mari Mulakato, on Shimayo platform. That's great. By qualification, he is a pediatrician with special interest in behavioral and developmental sciences and adolescent psychology. Possessing a unique combination of expertise in psychology and literature, he readily collects with audience, which he is going to do today. Over to you, Mania sir.
Thank you, sir. इस शाम का दमाम हिंदी जरा डिफरेंट लगे सर हिंदी में हाँ इस शाम का दमाम तबीबों के नाम है मेरा प्रथम प्रणाम तबीबों के नाम है मेरा प्रथम प्रणाम तबीबों के नाम और ये तो फैमिली फिजिशियंस है बिजनेस युग में फैमिली की जिनको है फिक्र पूरा बिजनेस का युग है बिजनेस युग में फैमिली की जिनको है फिक्र इंसानियत के काम को 100 सलाम है इंसानियत के काम को 100 सलाम है हैवी लंच एंड समवॉट हैवी लेक्चर्स के बाद लाफ्टर लाइट लाफ्टर चूंकि ये नेशनल कॉन्फ्रेंस है मैं कोशिश करूंगा कि आज थोड़ी बातें नेशनल लैंग्वेज में करूं वैसे मेरी हिंदी मोदी जी जितनी अच्छी नहीं है और विजय रूपाणी जितनी बुरी भी नहीं है इंग्लिश में तो मैंने पीएचडी कर रखी है लालू प्रसाद यादव इंटरनेशनल एकेडमी से तो मेरी आज की कोशिश हिंदी में रहेगी जब डॉक्टर आशीष पटेल और डॉक्टर प्रज्ञेश ने मुझे निमंत्रण दिया तो मैंने खुशी से सवाल पूछा कि तुम्हारी नजर मुझ पर कैसे पड़ी तो डॉक्टर आशीष ने कहा हमारी नजर तो बहुत ऊंचे थी लेकिन आखिरकार गिरी और तुम पर पड़ी पहले तो हम राहत फतेह अली खान या राहत इंदौरी जैसे किसी बड़ी हस्ती को आमंत्रित करना चाहते थे लेकिन फिर आखिरकार राहत दर से आने वाले किसी कवि से काम चलाने का हमने फैसला किया तो आप जैसे फैमिली फिजिशियन हो वैसे आप मुझे फैमिली कवि भी आपका समझ सकते हो तो डॉक्टर प्रज्ञेश डॉक्टर आशीष का कॉल आया कि इंडिया के इतने सारे डॉक्टर्स आपके सामने रहेंगे आपको लेक्चर देना है सब्जेक्ट क्या रखेंगे मैंने कहा कुछ भी रख लो वो एकदम इंप्रेस हो गए प्रभावित हो गए कहते क्या बात है रईस भाई तुम किसी भी सब्जेक्ट पर बोल सकते हो मैंने कहा हाँ जैसे पंजाबी रेस्टोरेंट में आप ऑर्डर कुछ भी दो सब्जी सेम ही आती है वैसे आप मुझे सब्जेक्ट कुछ भी दो मैं वही बोलूंगा जो मुझे आता है तो मेरा सब्जेक्ट है लाफ्टर क्लिनिक दोस्तों अच्छे वक्ता जो होते हैं वो महान ऋषि मुनि की तरह होते हैं हमारी संस्कृति में महान ऋषि इनको बोलते हैं जिनके आसपास अप्सराएं घूमती फिरती रहती है फिर भी वो उन्हें टच किए बगैर अपना तप पूरा कर लेते हैं ठीक उसी तरह सांप्रत काल में जो वक्ता अपने सब्जेक्ट को टच किए बगैर अपनी स्पीच पूरी कर लेता है वही महान वक्ता है तो मेरी ये सारी बातें सुनकर वो बहुत चिंतित होने लगे सोचने लगे कि यार इस कवि को बुला तो लिया पर ये क्या गुल खिलाएगा तो मैंने उन्हें आश्वासन देते हुए कहा कि चिंता मत करो मैं हूं ना तो पहले तो कहते हाँ हाँ ठीक है तुम हो ना फिर कहने लगे तुम हो इसीलिए चिंता है तो फिर मुझे भी शुद्ध गुजराती में कहना पड़ा कि समझવું નથી જે મને કઈ કશું પણ અમે એમને આજ સમજાવી દઈશું મગજની કમાનો હસે જેની ઢીલી ચડાવી અમે એને ચાવી દઈશું કે ઘણીવાર રેતીમાં ખેતી કરી છે ફસલ મુક જરોથી ઉગાવી દઈશું અમારી ઉપર આપ વિશ્વાસ રાખો હજારોને ઉઠા બનાવી દઈશું तो इतने सारे प्रज्ञेश भाई पोस्ट लंच सेशन में ही मेरा नंबर आता है ज़्यादातर और कभी भी मैंने कॉन्फ्रेंस में देखा नहीं कि इतने सारे लोग जागृत अवस्था में मेरे सामने बैठे हुए हों। तो आप सब फैमिली फिजिशियंस के लिए 4 पंक्तियां मेरी तरफ से। बिन पिए ही यहाँ कुछ लोग बहक जाते हैं, हो जो पैमाने अधूरे तो छलक जाते हैं, तुम में हीरे की सिफत है तो अंधेरे में मिलो, धूप में कांच के टुकड़े भी चमक जाते हैं। तो यहाँ पर कवि शायद ये कहना चाहता है कि एक्सरे और लैब रिपोर्ट की रोशनी में तो कोई भी कंसल्टेंट ट्रीटमेंट कर सकता है, अगर दम है तो फैमिली फिजिशियन की तरह अंधेरे में तीर चला कर देते। तो आप सब फैमिली फिजिशियंस के सामने मंचस्थ होना ये भी सर सौभाग्य की बात है। फैमिली फिजिशियंस जो कि एक एक पेशेंट को 2-2 मिनट में निपटा देने का महारत रखते हैं, उसके सामने मैं आधा घंटा टिकने की कोशिश करूंगा। संस्कृत में एक सर सुभाषित है, हस्ति हस्त सहस्रेण शतहतेन वाजिनः श्रृंगियो 10 हस्तेन स्थान त्यागेन कवि ही। हाथी से 1000 हाथ दूर रहना, घोड़े से 100 हाथ दूर रहना, सिंह वाले प्राणी से 10 हाथ दूर रहना, और जिस जगह पे कवि हो वो इलाका ही छोड़ देना। तो शास्त्रों में बगल थैले वाले प्राणी को इतना भयानक और खतरनाक समझा गया है, फिर भी आप शान से बैठे हो और ध्यान से सुन रहे हो, वो काबिले दाद भी है और मेरी समझ के बाहर भी है। आपने देखा होगा कि अपने हमारे समाज में, भारतीय समाज में, खास करके गुजराती समाज में कवि को थोड़ा नीची नजर से देखा जाता है। जिस नजर से अरब लोग यहूदियों को देखते हैं, जिस नजर से यूक्रेनियंस रशियन को देखते हैं, जिस नजर से तिब्बतियन लोग चाइनीज लोगों को देखते हैं, और प्रैक्टिस चल निकलने के बाद कंसल्टेंट लोग जिस नजर से फैमिली फिजिशियन को देखते हैं, और शादी के 8-10 साल बाद जिस नजर से पत्नी अपने पतियों को देखती है, समाज उसी तरह से कवियों को देखता है। पर सर सारे कवि ऐसे नहीं होते, दीपक भाई, यतीश भाई, सारे कवि ऐसे नहीं होते। मेरी बात मानिए दोस्तों, सारे कवि ऐसे नहीं होते। सिर्फ 99% की वजह से बाकी लोगों का नाम खराब होता है, बाकी कवियों का नाम खराब होता है। आज सुबह मैं ट्रेन से आ रहा था, आज डॉक्टर्स के सामने बोलना था, और हिंदी में कम ही बोलता हूँ, मैं गुजराती में बोलता हूँ, तो मैं थोड़ा टेंशन में था। मैंने सोचा क्यों मैं थोड़ा रिहर्सल कर लूँ। तो अपने बगल में जो पैसेंजर बैठा था उससे मैंने कहा कि मैं कवि हूँ। मेरी बात सुनकर उसने तुरंत ही कहा मैं बहरा हूँ। तो दोस्तों मैं कवि हूं, पर मैं आपसे वादा करता हूं कि मैं आज अपनी ज्यादा कविताएं नहीं सुनाऊंगा। अपने कान से अगर रुई आपने डाली हुई है तो वो निकाल लीजिए। आज का मेरा पैकेज जो है मेडिकल नहीं, कॉमेडिकल पैकेज है। मैं क्विक एक्टिंग एंड लॉन्ग लास्टिंग ह्यूमर का दवा दारू लेकर आपके सामने उपस्थित हूं, और वादा करता हूं कि मैं अपने शब्दों को सिर्फ थेराप्यूटिक डोज में प्रस्तुत करूंगा। उसके पहले कि वो लिथल हो जाए मैं एब्सकॉन्ड हो जाऊंगा। 4 पंक्तियां अर्ज करता हूं। थैंक यू, बजा लीजिए तालियां। दर्द सुनना या सुनाना हो तो हमसे मिलना, थोड़ा हंसने का इरादा हो तो हमसे मिलना, वैसे कई लोग मुलाकात के काबिल होंगे, तुमको खुद से कभी मिलना हो तो हमसे मिलना। अभी अभी डॉक्टर सर ने मेरा परिचय दिया, लगता है उन्होंने पहली ही बार पढ़ा, बहुत मतलब पढ़ भी रहे थे और अचंभित भी हो रहे थे। मुझे भी अच्छा लगा सुनकर, खुद हमने अपने प्रति सम्मान की भावना जागृत हुई। मुझे ऐसा भी लगा कि काश आज मेरी वाइफ सामने बैठी होती, उसको पता चलता कि उसका पति कितना बड़ा आदमी है। तो हालांकि परिचय मैंने ही लिख के दिया था। कभी कभी लाफ्टर परिचय से ही शुरू हो जाता है। एक जगह पर मेरा परिचय ऐसे दिया गया कि डॉक्टर रईस मनियार बड़े ही हास्यास्पद कवि है। चूंकि मैं कवि भी हूं, डॉक्टर भी हूं, तो कुछ लोग गुजराती में परिचय देते हुए कहते हैं, उनका भाव सर बहुत अच्छा होता है, लेकिन वो क्या कहते हैं कि डॉक्टर रईस मनियार बेवड़ा व्यक्तित्वना स्वामी छे। अब हमारे सूरत में बेवड़ा का मतलब बरोड़ा में चेवड़ा, हाँ यहाँ चेवड़ा का महिमा है, हमारे यहाँ बेवड़ा का महिमा है। यहाँ का चेवड़ा फेमस है ना। तो गुजराती में मैंने 2 पंक्तियां लिखी है। सूरत में छूहू वतनी, हमारे सूरत से डॉक्टर जयेंद्र भाई, डॉक्टर यतीश भाई, दीपक भाई सारे लोग आए हुए हैं, तो उनकी तरह मैं भी सूरत में छूहू वतनी एटले आ आड़ लागे छे। आड़ आरो एलिगेशन, सूरत में छूहू वतनी एटले आ आड़ लागे छे, शुभेच्छा पाठवुं छुं तोय सौने गाड़ लागे छे। अब जाणो છો કે આપણા ગુજરાતીઓની રસોઈમાં ગોળથી રસ આવે, પણ અમે સુરતીઓએ અમારી બોલીમાં રસ ઉમેરવા માટે આ ગોળ શબ્દ ગુજરાતીમાં લખાય ને, એ ગોળ ઉપરની માત્રા કાઢી નાખી છે। तो दोस्तों मैं डॉक्टर भी हूं, कवि भी हूं। यह अच्छी बात है कि आप अपने क्षेत्र के बाहर भी जाने या पहचाने जाते हो। जाहिरी तौर पर यह बेशक गौरव की बात है, लेकिन मेरी अंदरूनी बात यह है कि गुजरात के सारे डॉक्टर्स मेरे बारे में कहते हैं कौन रईस मनियार। डॉक्टर्स को अगर पूछो तो कहते कौन रईस मनियार, यार कवि अच्छा है। और हमारे सारे कवि मित्र कहते हैं कि यार डॉक्टर तो सही हो तुम। तो बात सिर्फ इतनी है कि दोनों फील्ड से एक्सक्लूजन की वजह से मैं एक्सक्लूसिव हुआ हूं। थोड़े दिन पहले किसी भाई ने मुझसे पूछा, जैसे लोग तरह तरह मतलब ज्यादातर कवियों की तरफ दया दृष्टि से देखते हैं, तो मुझे पूछा आप इस तरह से लेक्चर्स के बहाने, कविता के बहाने घूमते रहते हो अपना क्लिनिक छोड़ छोड़ के, सूरत छोड़ छोड़ के, तो आपके पेशेंट का सोचते नहीं हो? तो मैंने तो कुछ जवाब नहीं दिया, पर मुझे वो बात याद आ गई कि एक गांव में 2 डॉक्टर्स थे, डॉक्टर त्रिवेदी और डॉक्टर मेहता। उम्मीद करता हूं यहाँ पे कोई हो तो अच्छी बात है। डॉक्टर त्रिवेदी और डॉक्टर मेहता, एक गांव में 2 ही डॉक्टर थे, 2 ही काफी थे मोर्टालिटी रेट को बनाए रखने के लिए। तो एक दिन डॉक्टर त्रिवेदी और डॉक्टर मेहता स्मशान में मिल गए, किसी का अंतिम संस्कार चल रहा था। छोटे गांवों में ऐसी विजिट पर भी जाना पड़ता है ना। तो दोनों ऑब्वियसली खुश नहीं थे, क्योंकि ऐसी विजिट थी जिसमें विजिट फी मिलने वाली नहीं थी। तो अब देखिए डॉक्टर खड़े हैं दोनों ऐसे करके, सामने सीन देखिए, सामने वो मृतक जो है वो चीता पर जल रहा है। तो डॉक्टर त्रिवेदी ने डॉक्टर मेहता से पूछा, क्या इसको तेरी ट्रीटमेंट चलती थी? डॉक्टर मेहता कहता है, नहीं नहीं, मैंने सोचा तेरी ट्रीटमेंट चल रही होगी। डॉक्टर त्रिवेदी ने कहा, नहीं नहीं, मेरी भी ट्रीटमेंट नहीं चलती थी, तो ये मरा किस तरह? तो दोनों अचंभे में पड़ गए। पर सच्चाई ये है कि लोग कुदरती वजह से भी मरते हैं, हर मरण में अपना हाथ होना जरूरी नहीं है। डॉक्टर मेहता के एक पूर्वज थे, डॉक्टर नरसिंह मेहता, वो ऐसा कह के गए हैं, हूं करूं ये जग ज्ञान था। तो मेरी प्रैक्टिस भी कोई किडनी या कार्डियोलॉजी की तो थी नहीं, तो आत्मा से परमात्मा का मिलन करवाने का बहुत अवसर मुझे नहीं मिला। मेरी तो पीडियाट्रिक साइकोलॉजी की प्रैक्टिस थी, मतलब उनको चांस मिलता है, कार्डियक वाले को, किडनी वाले को आत्मा परमात्मा का मिलन करवाते वो। मेरी तो पीडियाट्रिक साइकोलॉजी की प्रैक्टिस थी भाई। हमारी साइकोलॉजी की प्रैक्टिस में क्या होता है कि हम चौथे कंसल्टेंट होते हैं। हमारा पेशेंट जो होता है ना, पहले 1-2 जोशी को दिखाता है, ज्योतिषी को, फिर 1-2 पड़ोसियों को दिखाता है, फिर 1-2 बूढ़ी दोषी को दिखाकर उनका सलाह मशवरा लेकर बाद ही हमारे पास आता है। हमारे पास आने तक पेशेंट की कुछ बीमारियां अपने आप ठीक हो जाती है और कुछ बीमारियां कभी ठीक ना हो ऐसी हो जाती है। इन दोनों स्थिति में मुझे कुछ खास करना नहीं होता है, इसलिए मैं ऐसे कार्यक्रम करता फिरता हूं। तो ये मेरी प्रैक्टिस की सच्चाई है। सूरत में मेरा क्लिनिक 2nd फ्लोर पे था, डॉक्टर साहब को पता है। ज्यादा दर्दी नहीं आते थे, सिर्फ अनपढ़ ही आते थे, समझदार आते ही नहीं थे। तो इसका कारण मुझे बहुत सालों के बाद पता चला। नीचे सीढ़ियों के पास मैंने बोर्ड लगवा के रखा था, ऊपर जाने का रास्ता। मेरी तरह मेरे एक गायनेकोलॉजिस्ट फ्रेंड की भी प्रैक्टिस नहीं चलती थी। उसकी वजह कुछ ऐसी थी, उसने अपने हॉस्पिटल के वार्ड में लिख के रखा था, जहां पे डिलीवरी होती है वहां पे लिख के रखा था, यहां बच्चों को आना मना है। मेरे एक सर्जन फ्रेंड ने अपने बोर्ड पे लिखा था, यहां हर प्रकार की सर्जरी की जाती है, बिल्कुल कम कीमत और कुशलता के साथ। बिल्कुल कम कीमत और कुशलता, दोनों कम। तो मेरे कार्डियोलॉजिस्ट फ्रेंड ने लिखा था, दूसरी जगह धोखा मत खाइए, एंजियोग्राफी यहां कराइए। धोखा खाना ही है तो मेडिकल प्रोफेशन में पहले एडवर्टाइज नहीं होती थी। अब तो मेरे घर के सामने एक बड़ा होर्डिंग है, होर्डिंग बदलता रहता है। कभी रशियन सर्कस की एडवर्टाइजमेंट होती है, कभी मलाइका अरोरा कपड़ों की एडवर्टाइजमेंट करती है, कपड़े निकाल के। कभी उसी होर्डिंग पर कार्डियोलॉजिस्ट डॉक्टर या नी रिप्लेसमेंट सर्जन भी दिख जाते हैं। तो आप कैसे भी सुपर स्पेशलिस्ट हो, विज्ञापन सबको एक लेवल पे लाके रख देता है। अब बहुत अच्छी तरह से सुन रहे हो। मुझे एक मेरा फेमस ह्यूमर आपको सुनाना है। वैसे नॉर्मली मैं गुजराती में सुनाता हूं, पर हाउ मेनी ऑफ यू आर नॉन गुजरातीज, आई मीन हु डोंट अंडरस्टैंड? या देयर आर 7-8 ऑफ देम, सो आई विल ट्राई इन हिंदी। तो आजकल भारत में हमारी उम्र के लोग कुछ पुरानी यादों को ताजा करने के लिए एक रियूनियन या एलमनाई बनाते हैं, ठीक है ना। अपना हमारा 83 का बैच था और किसी का 88 का बैच है, किसी का 2000 का बैच है। तो जब पुराने मित्र जो कभी बचपन में स्कूल लाइफ के बाद बिछड़ गए होते हैं, बड़े होकर जब एक दूसरे से मिलते हैं तो वो कितने बदल जाते हैं। एक कविता है इसके बारे में कि सब यार, डॉक्टर फिरदौस निखैया की 4 पंक्तियां है कि सब यार जिंदगी की मझधार में मिले। जब एलमनाई में मिलते हैं, सब यार जिंदगी की मझधार में मिले, साइकिल नसीब थी न जिन्हें वो सब कार में मिले। और बचपन की देखो मस्तियां कैसे बदल गई, कि बचपन की देखो मस्तियां कैसे बदल गई। कॉम्प्लान पीने वाले आज बार में मिले, कॉम्प्लान पीने वाले आज बार में मिले। और जो ढीले डाले थे सभी मेटल है आजकल। हमको ऐसा लगता था कि इसका क्या होने वाला है, इसका क्या होगा, ये कैसे सेट होगा। जो ढीले डाले थे सभी मेटल है आजकल, इंसान जो न बन सके केटल है आजकल। और रैंकर के बिक गए सभी मेडल कबाड़ में। जो रैंकर थे, रैंकर के बिक गए सभी मेडल कबाड़ में, और एटीकेटी वाले सभी सेटल है आजकल, और एटीकेटी वाले सभी सेटल है आजकल। तो ये होता है अक्सर रीयूनियन में। तो सूरत वाले अहमदाबाद जाते हैं, बड़ौदा वाले मुंबई जाते हैं, मुंबई वाले सूरत आते हैं। यहाँ तक तो ठीक है, लेकिन जो एनआरआई होते हैं वो भी दिसंबर महीने में वतन का ट्रिप लगाते हैं और कहते हैं कि हमारे बैच का रीयूनियन है। हाँ, तो इस सीजन में अगर एनआरआई को आप मॉल के बाहर देखो अटकते लटकते भटकते, तो आपको लगेगा कि अपनी पत्नियों को शॉपिंग करा रहे हैं, फोन पे टाइम पास कर रहे हैं, लेकिन अपने फोन पर वो बहुत इंपॉर्टेंट काम कर रहे होते हैं। वो सोशल मीडिया के समंदर में अपनी कुड हैव बीन वुड बी प्रेमिका की तलाश कर रहे होते हैं, कुड हैव बीन वुड बी प्रेमिका। तो आजकल तो दोस्तों जमाना है वैलेंटाइन डे का, फ्रेंडशिप डे का, है ना। हमारे जमाने में सिर्फ एक ही त्योहार स्कूल में धूमधाम से मनाया जाता था। मुझे लगा कोई भाई बोलेगा, लेकिन ये बहन की आवाज है बहुत बांधी लगती है उन्होंने। तो हमारे शिक्षकों को इतना उत्साह रहता कि क्लास में अगर 24 लड़कियां रहती तो हर लड़के के हाथ पे 24 रक्षाबंधी होती। वो चांस ही नहीं लेना चाहते थे। तो अभी अभी मेरे पड़ोसी के लड़के ने मुझे पूछा कि अंकल आपके जमाने में ब्रेकअप होता था क्या? मैंने कहा नहीं बेटा, हमारे जमाने में तो माँ बाप और शिक्षक ही ब्रेक लगा कर रखते थे। फिर भी खुदा ना खास्ता कभी हमारे जमाने में ब्रेकअप हो जाता तो प्रेमी बेचारा देवदास हो जाता था। आजकल के जमाने में ब्रेकअप होने पर कोई उदास भी नहीं होता, क्योंकि ब्रेकअप होने पर बैकअप रेडी ही होता है। तो आजकल एक शब्द अंग्रेजी, पहले इंग्लिश में एक शब्द है, मैंने पहले सुना नहीं था, अभी आजकल सुना है मैंने, क्रश। क्रश बोलते हैं। हाँ, क्रश का मतलब क्या है? आपको अगर किसी से मोहब्बत है, आप में उसे बताने की हिम्मत या सहूलियत या ताकत या औकात नहीं है, इंसान मन ही मन में क्रश रखता है। तो ये क्रश शब्द भले ही आजकल का हो, लेकिन ये भावना असल हमारे जमाने की। हमने तो अपनी पूरी जवानी क्रश रखे रखे ही बिता दी। हमको वो अच्छी लगती थी, उसको भी शायद हम अच्छे लगते थे, कह नहीं पाई एक दूसरे से। उधर उसकी भी शादी हो गई, इधर हमारी भी शादी हो गई, दिल टूटे और आवाज भी नहीं आई। कमबख्ती तो ये थी कि कभी कभी अपनी मनपसंद लड़की की पत्रिकाएं बांटने हम चले गए। कभी कभी उसकी ही शादी में समूह भोजन में दाल का कमंडल लेकर पूरी बारात में घूमे। तो सब अपने अपने क्रश को याद कर लीजिए और ये सत्य घटना सुनिए जो मेरे साथ अभी अभी घटित हुई। मैं अभी तो 48 साल का हूं, 48 साल की मेरी उम्र है, 48, 10 सालों से मैं 48 साल का हूं। सिंस लास्ट 10 ईयर्स मैंने सत्य पकड़ के रखा है। तो हम भी कभी रोमांटिक थे, अभी तो हमारा रोमांटिक है। लेकिन मेरी ये कथा सुनिए, रोमांटिक कथा सुनिए। मेरे पड़ोसी हसू भाई ने एक दिन आके मुझे पूछा, रईस भाई तुम्हें वो जलपाड़ी याद है? जलपाड़ी। मैंने कहा कौन सी जलपाड़ी? अब देखो हिंदी में गांधी को गांधी जी कहते हैं, गांधी नहीं कहते, गांधी जी। मोदी को मोदी जी कहते हैं, यानी सम्मान के लिए जी प्रत्यय लगाया जाता है। इसी तरह से गुजराती में लड़कियों को सम्मान देने के लिए रेखा को रेखाड़ी, आशा को आषाढ़ी, हाँ, कल्पना को कल्पनाड़ी, ऐसे बुलाया जाता है। गुजराती कोई फ्रेंड हो आपकी, ऐसे कहना मत, नॉन गुजराती है बेचारे बोलेंगे फिर। तो हमारी जलपा को भी हम जलपाड़ी कहते थे। तो मेरे पड़ोसी हसू भाई ने क्या पूछा मुझसे कि रईस भाई तुम्हें वो जलपाड़ी याद है? मैंने कहा यार कौन सी जलपाड़ी? तो हसू भाई कहने लगे, अरे वो जो 7वीं कक्षा में किसी और स्कूल से ट्रांसफर लेकर हमारे क्लास में आई थी, हमारे सभी दोस्तों की सार्वजनिक स्वप्न सुंदरी। सार्वजनिक पर हंसी आई आपको? दोस्तों सही बात यह है कि इंसान जो है ना बचपन में निस्वार्थ होता है, उसके अंदर सेल्फिशनेस, जेलसी, कंपटीशन की भावना वगैरह बिल्कुल नहीं होता। बड़ा होने के बाद इंसान स्वार्थी हो जाता है, कहने लगता है मेरी प्रेमिका, मेरी पत्नी, मेरे बच्चे, मेरा परिवार, मेरी संपत्ति, मेरा मेरा करने लगता है। बचपन में कुछ तेरा मेरा नहीं होता आशीष, है ना। जब इमेजिन करिए कुछ लड़के, जैसे हम लोग जीएमसीएस वाले थे, गवर्नमेंट मेडिकल, तो एक कॉलेज की लॉबी में खड़े रहते थे और लेक्चर के लिए लड़कियों का आने का टाइम है, तो लड़कियां भी लाइन लगाकर आराम से आती है, नीची नजर से वहां से गुजरती है, लड़के लॉबी में खड़े हैं देखने के लिए, दर्शन के लिए। तो हाँ, और लड़कियां भी अक्सर धीरे धीरे जाती थी जिससे कि देखने वाला उनको आराम से देख सके। तो लड़कों की इस प्रवृत्ति को समाज चाहे कुछ भी घटिया नाम दे, पर मैं तो साहित्य का सेवक हूं, मैंने इस प्रवृत्ति करने वाले जाबाजों को एक सम्मानीय नाम दिया है। मैंने कहा है कि ये सारे नयन सुख साथी है, नयन सुख साथी, यानी साथ में मिलकर इन्होंने नयन का सुख लिया है। तो कोई भी दो, समझ लीजिए मैं और अशेष या मैं और हसू भाई, कोई भी दो नयन सुख जो साथी होते हैं, कभी कभी दोनों एक ही लड़की को पसंद करते हैं, लेकिन उनको कभी आपस में जेलसी नहीं होती, उनके बीच कभी कंपटीशन नहीं होता। उनके बीच कोई सेल्फिशनेस नहीं होती। वो जानते हैं कि भाई तुझे भी नहीं मिलने वाली, मुझे भी नहीं मिलने वाली, तो रहने दो ना सार्वजनिक। तो ये सार्वजनिक, इस तरह से हमारी जलपाड़ी सार्वजनिक स्वप्न सुंदरी थी। तो हसूभाई की बात से मुझे भी एकदम से याद आ गया कि हाँ, छठी क्लास तक हमें भी सपने में भूत पलित आते थे, डरावने पशु आते थे, चोर डाकू के सपने आते थे। जब किसी स्कूल से, किसी दूसरे स्कूल से ट्रांसफर लेकर एक बार जलपा हमारे क्लास में आई तो जलपाड़ी के सपने आना शुरू हो गए। सपनों का पूरा जॉनर बदल गया। हम सारे के सारे वानर अचानक नर हो गए। डार्विन कहता था कि वानर से नर बनने में 1 लाख साल से ज्यादा समय लगा, लेकिन हम लड़के लोग जानते हैं कि क्लास में जब कोई अच्छी लड़की आती है तो रात ही रात सारे वानर नर हो जाते हैं। तो मैंने हसूभाई से कहा, यार अब इतने सालों के बाद 30-35 साल हो गए, 40 साल हो गए, अब जलपा को याद करने से क्या फायदा, क्या वजह है? हसूभाई ने कहा, रईस भाई मेरी बात तो सुनो, कल मैं किसी अवसर पे गया था, वहां पे बुफे डिनर था, तो मैंने गुलाब जामुन के काउंटर से 4 गुलाब जामुन लिए। वहां पर एक मेदस्विनी स्त्री थी, जाड़ी तो नहीं कही हमें, हम कहते हैं मेदस्विनी। तो वहां पे एक मेदस्विनी स्त्री थी, उसने भी 4 गुलाब जामुन लिए। 15 मिनट के बाद मैं रिफिल करवाने गया, मैंने 4 गुलाब जामुन लिए, तो वो मेदस्विनी स्त्री भी वहीं खड़ी थी, उसने भी 4 गुलाब जामुन लिए। फिर मैंने फुल खाना खा लिया, मैंने देखा कि मेरा पेट तो पूरा भर गया है, पर अभी अन्न नली में थोड़ी सी जगह बाकी है। तो मैं गुलाब जामुन के काउंटर पे वापिस से गया, 4 गुलाब जामुन लिए, वो मेदस्विनी भी वहीं थी, उसने भी 4 गुलाब जामुन लिए। तो मैंने कहा, हमारे ख्यालात कितने मिलते जुलते हैं। मैंने उसे स्माइल दिया, उसने भी मुझे स्माइल दिया। गुलाब जामुन हलक से उतरने के बाद मैंने उससे पूछा, आप कहां से हो, किस गांव से हो, किस कॉलेज में पढ़ते थे, कौन सा स्कूल था? ये सब पूछने से पता चला कि वो मेदस्विनी स्त्री अपनी ही स्कूल से थी। हसूभाई ने कहा, तो मैंने कहा, हमारे क्लास में तो ऐसी कोई मेदस्विनी थी ही नहीं। अपने क्लास में तो सारी की सारी स्लिम एंड ट्रिम थी, सारी की सारी क्यूट थी। कोई और क्लास से होगी। नाम पूछा उसका, और फिर मुझे अपना भी सेल्फिशनेस, क्या वो जलपा को जानती थी? हसूभाई ने कहा, अरे यार, उसको सीधे सीधे तो मैं कैसे पूछ सकता था कि तुम जलपा को जानती हो? तो मैंने उस स्थूल देहधारिणी सहध्यायिनी को पूछा। किसको? स्थूल देहधारिणी सहध्यायिनी को इनडायरेक्टली पूछा कि तुझे अपनी स्कूल का कुछ याद है? वो तुरंत कहने लगी, हाँ हाँ, हमारे क्लास में एक बड़ा ही गिलिंडर लड़का था, हसू नाम था उसका, शैतानी बहुत करता था पर बड़ा स्वीट था। मैंने कहा, अरे फिर तो तुमने बताया कि नहीं मैं हूं वो स्वीट हसू? हसूभाई कहने लगे, अरे ऐसा मैं कैसे कहता, वो शर्माना जाती बेचारी। तो फिर बातों बातों में मैंने उससे पूछा कि जलपा का कोई अता पता है? उससे पहले कि हसूभाई उसका जवाब सुनाए, मेरे मुंह से निकल गया कि जलपा का कोई अता पता नहीं है। क्योंकि मैं भी अपनी फुर्सत के पलों में जलपा को ढूंढने के लिए फेसबुक, इंस्टाग्राम, ट्विटर, गूगल, मैरिज ब्यूरो, पुनर्विवाह, सारी की सारी जगह छानबीन कर चुका था, पर कहीं जलपा मुझे मिली नहीं थी। हाइट ऑफ ऑप्टिमिज्म देखिए, मैंने पुनर्विवाह में भी उसको ढूंढ लिया, पर जलपा नहीं मिली। तो हसूभाई कहने लगे, रईस भाई, वो हमारी ड्रीम गर्ल, वो हमारी धक धक गर्ल, ड्रीम गर्ल और डक डक गर्ल जैसे विशेषण को सुनकर मैं भी कल्पना की दुनिया में खो गया, विहार करने लगा। 50 साल की हो गई होगी हमारी जलपा, हाँ? पर आज भी माधुरी या डिंपल से कम तो नहीं होगी। अब देखिए, परम कृपालु भगवान ने कुदरती संपत्ति की समान भाग बटाई के नियम के अनुसार हर स्कूल के हर एक क्लास में ऐसी एक सुंदरी अलॉट की होती है। गुजराती में कहते हैं कि दरेक क्लास में આવી एक सुंदरी ફાળવવામાં આવી હોય છે, जिसकी वजह से शिक्षण सह्य बनता है। ये सह शिक्षण नहीं होता, ये सह्य शिक्षण होता है। हसूभाई उत्साह से कहने लगे, रईस भाई, मैंने तो सोच भी लिया कि अगर आज जलपाड़ी का कांटेक्ट मिल जाता है, उसका अगर फोन नंबर मिल जाता है, तो हम हमारे क्लास का एल्यूमिनियम बना ही देते हैं। मैंने कहा, एल्यूमिनियम नहीं भाई, एलमनाई कहते हैं उसको। हाँ हाँ, वही जो भी हो, जरा सोचो तो सही, अगर जलपाड़ी का आज पता मिल जाता और हमारा एल्यूमिनियम बन जाता, तो ये एल्यूमिनियम हमारी पत्रे जैसी जिंदगी का गोल्डन पन्ना बन जाता कि नहीं? मैं भी उत्साह में आ गया, यार बात तो सही थी। जिंदगी के इस मुकाम पे अगर जलपा का जलवा फिर से मिल जाए, तो रोज सुबह फिर उसको गुड मॉर्निंग, रात को गुड नाइट, शाम को खाना खाया और वक्त बेवक्त क्या कर रही हो, ऐसे मैसेज करते, हाँ, जिंदगी गुलजार हो जाती। और उत्सुकता और आवेगवश मैंने भी पूछा, क्या हुआ फिर? मिला जलपा का फोन नंबर? उस मेदस्विनी को जलपाड़ी के बारे में कुछ पता था? हसूभाई ने इमोशनल होकर कहा, पता ना होता तो ही अच्छा था। मैंने कहा, ऐसा अशुभ अशुभ क्यों बोलते हो? हसूभाई ने कहा, उस 120 किलो वजन वाली मेदस्विनी ने कहा, मैं ही जलपा हूं। मैं शौक में आ गया। मैंने कहा, हसूभाई क्या बात कर रहे हो? घिन आती है तुम पर, तुम हमारी हमारी जल्पा को नहीं पहचान पाए, रात दिन मिलकर जिसके सपने देखे, उस जल्पा को आप पहचान नहीं पाए, डूब मरो। हसू भाई की भी सूरत रोने जैसी हो गई। भरी हुई आवाज में उन्होंने एक उपमा दी, रामायण की उपमा दी। जैसे रामायण में वालिया लुटेरा 12 साल तप करने के बाद वाल्मीकि बना, तब उसका सारा शरीर दीमक की परत के नीचे, उदय दीमक के थर के नीचे दब गया था और वो पहचानने के लायक नहीं रहा था। उसी तरह हमारी जल्पा भी चर्बी के मोटे से लेयर के नीचे अदृश्य हो गई थी, अदृश्य हो गई थी। हाँ, उसी 120 किलो के चर्बी के पहाड़ के अंदर कहीं नाजुक हमारी 45 केजी वाली जल्पा थी, अंदर ही थी, लेकिन नजर नहीं आती थी। फिर हसू भाई कहने लगे, रईस भाई हमारी ड्रीम गर्ल अब ड्रीम गर्ल नहीं रही, हमारी ड्रीम गर्ल अब ड्रम गर्ल बन गई है। अब ऐसा तो कह नहीं सकते कि जिसको हम जलपाड़ी कहते थे, जिसको हम जलपाड़ी कहते हैं, उसी के आगे से जल निकल गया और सिर्फ, ऐसा तो कह नहीं सकते। हसू भाई कहने लगे, रईस भाई फिर से सपने में भूत पलित डरावने पशु और चोर डाकू आने लगे हैं। मैंने कहा, लेकिन आखिरकार तुमने बताया कि नहीं मैं ही वो हसू हूं जो तुम्हें बहुत स्वीट और क्यूट लगता था। हसू भाई बोले, अरे उससे पहले कि मैं उसे बताने जाऊं, वो खुद कहने लगी कि हमारे क्लास में जो हसू था ना, उसके एक दादाजी थे, एकदम बूढ़े, सर पे बाल नहीं, मुंह में दांत नहीं, चेहरे पे झुर्रियां, बस आपकी तरह एकदम गए गुजरे लगते थे। तो उम्मीद करता हूं कि आप सब लोगों को मेरी ये प्रस्तुति पसंद आई हो। कितने मिनट से? 5 मिनट से तो है ना, 5 मिनट है ना। हाँ, तो आज इस 5 स्टार में मैं हूं, तो मुझे याद आता है कि मैंने भी 5 स्टार शादी की थी सर। 5 स्टार अपनी पत्नी को 5 रुपये वाला 5 स्टार चॉकलेट खिलाया था और फिर कोर्ट में सस्ते में शादी की थी। तो मैंने शादी कब की थी मुझे याद है, शादी कहाँ की थी वो भी बराबर याद है, शादी किस तरह से की थी वो भी याद है, शादी में कौन कौन आया था वो भी याद है, और शादी किसके साथ की थी वो भी हल्का हल्का धुंधला धुंधला याद है। पर शादी क्यों की थी नहीं आ रहा। अरे यार, मेरी शादी की पत्रिका जिसने छापी थी, जिसने प्रिंट की थी, वो कोई सीधा साधा प्रिंटर नहीं था, वो बहुत बड़ा ज्योतिषी था, भविष्यवेत्ता था। मुझे बाद में पता चला, मैं उसके पास गया, जब मेरा मैरिज था शादी की पत्रिका के लिए, उसने सैंपल की पत्रिकाएं दिखाई, सारी की सारी लाल रंग से आभूषित थी। अब मुझे एकदम से विचार अब आ रहा है कि पत्रिका लाल रंग की होती है, रेड सिग्नल के समान होती है। गौर महाराज भी बार बार सावधान सावधान बोलते हैं, फिर भी विवाह उत्सुक पुरुष संभल क्यों नहीं जाता।
हेलो,
तो मैंने एक पत्रिका सिलेक्ट की सर, और उसके अंदर की जो डिटेल थी वो मैंने दे दी, और उसने मुझे पूछा कि रईस भाई फ्रंट पेज पे क्या लिखे, टाइटल पे क्या लिखे। मैंने कहा पत्रिका पे शुद्ध हिंदी में विवाह लिख दो। उसने पूछा सिर्फ विवाह, शुभ अशुभ आगे कुछ लिखना नहीं। मैंने कहा शुभ अशुभ तो भगवान के हाथ में, तुम सिर्फ विवाह लिखो। हंसो मत यार, मेरी बात एकदम तार्किक है। आप शादी विवाह के लिए किसी प्लॉट पे जाओ, किसी वाड़ी में जाओ, तो वहां पर एक एडवर्टाइजमेंट का बोर्ड होता है, वहां पे लिखा रहता है शादी विवाह तथा शुभ प्रसंगों के लिए हॉल भाड़े से मिलेगा। अगर शादी विवाह भी शुभ प्रसंग है तो शादी विवाह तथा शुभ प्रसंग लिखने का क्या मतलब था। ऐसे लिख सकते हो कि शोक सभा तथा शुभ प्रसंग, तो लॉजिक है। हाँ, उसको ब्रैकेट के बाहर निकालने की क्या जरूरत। तो मेरे मन में डाउट था कि ये शुभ है कि नहीं। ठीक है, तो उसने भी बोला कि सिर्फ विवाह भी अच्छा लगेगा, एकदम मॉडर्न एकदम लगेगा। तो मैंने दूसरे दिन उसका कॉल आया, बोला रईस भाई पत्रिका तैयार है। 1000 पत्रिका का बंडल पड़ा हुआ था, उस पर एक पत्रिका खुली पड़ी हुई थी। उसने बढ़िया पत्रिका प्रिंट की थी, मैं भी खुश हो गया। अपने स्वभाव से विरुद्ध मैंने सोचा कि बिल में बार्गेनिंग नहीं करूंगा, 1000 रुपया खाली कम कराऊंगा और ऊपर से 500 रुपया मैं टिप का दूंगा। तो जो एक पत्रिका खुली पड़ी हुई थी उस पर मेरी नजर पड़ी। मैंने बोला था टाइटल में विवाह लिखना, और उसने विवाह शब्द में, शब्द जो होता है उसमें हिंदी में लिखा था, आखिरी शब्द ह के बदले द छाप दिया। तो मैंने बोला ये क्या है, विवाह के बदले उसने विवाद छाप दिया। मैंने बोला ये क्या है, वो बस स्पेलिंग मिस्टेक हो गया। जरा सा माइनर सा है। मैंने बोला जरा सा है, हाँ सर हिंदी में ह और द एक जैसा होता है ना, टाइपिंग में थोड़ा इधर उधर। मैंने बोला ये मिस्टेक सिर्फ एक ही पत्रिका में है कि पूरे बंडल में है? बोला ये तो ऑफसेट प्रिंटिंग है, सारे में है। मैं अपसेट हो गया, मैंने कहा कमबख्त है, तूने क्या कर दिया, मेरा पहला और आखिरी विवाह है, इसको तूने विवाद बना दिया। बोले ठीक है, इसमें इतना गुस्सा करने वाली क्या बात है, छोटी सी बात है, एक अक्षर की तो गलती है। मैं चिल्लाया इसको तुम छोटी गलती कहते हो, पूरा का पूरा मीनिंग बदल गया। बोले अरे भाई इतना भड़कते क्यों हो, क्या अनर्थ हुआ है, आपका विवाह तो एक दिन है ना, फिर तो बाकी सारी जिंदगी विवाद ही है ना। तो वो भविष्यवेत्ता था, उसे शायद पता था कि ये विवाह नहीं ये विवाद है। तो शादी हो गई, बस बदकिस्मती से कोई विघ्न नहीं आया। चलो गलती से सही बोल दिया मैंने। तो कन्या विदाई का समय आ गया, बैंड बाजे वाले ने गाना शुरू कर दिया। कौन सा गाना? दिल में छुपा के प्यार का तूफान ले चले। जयेंद्र भाई आप जानते हो दिलीप कुमार मेरा कितना फेवरेट है। मैंने सोचा जयेंद्र भाई जैसे कोई दोस्त ने 50 रुपया टिप देके गाना बजवाया तो मैं खुश हो गया कि दिल में छुपा के प्यार का तूफान ले चले। कन्या आन बान और शान से विदा हो रही थी और आन फिल्म का गाना बज रहा था। लेकिन जब जैसे दूसरी लाइन सुनी मेरा कलेजा कांप उठा। दिल में छुपा के प्यार का तूफान ले चले, कन्या विदाई पर हम आज अपनी मौत का सामान ले चले, हम आज अपनी मौत का सामान ले चले। थैंक यू वेरी मच, बहुत अच्छा लगा आप लोगों से मिलके। डॉक्टर प्रज्ञेश, जितने भी सारे एफपीए के मेंबर्स हैं सबका मैं आभारी हूँ। बहुत अच्छा लगा, बहुत सालों के बाद किसी कॉन्फ्रेंस में काफ़ी समय बैठकर मैंने लेक्चर्स सुने एंड आई वुड गो टू द एक्सटेंट टू से दैट बहुत अच्छे लेक्चर्स थे जो भी मैंने सुने। तो सारे जितने स्पीकर्स हैं उनको भी मेरी तरफ से धन्यवाद। और मुलाकातें हमेशा वक्त की पाबंद होती है, मोहब्बत एक खुशबू है हमेशा साथ रहती है। जो बातें बाकी रह गई है कभी दूसरी बार मौका मिला तो फिर मिलेंगे। थैंक यू वेरी मच। हंसी और खुशी की ये सौगात होगी, नए लोग होंगे, नई बात होगी। मुसाफिर है हम भी, मुसाफिर हो तुम भी, किसी मोड़ पर फिर मुलाकात होगी। थैंक यू वेरी मच।
Thank you so much, sir. It was very entertaining. I would honor the chairperson to, I would request the chairperson to honor Dr. Rais, sir. It is my pleasure to invite Dr. Pankaj Khandelwal, sir, who will enlighten us on bariatric surgery, boon or bane. And I request chairperson to introduce the esteemed speaker.
Slide changer. ना बस अभी ये स्लाइड चेंजर मेरा लगा दिया, आपका लगा हुआ है स्लाइड चेंजर? तो स्लाइड चेंजर दे दो ना।
हेलो हेलो,
हाँ स्लाइड चेंजर एक्चुअली वही भेज रहा था।
Good afternoon, friends. Now we have among us Dr. Pankaj Khandelwal. He is a senior and renowned laparoscopic surgeon and now a very good name in bariatric surgery in the city of Vadodara. Please.
ગુડ આફ્ટરનૂન એવરીબડી. હમણાં રઈસભાઈએ બહુ સરસ જ બહુ સારી આપણી લાફ્ટર ક્લિનિક ચલાવી. એમાં એક વસ્તુ હું કહી શકું છું કે હસુભાઈને તો અમે બદલી નથી શકતા, પણ જલપાડીને ડેફિનેટલી જલપા બનાવી શકીએ છીએ.
હું છે ને આ સત્ય ઘટના છે. જલપાડી એકચ્યુઅલી આ રીતે જ મળેલી. હસુભાઈ કોઈ હતા નહીં, મને જ મળેલી. જલપાડીએ મને ફોન નંબર આપ્યો. હું કાપલી લઈને આવ્યો ઘરે અને મેં મારી વાઈફને આપી કે આ મારી 6ઠા 7મા ધોરણવાળી જલપાડી, અને એણે ફોન નંબર આપ્યો છે. તો મને એમ કે મેં બધી જ વાત કરી 120 કિલો આ તે બધું, તો એણે ફોન નંબર ફાડી નાખ્યો. મેં કહ્યું શું કામ ફાડી નાખ્યો, તું કેમ ઇનસિક્યોર? કે બેરિયાટ્રિક કરાવી દેતો.
Bariatric surgery has been there for a very long time, more than 70 years now. And in spite of that, we find that there is still a lot of controversy. People think that it isn't a boon and it's a bane. So what I'll do is I'll just go through a few case scenarios. But before we do that, I'll just like to talk about what's boon. Boon means that anything that is helpful, beneficial, improves your quality of life or is a blessing. And bane is something which is a distress, which causes a continuous trouble or unhappiness. So based on these two definitions, we'll just go ahead and see. Now this was a 44-year-old lady who presented to us with diabetes over 23 years, all types of medications, resistant to insulin, and in spite of that her HbA1c remaining at 11.9. Hypertension for 15 years, all medications going on, and still an uncontrolled blood pressure. To make matters worse, she had undergone angioplasty, she had undergone a coronary artery aneurysm coiling, diabetic foot, polyneuritis. You name the complication of diabetes and she had it. Diabetic retinopathy with almost loss of vision in the left eye, right eye vision significantly reduced, and she was referred to a retinal surgeon who said that the diabetes and the blood pressure have to be controlled before taking her up for a surgery, and since medical management was not possible, she was referred to us. So we went ahead and did a loop DJ with a sleeve gastrectomy, which is a strong metabolic surgery for her, in which we do a sleeve gastrectomy and bypass simultaneously. Now, after a year, her weight had reduced to 57 kg, blood pressure was normal, her HbA1c had reduced to 6.1, no antihypertensives were required, oral antidiabetic, only one medication, and she was operated for retinal surgery and her vision improved. So whether we call this surgery a boon or bane for us is something which we ourselves need to decide. This is another case, and this is, you can see this huge ulcer. This patient had this huge ulcer for 17 years. He had met all plastic surgeons, vascular surgeons, and it wasn't getting better. And one of the major reasons was the weight, 175 kg, diabetic, hypertensive, hypothyroid. And his life was a misery. He couldn't live a normal life at all. Now, after we operated, that is him after 1.5 years, 3 months to 4 months down the line, his ulcer had healed, his weight reduced by 1.5 years to 102 kg, the diabetes and the blood pressure went off. And he has been able to live a fairly normal life after that. So again, I would ask you whether this surgery was a boon or bane for him. Now, all the cases we operate don't have a very smooth ride. Some of the patients are going to have a little bit of a rough ride. So I'll just show you a couple of cases where the ride was rough. Like this particular patient, she came from Australia. She had been struggling with obesity for more than a few years, 105 kg weight. We did a sleeve gastrectomy for her. Now she had a post-operative bleed and we had to go back in and do a diagnostic laparoscopy, evacuation of the clot. Less than 1% of the patients are going to have that. She comes back after a week of discharge and she has vomiting. We do a CT scan to find a leak and we have to place a stent. So 1% of the patients develop either of the two complications, and here I had one patient who had both the complications. She had an uneventful recovery after that and went home, and that is her before and after the surgery. Now, unfortunately, she was the niece of a very, very close friend of mine. And I met her again after a year, and I asked her, "Kevu lage che tane? Do you feel happy?" So she said, "Sir, after the weight loss and my looks, I am more confident, I can manage my family better, and I am living a better quality of life." So yes, she had pain. She had trouble for a short time, but in the long term, when you see her, it was a boon for her. Similarly, another case, see, I am talking about these complications to show you that there can be short-term problems, but in the long term, all these patients have a significant improvement of quality of life. This was another lady, we did a DJB sleeve, and she had a leak. We had to do a diagnostic laparoscopy, then go back in, do a gastric bypass, and she was fine after that. Now, she was struggling with her diabetes, pseudo-Cushing's, weight was 87, BMI 38, uncontrolled diabetes, and to make matters worse, she developed NASH. And that was the reason she came up for the surgery. Post-operatively, a year after the surgery, her weight had dropped to 62, HbA1c was 5.6, and the fatty liver had reversed. So again, she had problems after the surgery, but when you see in the long term, it was a bane to begin with, but ultimately a boon. Bariatric surgery has been there for more than 70 years, but there were three major milestones. The first was in 1966, when the gastric bypass was done for the first time. So that's going back more than 55 years. The second was in 1997, when the mini gastric bypass was started, and in 2002, when the sleeve gastrectomy was started. When I started bariatric surgery in 2005, we had only three options for the surgery: a Roux-en-Y gastric bypass, a BPD, or a gastric band. I never liked the gastric band, so I never did the gastric band. It was a very simple surgery. 2013 guidelines, the sleeve gastrectomy was also added to it. And presently, this is the gamut of bariatric surgeries which are available. So a huge number of surgical options are available, but three procedures remain the mainstay: the sleeve gastrectomy, the gastric bypass, and the one anastomosis gastric bypass or the mini gastric bypass. So when we look at the world trends, in 2008, about 3.5 lakh cases used to be done in the world. In 2018, there were about 7 lakh cases which were being performed. And sleeve has become, the green line which you see is the sleeve gastrectomy, which has become the commonest procedure, and the Roux-en-Y gastric bypass has reduced from the commonest to about 30% of the cases. And when we see the further trends, we find that sleeve gastrectomy remains the most common procedure over the years because of its low complication rates and fairly good results. So Roux-en-Y gastric bypass has its sets of advantages and its set of complications. The sleeve gastrectomy has its significant advantages, and the only major problem which I've seen, I've done more than 1,000 sleeves now, the only problem I've seen with it is a reflux disease problem, which most of the times can be managed by medications. And the mini gastric bypass, again, with fairly good results. Now, there have been 2 trials which have looked at patients over a long term. The sleeve plus trial, which is considered as one of the hallmark trials, which looked at patients for 10 years, sleeve versus a bypass. And at the end of that, they found that the weight loss is not significantly different. And when you look at the comorbidities, there is no statistically significant difference between the two. Only in hypertension, the gastric bypass over a 10-year follow-up scores more than the sleeve. Similarly, there is this Y-omega trial, which is a 5-year trial, which compares the mini gastric bypass, commonly called in India, also called as one anastomosis gastric bypass, to the RYGB. And here also we find that both of them at the end of 5 years are almost similar, except that in the mini gastric bypass, some patients will have reflux problem, which is less commonly seen in the gastric bypass. And about 8% of the patients of mini gastric bypass will require a conversion to a Roux-en-Y gastric bypass. So the question comes down to which of these surgeries are best. Almost all of them are equivalent over a 10-year follow-up. In a 10-year follow-up, it doesn't make any significant difference as to which one you perform. It's more or less based on discussion with the patient, what the patient preferences are, and the decision can be taken. Now, we always have been talking about diabetes, hypertension, weight loss. But are there other things where we find bariatric surgery to be beneficial? So this was a trial, the SWIFT trial, which looked at patients with osteoarthritis, and they found that a large number of patients, there was a significant symptom relief, and 20% of the patients did not require a knee replacement after the weight loss. The second issue we find is obesity-associated fertility issues. So when you look at the female problems associated with obesity, PCOS reduces from 45% to 7%, menstrual irregularities from 56 to 7%, and infertility from 18% to 4%. Now, one very important thing is we talk about treatment. The second thing is also talking about prevention of a disease. So when you have pre-diabetic patients, and if I don't operate them, over a 15-year follow-up, you find that 69% of obese patients pre-diabetic will get diabetes. Similarly, when they are operated, only 6.7% of these patients will become diabetic. So it's not only for treatment, it can be also very good for prevention. And here, the gastric bypass gives us better results than the sleeve. Now, NASH we have all been talking about for many years now, and it is nowadays called as MASLD, and obese patients have 85% prevalence, diabetic 30 to 75%, metabolic syndrome 50%, and the disease progresses in 20% of these patients to MASH, and 20% of MASH patients go to cirrhosis. So what happens when you operate on them? If patient has only steatosis, then it gets resolved in 63% and same in 27%. When there is steatohepatitis, it resolves in 90%. And patient, when they have fibrosis, you don't get a resolution, you would get just some improvement. Another aspect is cancer. We all know that obesity leads to higher incidence of cancer. When bariatric surgery is performed, the incidence of cancer reduces. So I've given all these examples, I've talked about the benefits. So the point comes as, is bariatric surgery boon or bane? So what is the truth of life? जिंदगी का सत्य क्या है? क्या कोई भी ऐसी चीज़ जिंदगी में होती है जो सिर्फ फ़ायदा दे? जो आप अपने मेडिसिन्स पेशेंट्स को देते हैं, क्या उसके साइड इफ़ेक्ट नहीं है? जब आप ऑपरेशंस करते हैं तो क्या उसके कॉम्प्लिकेशंस नहीं है? इसी तरह से ज़िंदगी में कोई ऐसी चीज़ नहीं होती जो सिर्फ आपको फ़ायदा देगी. हर चीज़ जो फ़ायदा देती है वो कहीं ना कहीं थोड़ा बहुत नुकसान देती है. और बेरियाट्रिक सर्जरी व्हाट वी फाइंड इज इट गिव्स लॉन्ग टर्म boon. There can be short term bane. The problems of obesity are these many. If the problems of surgery come, they can be very, very less, and most of them can be managed by medications or conservatively. Thank you very much. Sir, since we were talking about bariatric surgery and you just talked about boon or bane, I think surgery is not the only answer. There are so many things related before performing a bariatric surgery so that it becomes a boon, not a bane. Can you shed some light that what things to be taken care of before surgery and after surgery, where we as family physicians can take a active role in that? Yes. See, there are few things which patients have to understand very well. Patients come with an expectation that when the surgery is performed, they can keep on eating and drinking everything and keep on not taking any care, and the weight will be maintained. They would have to have certain modifications. But the surgery takes care of 80% of the issue. The surgery does not allow them to have volume eating. Their eating sizes reduce significantly. As long as they can take care that the high calorie intake is lesser, they will not have problems. The second thing is they are going to develop certain deficiencies like B12, D3 deficiencies. In the first 1.5 years, they can develop protein deficiencies. So we tell all of them that they will have to take supplements throughout their life, and they would also need to get yearly blood checks done to make sure that they aren't developing any deficiencies or any problems related to the bariatric surgery. It's a 45-minute consultation when we have with our patients prior to the surgery. And one of the most important things which I have realized is only if the patient is ready for the surgery, you do it. If the relatives bring the patient to you and they say ki ani surgery kari kado, never ever do it, because the cooperation of the patient is very important. It's a life-changing surgery, and there will be a lot of minor issues in the beginning, and unless and until they are ready, you will never be able to give them a good result. See, it's not like inevitable, but if you look at the guidelines used to be 40 BMI for Caucasians, 38 BMI for Indians without comorbid conditions. They have been revised to 35 BMI without comorbid conditions. With comorbid conditions like diabetes, hypertension, 32 plus BMI, you can go ahead and operate those patients. Above 30 BMI, when you are operating, there have to be indications like uncontrolled diabetes or other major metabolic problems which would make you operate on these patients. Less than 30 BMI, we would normally not recommend a bariatric surgery. There are other options available, and they should be looked into first. No, our criteria, see, the ASMBS guidelines don't talk about any staging. What we try to usually follow is BMI with comorbid is usually the criteria, and that is what has been mentioned in all the things. So we don't have to go by the other criteria. Yes. Honestly, I don't use that criteria. I follow the ASMBS guidelines, which are a little different.
Thank you so much, sir. It was a brilliant synthesis of data and theory. Now I would request chairperson to honor Dr. Pankaj Khandelwal, sir. Now I would call Dr. Dipti ma'am on stage for lucky draw.
The number is 254, not present. 273, it is also not. 226. Aija. 299. 2 more. 439, nothing. 318. Okay, and last one. 259. Not present. Okay.
Okay, so for the next session, I would like to invite Dr. Sutaria sir from Banaskantha, Dr. Rosie Kapadia from Mumbai, Dr. Dhiren Mehta sir from Ahmedabad, and Dr. Vasant sir from Rajkot to chair the session. I would like to call Dr. Chandwani sir and Dr. Dipti ma'am to chair the session. Now I would like to invite Dr. Vijay Thakur sir to enlighten us on vascular diseases in family practice and request the chairperson to introduce sir.
Dr. Vijay Thakur is a very well-known vascular surgeon of Vadodara. He is the director of Department of Vascular and Endovascular Surgery, Adipura, and founder president of Vascular Society of Gujarat, secretary of Vascular Society of India from period 2019 to 2022, and board member of DNB Vascular Surgery from 2018. And sir's special interests in practice are carotid endarterectomy and abdominal aortic aneurysm. I welcome sir to start.
Thank you, ma'am, for a nice introduction. Can I have my slides, please? Right? અહીંયા આગળ જ મૂકીશ. ના. ક્યાં છે? ઓકે. મને એમ કહે તમે અહીં મૂકી શકો. Good evening, chairpersons, friends and colleagues. On behalf of Adikira Hospital, I would like to thank Dr. Pragnesh and team for today's invitation and podium privilege. Vascular surgery is a specialty surgical branch. You know, as a general practitioner, as a family physician, we really don't get into the details while studies and even then after. I remember when I was a surgeon, the type of problems we treat now were virtually, they were there all the time. But we had no idea how to investigate them and how to treat them. Things have changed almost 180 degree. So today, in today's forum, I think I would take an opportunity to share very commonly seen problems. In my talk, you will see the kind of problems I'm going to talk to you are seen by you every day. And your input, your participation is very, very important for the patient care. So I changed my title. Actually, my talk was family physician and a vascular surgeon, but when I saw a post of tomorrow's run, the caption said, family physician is the heart of healthcare. I believe not only heart, they're also heart and brain, both of the healthcare. In my viewpoint, family physician is an interface. He's a connect between patient and vascular surgeons. And you will see in these slides to come that how can you be an interface and how can you be a right connect, right advisor for the patients and then after for the family. These are the most common problems we see as a vascular surgeons. Most of the vascular surgeons are seeing these kind of problems. See, they are very common. I'm sure all of the doctors sitting in this room, you also must be seeing varicose veins, some kind of leg edema or venous ulcers. So the problems are not new, but the investigation methods and the treatment principles keep changing as science keeps evolving, as technology keeps developing. Look at one common problem like a leg pain. There can be so many causes of leg pain. There can be different pathologies like cellulitis, myositis, myofascial pain, osteoarthritis, osteomyelitis, neuropathy, peripheral vascular disease, vascular insufficiency, so many things. Now, patient does not know what he has. He goes to a family physician with his leg pain. And you see so many different kind of specialists treat leg pain, physicians, surgeons, orthopedic, neurosurgeon, neurophysician, vascular surgeon, rheumatologist. So it is a job of a family physician to advise him a right path at a right time. And it is very easy to do when you look at the commonly seen problems I have shown you in the previous slides. See, these are the most common problems of leg pain. He could have infection, cellulitis, so get blood counts, and this kind of picture, very self-explanatory, is suggestive of cellulitis. This type of an X-ray is very obvious to say it's an osteoarthritis. This is now an NCV, neuropathy and vascular, some kind of vascular cause. So having clinical examination, detailed history, and some basic investigations, a family physician can certainly guide patient whom to consult. I'll talk about common 2 or 3 problems we see in our practice like this, varicose veins. Everyone knows about varicose vein. It's a self-diagnosis. And when you see these kind of pictures, all these pictures are familiar to you. These are the different types of varicose veins. So again, patient knows varicose veins. It is your job to advise them that does all kind of varicose veins require treatment or not. It is your job to kind of reassure them that, look, you need treatment, you don't need treatment. And having had these kind of patients, you can have a basic investigation like sonography, which is called color Doppler ultrasound, and which will give you all this information desired to have any leakage in the valves, any reflux in the veins, DVT, etc. Based on this information, you can decide, we can tell your patients that, look, you need some kind of treatment, you don't have to be wearing stockings. It's very important to know these investigations. These days, because of social media advertisements, and there is lack of kind of an accountability and audit, you see a lot of advertisements in the media these days about varicose vein treatment. And every doctor claims to treat varicose vein, which could be true, but it is our job collectively to offer right kind of treatment to right patients who needs treatment, like patient who has pain, a pain because of varicose veins, he has swelling because of varicose veins, he has some kind of skin changes like dermatitis or lipodermal sclerosis, ulcers because of veins, infections, bleeding, and etc. Only if person with varicose vein has these kind of symptoms, then you get color Doppler ultrasound, And based on the finding, you can offer them different treatment options. See the variety, the gamut of options. You can see some kind of spray, some kind of oil, and then other medical management like medication, stocking, surgery, laser, radiofrequency, and glue. So you have so many options. And these days, when you read about the latest developments, modern therapy, we do all these kind of endovenous ablations. Could be laser, glue, radiofrequency, steam, mocha, or microwave. So you need different kind of technology just to cook the vein, to close the vein, so that you stop the reflux and the problems associated with reflux are taken care of. And see, I remember when I was a surgeon, I've spent some years as a surgeon, and we used to shy away from varicose vein surgery only because of very high recurrence. And that was because of a poor understanding, because those days Doppler was not available. But these days with the Doppler you get a very precise information, and with the advent of endovenous ablation, which is simply just a percutaneous nail-based procedure. The advantages are plenty. It's very safe, simple, and effective. Anyone who can puncture the vein can do the procedures. It's office daycare procedures. They can go back to activity next day. Excellent cosmetic results. Recurrence is there, but not that very high, and can be treated again only with injections, and there are very few complications to name. And these are the results. When you see, they can be treated very well without kind of a surgery. So this was an overview about a varicose vein. If you have a symptomatic varicose vein, get a Doppler study done. If Doppler shows some kind of reflux across the valve or vein, and then send them to a vascular surgeon to select one of the best treatment option. Second most commonly seen problem is leg swelling. Again, all these pictures I have taken from your referrals only. They are very obvious. Many times it's a spot diagnosis. Is it DVT? Is it lymphedema? Is it cellulitis? Etc. And based on this presentation, we can make out if it is bilateral significant edema, it could be cardiac dysfunction, renal failure, hepatic dysfunction, or hypoproteinemia. Very simple to diagnose. If it's local or unilateral, you have to think about these common causes. Again, not a very difficult science to remember. It could be infection, venous pathology, lymphatic lymphedema, people call filariasis, osteoarthritis associated, or hyperuricemia. Very simple. And again, only one test to diagnose is color Doppler ultrasound. So most of the vascular surgeon problems can be diagnosed with a simple test called ultrasound, color Doppler ultrasound, and any ultrasound will never miss significant DVT. Only in those cases when you suspect some kind of lymphovenous element or a lymphatic edema, these days we get something called lymphoscintigram to stage the disease and offer some kind of lymphatic surgery. These are the principles of treatment of leg edema. When you diagnose acute DVT based on a Doppler ultrasound, which is mandatory though, we have to give, traditionally you can give heparin or LMWH followed by oral anticoagulations. Some people also give systemic thrombolysis. We prefer to give local thrombolysis into the clot so that we can lyse the clot, you can suck the clot, and you can prevent post-thrombotic leg syndrome, which is the most common practice of most of the vascular surgeon. It is, I would say, not possible to cure PTS, post-thrombotic leg syndrome. All the patients will keep coming back. So if you have acute significant DVT, to prevent PTS in future, we offer them, I would say it is mandatory to offer them some kind of thrombectomy with technologies like Angiojet, Penumbra, Aspirex, etc., or catheter-based thrombolysis, so that you prevent post-thrombotic leg syndrome and subsequent complications. IVC filters in those select cases. If you cannot treat DVT in the right time with the right modality of treatment, they end up into CVI called chronic venous insufficiency, and all these patients will have swollen legs, eczematous legs, ulcerated legs, and then there is no cure for it. At times, I'll show you next slide, we do angioplasty stenting like arteries, even for veins. Lymphatic edema, the mainstay of treatment is some kind of manual compression therapy, maybe manual or machine-induced called lymphatic compression devices, or lymphatic surgery is a new frontier these days. We do node transfers or implant silicone tubes, etc. I'll show you this example of a young man, 40-year-old, who had extensive DVT. You can see thrombus everywhere into the IVC in the iliac vein. This kind of thrombus, if you treat only with heparin or drugs, probably you cannot have a cure. We have to offer some technology to clear this thrombus. Here we use angiojet thrombectomy and did clear the thrombus. If you can't treat DVT in right time, they end up with this kind of problems where a lot of the IVC is occluded, a lot of collateral veins. Symptomatically, they will have swollen legs. You have to do angioplasty like venous angioplasty, like arterial angioplasty, put a stent, and they do much better. This is just to show you, seeing is believing that angioplasties can be done everywhere. Another commonly seen vascular problem by you is non-healing ulcer, and these are the causes of non-healing ulcers: infection, arterial or venous insufficiency, neuropathy, malignancy, or it could be just traumatic ulcers. So these are the pictures. Again, as a surgeon also, you can, based on the location and the site, you can diagnose this. All the gangrene is an ischemic ulcer, this could be venous ulcer, this could be neuropathic ulcers. And if you have this in mind, you investigate them. You investigate them with these ideas based on the history, based on the clinical examination, like palpation of pulse. You can ask for Doppler ABI, Doppler ultrasounds, angiography, the different kinds of angiography, CT angiography, MR angiography, and DSA. So this will tell you what type of ulcer patient has. Based on that, or if you have some clinical information in your mind, based on the history and a basic investigation, you can make a right referral and you can have right kind of treatment at right time. So when you have any kind of vascular ulcers, these are the broad principles of treatment. Now we insist a lot. I always say that except PDA closure, none of the cardiovascular disease is curative. All are palliative. They come back. To prevent that comeback, to prevent the recurrence, we have to make sure we control these factors, walking exercise, and medications. All these medications are must. We do require angioplasty, stenting in those cases, and there's again a lot of technologies contributing great extent to, for a betterment of care. A lot of technologies are there into practice. Bypass operation certainly there. And there are cases where, we cannot do anything. We call no option ischemia, where they have no option but to undergo major amputation, wherein we have tried kind of stem cell therapy, prostaglandins, hyperbaric chambers, etc. I'll show you one of the cases. Based on this criteria, age, lesion morphology, conduit, we decide which is better for the patient, surgery or angioplasty. Like this case, very simple, short lesion, only option is angioplasty. I don't think that a surgery can be offered to this case. The last case of mine, probably young man, you see 54 is a young man, diabetic, hypertensive, and he had bilateral this kind of toe gangrene and wrist pain. And we did his angiogram. In fact, he had disease below the knee, and bilaterally, it was not possible to do any kind of angioplasty or bypass surgery. Think about the patient and the family, 54, he has to undergo bilateral below knee amputation. Look at the quality of life. He underwent hyperbaric therapy, stem cell therapy on both the extremities. Unfortunately, one extremity could be saved, other he underwent below knee amputation, but he's still walking on his leg and a prosthesis. So I believe with this overview, a family physician has a tremendous role in the management of vascular diseases. The right intervention, they can reduce patients' agony, they can save time and money, they can become a right teammate for the right treatment at the right time, and can also be part of the team for follow-up of the treatment. Thank you very much for your time and attention.
One questions can be asked. Is there any questions from audience? No questions. Okay, thank you, sir.
So I'm assuming there are no further questions. Thank you so much, sir. It was a valuable contribution. Sir, please be on stage. I would request chairperson to honor Dr. Vijay, sir. Moving ahead to the next session, now I invite Dr. Mehul Agrawat sir to elaborate on red flags in patients presented with abdominal pain. And I request the chairperson to introduce the esteemed speaker.
It is my honor to introduce Dr. Mehul Agrawat. He has completed MBBS 1990, June 1996, BJ Medical College, and Masters of Surgery, NHL Municipal Medical College. His expertise in hospital establishment, hospital management, laparoscopy, hepatobiliary pancreatic surgery, and organ transplant. Mehul Agrawat, sir.
Thank you very much, committee members of FPA, to invite me on topic which is very interesting for every practitioner. It is a day in, day out routine problem which we encounter in our practice. So, can we start our slides?
Yes, sir.
Now, આગળ કરી દેજો. અહીંથી નથી જશે ને? Okay. So, topic is red flags in abdominal pain. To understand red flags, before that we must understand actual what is abdominal pain and why we are talking about red flags in abdominal pain. So our talk objective is to equip all of you to diagnose abdominal pain and provide a structural approach for the investigations and treatment. And when to refer to a gastrosurgeon, that is the key point where we must understand when to refer, right? And its significance is because in day in, day out, up to 5 to 10% of emergencies is with abdominal pain. So quadrant-based abdominal diagnostic and investigation accuracy should be there. And what is the importance? Abdominal pain is a common symptom, but identifying red flag is crucial to prevent delayed diagnosis of serious conditions. Red flags help us to distinguish between benign condition and some life-threatening condition which we might miss if we don't understand red flags. And we may need urgent attention or urgent actions. So to understand abdominal red flags pain, we must understand anatomy of abdominal. And anatomy of abdomen is divided into quadrant. Generally, it is divided in 9 quadrants. Broadly, it is divided into 4 quadrants. There is right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. And in center, it is epigastric, umbilical, and hypogastric quadrant. According to quadrant, there are structure which is situated into the quadrant. So right in, for example, right quadrant is having a liver, gallbladder, right kidney, and bile duct. Then left upper quadrant is having a stomach, spleen, pancreas, and left kidney. Right lower quadrant is having a appendix, cecum, ascending colon, right ovary, right ureter. Likewise, in left lower quadrant, sigmoid colon, left ovary, left ureter. So what are the common red flag conditions which is associated with we might need urgent actions? So these are common conditions. We are not going into uncommon conditions. So acute appendicitis, perforated ulcers, either it is a peptic ulcer or jejunal ulcers, bowel obstructions, and mesenteric ischemia. Now, there are a symptomatology associated with all quadrant problem. So when we are talking about upper quadrant symptoms, why we are talking symptoms? Because symptoms which is associated with the normal abdominal condition, we must differentiate that symptoms with the red flags. So we are talking right now as if it is a normal abdominal pain, right? So right upper quadrant symptoms are pain radiating to back or shoulder, nausea, vomiting. In general, these are the cases associated with gallbladder, hepatitis or liver abscess. In left upper quadrant, it is dull aching pain, weight loss. Associated conditions are splenomegaly, gastric ulcers, pancreatitis. Left lower quadrant, acute pain, fever, vomiting. Associated condition must be appendicitis, Crohn's disease, or ovarian torsion on right side. Likewise, in left lower quadrant, cramping pain, diarrhea, vomiting. Associated condition must be diverticulitis, IBD, irritable bowel disease, or ectopic pregnancies. General condition where systemic disease leads to abdominal pain, like DKA, tetanus abdomen, and sometimes referred pain from other side comes into abdomen, and cardiac issues. Physical examination, what we do is, as usual, what we read during our residency or during our MBBS course, it is inspection. What we see is distension, previous surgical scar, or discoloration of abdomen like jaundice or bruising. In palpitation, what we do is localize, or there is a localized tenderness or a diffuse tenderness, a guarding present or not, and rigidity is there or not, to differentiate acute abdomen. And in percussion, dull note is representing ascites or a mass. Tympanic note is associated with bowel obstruction because of the gas. And in auscultation, we listen bowel sounds. Now, special signs. In special signs, there is a Murphy's signs which is associated with cholecystitis. McBurney's, everybody knows is McBurney's pain, McBurney's point is associated with appendicitis. Kuhnlen's and Gray Turner's signs are associated with retroperitoneal hemorrhages. So now these were the normal conditions. Now what are the red flags associated with these conditions? So when there is a systemic signs like fever is more than 100.4 Fahrenheit degree, there is a tachycardia with the patient, and if there is unexplained weight loss, it is a red flag. So we must understand that this patient might need further evaluation. In severe symptoms like persistent vomiting or sudden severe pain, even though we are treating patient, pain is not relieving, pain radiating to back or shoulder. GI symptoms like hematemesis, melena or hematochezia, persistent vomiting. And history itself given by the patient is also a red flag sign sometimes. Any recent abdominal surgeries or immunocompromised state of a patient, and history of malignancy. Physical examination finding red flag is always we must rule out any localized collection or a generalized collection. For that, a localized guarding or rigidity or a generalized or diffuse guarding or rigidity. It leads to a peritonitis, whether it is a localized peritonitis or a generalized peritonitis. Absent bowel sound in case of obstruction, sometimes we see hyperperistalsis also in obstructions. And there is a rebound tendency in acute appendicitis. Now, what kind of investigation we should offer to the patient when we are talking about abdominal pain? Always we start with CBC, LFT, lipase and amylase according to the quadrant, whether patient is having epigastric pain or whether patient is having apogastric pain. On that basis, we differentiate our investigations list and beta HCG to rule out ectopic pregnancy in patient with the RIF pain or LIF pain. Imaging, what we order is X-ray for X-ray abdomen standing, particularly. It is a very important imaging tool. And in that, we see pre-case or obstruction like air fluid level, ultrasound for gallstones and appendicitis, CT scan for specific diseases like pancreatitis, mass or diverticulosis, MRI, particularly for hepatobiliary conditions. My favorite one is I always order ultrasound to rule out major conditions, and then I order specific investigations if patient is needed. Endoscopy and colonoscopy is a diagnostic purpose. Then there is a diagnostic purpose, and then there is a therapeutic purpose as well. So we detect ulcers, IBD or malignancy in endoscopy or colonoscopy. Additional test, urine analysis and stool occult blood test to rule out stones, UTI, hematuria or GI bleed. Now what are the differential diagnoses? Quadrant by quadrant. In right upper quadrant, if we see the pain with the Murphy sign, it is a cholecystitis, otherwise it is hepatitis, cholangitis or trirenal stone. Left upper quadrant, it is splenic infarct, gastritis or left renal stone. Right lower quadrant, appendicitis, ileitis, ovarian torsion, and sometimes lower ureteric stone. Left lower quadrant, diverticulitis, sigmoid volvulus, and IBD. Epigastric pain is always associated with either pancreatitis. Common condition is gastric ulcer or peptic ulcer and gastric refluxes. Diffuse pain means there has to be some all-over condition in the abdomen like peritonitis, bowel ischemia or bowel obstruction. So what should be the treatment approach? General measures are analgesia. Now use of analgesia in particular case of abdominal pain, we might lead to masking effect of analgesia. So use of analgesia is very specific. We should not every time use analgesia for to reduce the pain, because pain is ultimately giving us some sign or some symptoms that we lead to diagnosis to of the patient. Then stabilization of dehydration and shock with the fluid, antibiotic for the infection. Specific treatment is surgery, like in cholecystitis, cholecystectomy. Appendicitis is referred to for the appendectomy. Diverticulosis for antibiotic or resection of that particular colon. Pancreatitis is always with the supportive measurements. And for peptic ulcer, PPI and H. pylori eradication. Sometimes if it perforate, laparotomy and closure of the ulcer. So now when to refer to a gastrosurgeon? Persistent pain, despite good evaluation and treatment, worsening symptoms with our true efforts and good antibiotics and other coverages, complications like obstruction, perforation and severe infection. And sometimes we need an advanced diagnostic purpose also. For that, like ERCP and endoscopic ultrasound, we should refer the patient to the gastrosurgeons. And in case of suspected malignancy or complex surgery need, it is supposed to be referred to a gastrosurgeon. So timely reference is equal to optimal outcome and better for the patient. In conclusion, in summary, accurate quadrant-based assessment is essential. Systemic investigation and treatment ensure sufficient and good care of a patient, and early referral to gastrosurgeon avoids the complication. So early recognition of red flags saves the life. Thank you very much, everyone. Any questions?
Thank you, sir. You have covered a very vast subject in 20 minutes. Thanks a lot.
Thank you so much, sir. It was a captivating talk. I would like to request Chairperson to honor Dr. Mehul, sir. Next session, I would like to invite Dr. Vinod Shah, Surat, Dr. Ramesh sir from Karnataka, Dr. Nilesh Shah sir from Vadodara, and Dr. B.M. Chauhan sir from Vadodara to chair the session. I would like to invite Dr. C.S. Butt sir to bring some focus on artificial intelligence and chat support in healthcare. I would request the chairperson to introduce the esteemed speaker.
Yeah, just one sec. Let it be.
Shall we start?
Yeah, we can.
Good evening, sir. Good evening.
So we can go.
Dr. C.S. Booth is senior consultant physician and telemedicine physician. He is an alternative to computer or Google. He is blessed with the Ma Saraswati goddess, Ma Saraswati on his tongue. And list is very long. I am better to listen him. Add to few at the award level, world records 5, international 2, national 4, state level 8. And one of the special, he was invited as a special guest at Six Sigma Excellence Award 2023 at Vigyan Bhavan, New Delhi, presided by our Modi ji sir, December 2023. List is long, but the latest is he is the executive director at India Wills Global Foundation of Boston in field of telemedicine. Second is he started air ambulance service with 3 helicopters from Norway. And one of the latest and one of the best is he is the Gujarati language resource person with the Government of India validated 1 lakh words translated by AI. Over to you, Booth sir.
Yeah, no. Good afternoon, everybody. Thank you very much for those words. I am here to do 2 things. One is to do marketing and another is to safeguard our interest. Nothing to be marketed as far as I am concerned, but people have a fear. Everyone listens to AI and everyone is thinking that can I use chat support in my clinical practice? And those who are interested, they are not sure whether it will harm me in any way. So I see many doctors who tell their children not to use in clinical practice. And the children are telling them that, Papa, there is no problem. We can use if we take precautions. So we will talk about AI and chat support in medicine and in healthcare. So, yes. Okay. So as we know, these things are unimportant. These are the things that he already has narrated. But what I'm trying to tell you is that if we keep working in various different fields over a period of time, from your practice, you grow into other areas. And therefore, I say that do not only do what you do. You must go to other areas, go out of your clinic, go to the society, go to the disabled persons and do that. And then you will get various things. And all these things are, people ask me, how are you able to do it? So I tell that because I want to do more, I do less. I use technology so that I don't have to do too much. So what is a chatbot? Name of some of the chatbots, and does chatbot help? What happens? Patients think that doctors don't know technology. એટલે બધા એન્જિનિયર ને બીજા બધા આવે ને એ ઘણા બધાને એવો ખ્યાલ હોય છે કે આ તો કંઈ મદદ થઈ શકવાની નથી ને મેં ગૂગલ પર આ વાંચ્યું છે ને તમને ખબર છે. So that is why we need to know about these chatbots, and they are very helpful. And how are they helpful is what we are going to talk about. So our first we will talk about what is the AI in medicine. correct? AI in medicine. The second one is the bots. The third is their clinical use. And the fourth one is a discussion about how that helps. So, what he was talking about, I will inform you that now, like we talked about various different things, currently I am the executive director for the WHEEL Global Foundation. And these WHEELs stands for water, health, electricity, energy, livelihood, and sustainability. Important thing to share with you, because your majority are from Baroda and many others are from outside, that we are expecting the support from you. I am looking after the health component of the WHEELs. And all over India, that is how through mental health, we have started Ram Mandir, clinic at Ram Mandir with ambulance, and we are seeing about 1,500 patients every day. Now I might think that, okay, our friends from here may decide that, okay, on Saturday, 1 hour, Dr. Chauhan has time. So he will donate his time 1 hour, and we will see the patients anywhere in the country. We provide the infrastructure. So that is one thing. And 1,500 patients is not a big number because 3 lakh people visit every day. Same way, our aircraft, the helicopters, they are helping. So, just to familiarize that these all things are being done at India from Vadodara. So, for us, that is the good part, correct? AI, as you know, there are many applications, and all of them you have heard. Fear people have is that should I use AI? But I feel that that fear is out of place. Another thing is they think that your job will be replaced. When you are doing a computer work, you are doing writing a code, creating an app, it might be taken away by the AI. But giving an injection, doing a surgery, you may have help, but you do not necessarily have to worry about it. As we can see, data mining, medical imaging, hospital information system, we have been using all of that. And therefore, as we talked in the morning, even the mental health is also very, very important. What it does is that it is working as a virtual assistant. So if you use AI as a virtual assistant and not as your boss, and you are not worried by it, then you have no issue. AI, main 3 ways by which it helps is natural language processing. Now I will tell you the other example and the side effects and the wrong sides of AI as well, but natural language processing, so unlike previously 10 years back, today આપણે એને કહીએ અને જે કહીએ એ સમજી લે અને એનો જવાબ આપે, and that you have seen on Google search, on everything, on Copilot, on Bing, everywhere. So it understands the context, and it is also very helpful for intelligent robotics. So if the time permits, I will see, where is the timer actually? I don't see it. Anyway, it doesn't matter. So chatbots are for long time, but now is the time where all companies, all startups and all businesses, companies, startup and businesses have found, and 1/3 of the customers are being taken care by the answers given by the chat support, and even the appointments are given, even the billing is done, even the certificates are given. Previously, if I wanted to make this picture, it would take me 1 week because I'll send it to my DTP person, he will send it to me, there will be changes. Now, any image of a camel on the moon with Chandrayaan, though I can get that in 30 seconds in my office. And therefore, these are the reasons why we are very, very happy. So talking about what, why, who will be benefited, all of us will be benefited. When, at which stage of our practice? હવે મારે તો 40, 50, 51 વર્ષ ચાલે છે પ્રેક્ટિસમાં. I am a 1974 batch. તો હવે શું અર્થ છે? જવા દો ને. No. Even now it is helpful. So that is what we will talk. We need not be afraid of technology because we gave birth to technology. So we are the parents of technology, and therefore we must be masters and not slave. Another thing is that you and Sang went all over the world walking, but we don't have to walk because today we have a plane. So આખી જિંદગી ચાલવામાં વિતાવા કરતા 2 દિવસની અંદર તમે જ્યાં જવું છે ત્યાં પહોંચી જાઓ છો. 24 થી 36 કલાકની અંદર you can reach most destinations in the world. So if you use technology like this, are you ever afraid? You are not afraid. પણ AI વાપરતી વખતે you are worried. મારું એવું કહેવાનું છે કે રાત્રે 2 વાગે જ્યારે there is no light and you want to see, do you not use the torch? If you use the torch at night, is it not natural? No, it is not natural. It is artificial. Therefore, જેવી રીતે પ્લેનની અંદર ટ્રાવેલ કરવું જોઈએ એવી રીતે હું સ્ટુડન્ટ્સને એવું કહું છું કે સ્ટોપ રીડિંગ, સ્ટાર્ટ સ્કેનિંગ ધ વેબ. કારણ કે મારી પાસે પડેલી 2000 પેજની 15 બુકમાંથી CA બ્રેસ્ટ પોસ્ટ ઓપ હવે શું કરવાનું એ જાણવા માટે મારે એકની અંદર there is પેજ 705, બીજુમાં 203, તો વાંચવાનો ટાઈમ ગોતવામાં જાય છે. માટે એવું ન કરવું. Technology, automation, they promote, they make it easy, they make it speedy, they make it powerful, they increase your income and they increase the patient outcome. Therefore, we must focus on that. Now, this technology, what is the difference between chatbot and robot? I think very important for us to know so that we can answer our children, because they are already knowing it. So whatever action we are doing in that, if there is a help provided by the technology, that is surgery માં વપરાય તે રોબોટ. અને તમારે ને મારે જે જવાબ આપવાના છે, એક પેશન્ટને ગુજરાતીમાં જાણવું છે, બીજાને પંજાબીમાં જાણવું છે, ત્રીજાને ડાયાબિટીક ન્યુરોપેથી માટે મલયાલીમાં જાણવું છે. So from my clinic I give in 14 languages the prescriptions, and believe me, they are so happy કે ફોન આવે, અરે બુચ સાહેબ કલકત્તાથી આપને મેરે બેટે को Bengali में prescription दिया. So he is very happy. So what I am trying to tell you is that these things are very, very necessary. જ્યારે ઇન્ફોર્મેશનમાં હેલ્પ જોતી હોય તો that is a bot, અને એક્શનમાં જોતી હોય તો robot. With that simple thing, now what are the things because of which the bots are made? So all the social media, mobile, તમારા પેશન્ટના લિટરેચર, લેબ રિપોર્ટ્સ, એ બધા ડેટા કલેક્ટ કર્યા પછી how many don't understand Gujarati? Raise hand if you, in case, yeah. So I must avoid. So then all the inputs that we have, they are taken in as a data and analyzed and then goes to the chat server, and from that it gives you, as per the rules that you have decided, it will give you an idea that this is what is my suggestion. So you will get. Now bot and AI, both are very important. AI is natural language processing. AI is flexible. AI understands that these are the rules. Accordingly, we have to do it. But bot is rule-based. It is predetermined. If you give something new, it may not be able to answer. Chatbot is conversational, whereas context is understood more by AI. And therefore, you see more and more about AI. Bot will go as per the decided flow, but AI can be changed. AMI, when I search, it will be acute myocardial infarction, but it will detect American Meat Institute. So whether we are talking in medical field or in non-medical field, that contextual help AI does have, chat support, chatbot doesn't have. So chatbots, depending upon the name, a person who is speaking is a speaker, a person who is sitting there is a chairperson, a person who is traveling is a traveler. Same way, a chatbot is classified based on their names. So depending upon their names are ChatGPT, Bing, etc. Everyone who can be helped, everyone can be helped, because everyone wants change, everyone wants creativity, everyone wants success. And if you get all this, then you get happiness. So you want that in your practice, and for that, what you need and when do you need that help? So those who have patient care in mind, and my acronym MIND is for medicos, interns, nurses and doctors. All of them at every stage have a utility of the chatbot in clinical practice, education, exams, everywhere. So it helps in everything, in appointment, in billing, in certificate, in diagnosis, in every examination, every kind of activity that you carry out in the clinic. More and more there will be a utility of chatbots. So please be ready to accept. We did not want mobiles to begin with. We did not want pagers to begin with. Now we use everything. So let us do it early rather than late. So improving the performance, quality, increasing the reach and being more rich, increasing the strength and the speed of getting the literature, saving time, improving timing and increasing the training of the medical students. All this is all possible if we are using the artificial intelligence. Colleagues, you know, when you start practice, I used to say there were two consulting rooms. There was one doctor's waiting room and another was patient's waiting room. Then my room became consulting room. So in the initial phase, you have time, but you don't have money. And then you have more time, but you have less money. Then you have money, but you have no time. You are very busy. And then in that stage, after maybe my stage, I have both time and money. So how do we save time? If you save time, you have saved money. So if you energy is saved, energy is earned, time is saved, money is earned. So therefore, more positive output with less input. If you put less and you get more out, you are helped. And that is why you are able to do more things. AI and bots are an augmentation of your reach. બેટરી જેવી વાત છે, ઓફ યોર ઇમેજ, ઓફ યોર બ્રાન્ડ. એન્ડ તમારી ગલીમાં મૂકેલું બોર્ડ તમારા ગલીવાળા જ જુએ છે, પણ તમારા ફેસબુક પર મૂકેલું બોર્ડ બધા જ જુએ છે. અને એટલે ઇન બિટવીન ઇન 2018 I do work for 300 differently abled children. એમાં ગ્લોબલ ગર્લ ચાઇલ્ડ એજ્યુકેશન સમિટની કોન્ફરન્સ શિકાગોમાં ઓબામા ફાઉન્ડેશનની હતી.
2 minutes, sir.
Yeah. So what happened that I got a invite from Michelle Obama to Obama Foundation. So what I'm trying to tell you is that doing work is important, but putting that work on internet is more important. It is because of that I could run the clinic, I could write the book, and that became number one on ABCD of success on internet. So looking at all those things and doing all these things, we are able to do all these things simply because of the support, excellent support that you get from the technology as a secretary. So creative success is possible with the bot, and creative success is doable with all the various things. It should be a fashion? No. It should be passion. It should be science, not commerce. But commercially also it helps. So looking at everything, all these activities are, and all these pictures and images and everything that you see, every word is all done by chatbots. So therefore, we don't go to the DTP now. And therefore, I would say that we must use chatbots in medicine, AI in medicine. And once we do that, this is what is the Ubuntu is the African word. And they say that I am because you are. I am because you are. You are chairperson because I am a speaker. I am a speaker because I have an audience. So we all are together. And if we work together, team, together everyone achieves more. Now I will tell you one small incidents only, that of the 1 lakh words that I underwent to translate for Government of India for NABH, this is the last thing, there I found it was tedious job, thankless job, but at least it was done. And in that I found, and you will be interested in knowing only 2 examples, that it said that for every surgery,
You can give the carry home message, sir.
Yeah, that's all. Yeah. That before every surgery, the instrument has to be sterilized. Now, this was translated by AI. દરેક શસ્ત્રક્રિયા પહેલા શસ્ત્રનું વ્યંધીકરણ કરવું જોઈએ. કોમન સેન્સ નથી એઆઈને, વ્યંધીકરણ ન કહેવાય એને. અને બીજા 15 પેજ પછી લખ્યું હતું કે you can do નસબંધી. And there is a difference in the mortality between ventilated and non-ventilated COVID patients. The AI translation is કે હવા ઉજાસવાળા ફેફસાવાળા કોવિડના દર્દીઓ અને હવા ઉજાસ વગરના ફેફસાવાળા દર્દીઓની અંદર મૃત્યુ દરમાં ફરક હોય છે. So what I am trying to tell you is that while using AI is important, you must use your own intelligence, use artificial intelligence as your secretary, and that will make you better. It will change your spellings, it will improve your style, it will improve your prescription, it will give you everything that you need to do for your patients. And therefore, and or for publication. So kindly use AI and chat support in your practice. Thank you very much.
Any question from audience? 2 questions.
You can always send anywhere you type Dr. C.S. Buch, DRCSBUCH, and if you type that, I'll get the questions and I'll send you the answers. But you can ask here if in case.
Thank you, sir.
Okay, thank you.
Sorry.
Question?
Sir, any specific medical related AI available? Any specific AI website or?
Too many, depends on your purpose. But again, how do I, just put that, how do I, and then write whatever you are writing. I would say in a plane with a pilot, he gets a heart attack, we are troubled. But therefore they keep a second pilot known as co-pilot. So તમને બધાને રિક્વેસ્ટ એ છે કે તમે આ કહેતે કે ચેટ જીપીટી કેવી રીતે ન વાપરો. You use co-pilot as your search engine, as your support. And once you do that, it will offer you everything that you want. There is a big change which has happened for the medical students in the industry today. And I, from my teacher, got a message that, Buch, there are 3 students in Baroda Medical College who do not afford. Their fathers have only 30,000 rupees income annual. અને એમની ફી ભરવાના અને બુક ખરીદવાના પૈસા નથી. So I now run, because of this, a project where I call it Read to Feed. And what we do is we give the books in 300 થી 500 રૂપિયામાં 21 medical books આપણે આપી શકીએ using AI. So I have spent 12 to 15,000 rupees for 140 students. So પહેલાના સમયમાં તમને ને મને ભણતી વખતે સાચો ને સારો જવાબ આપનારને, the people who gave good answers used to get good marks. Now the student has to know what to and how to ask, which is known as, that question is known as prompt. So in AI, if now you understand how to ask the question, you will get the right answer. And prompt engineering is getting a very big salary, 5-7 lakhs per month to many engineers. So changing focus from answers to questions. How do I can be one of them? Right? Thank you. That is answered in the first one.
Thank you, sir, for sharing your expertise. Now I would request the chairperson to honor Dr. C.S. Buch, sir.
Yeah.
Thank you, chairpersons. Let's start the panel discussion on changing horizon of hypertension. I would like to invite Dr. Hiren Mehta, family physician, Dr. B.P. Chandwani, sir, family physician, Dr. Aditi Tripathi, ma'am, ophthalmologist, Dr. Anand Ahuja, sir, cardiologist, and Dr. S.C. Trivedi, sir, physician, to I would also like to invite moderator Dr. Vinit Jagnani, sir, clinical cardiologist. Dr. Vinit, sir, please start the panel discussion.
Slides, please. Slides, please. Excuse me, slides, please. Yeah. Today we are here to discuss hypertension, and we have eminent panelists with us, ophthalmologists, cardiologists, and family physicians with us, who will be enlightening us about hypertension. Slides, please. Slides नहीं है.
Do it again. It is just buffering. It's there.
I can't see here on the screen also.
मेल किया कौन सा है कौन सा है सर
वडोदरा करके होगा
ओके
दिया है
मेल किया था सर
नहीं अभी सुबह पेन ड्राइव में दिया मैंने
अच्छा
व्हाट इज द पेन ड्राइव
लाओ ना मुझे दो ना एक मिनट
brigadier was to come. So he asked that all arrangements are done. The corporal said, yes sir, everything is ready. He said, why are you carrying the lantern? Because sir, कदाच में सूरज न उगे तो. When I started,
Vadodara.
it was not working.
Yes.
Because it was not working, I had the pen drive. So I put the pen drive. If the pen drive did not work, I have brought the laptop. So I can just connect that. So the any option A, option B, option C, value orders.
Thank you. So, we are here for changing horizon on hypertension. So, how do we define the hypertension? We are going to do this in a question-answer pattern. So, first question is with Dr. Chandalia, sir. How do we define the hypertension? I guess we need to have mic with
Blood pressure more than
130 by
more than 130, diastolic more than 185.
is hypertension. This is a standard definition. There are so many guidelines, European guideline, American guideline, International Society of Hypertension. We have tried to simplify by consolidating all those guidelines so that we can practice comfortably and easily. So if we go in detail, how do we go ahead in hypertension? Optimal is less than 120 by 80. Normal is 130 by 85. Therefore, this definition comes that more than 130 by 85 is hypertension. Then we further classify as pre-hypertension, where we do not give any medical treatment, that is up to 139 and 89. Then we have grade 1 and grade 2. As we see in the screen, that is up to 160 and 100 is grade 1. Then up to 180 and 110 is grade 2. Then hypertensive urgency with hypertension with no end organ damage. We'll go in detail. Then emergency is there with there is end organ damage. Then we have office BP and home BP. Here we want to specify that nowadays patients are coming to us with home BP measurements of automatic blood pressure machines. So we cannot just ignore them, though we as clinicians understand. I hope my panelists will agree with me that we as clinicians understand that automated machines are not that accurate, and we need to have traditional mercury sphygmomanometer in our clinic, and we need to have standard methods to measure the hypertension. And then we have, of course, isolated systolic hypertension, that is systolic is more than 140 and diastolic is less than 90. So here comes the second question. I would like to have Dr. Mehta with us for first line of treatment for young hypertension.
Sir, for young hypertensive patient, I would like to prescribe thiazide diuretic or beta blocker.
Yes, we generally prefer these two combinations put together. And here, if we go in further detail about hypertension for heart failure with Anand Ahuja, sir.
Well, all patients with hypertension and heart failure would benefit by use of RAS blockers. So they can be ACE inhibitors or ARBs. So because that would help reduce afterload, will help both in hypertension as well as heart failure. Once blood pressure is reached or is not reached and you have reached the target goal, the second line should be the beta blockers, which will again be beneficial for both agents.
And I guess, sir, in present scenario, ARNI, where do we place ARNI?
So ARNI right now is a class 1 indication for heart failure irrespective of ejection fraction. There are a lot of studies underway for hypertension, but we do not have ARNI as a recommendation for hypertension management as of now.
Yeah, thank you so much, sir. So here also, if we go in little detail, that uncomplicated hypertension, which is almost 95% of the hypertension, which we also call essential hypertension. So in Indian patients, I am differentiating from our Caucasian counterparts. In essential hypertension, in Indian patients, first line of drug will be thiazide with calcium channel blocker. If diabetes is a comorbidity, we replace calcium channel blocker with ACE or ARB. If coronary artery disease is there, as sir has rightly said, ACE inhibitors with thiazide and beta blockers. Young hypertension, beta blockers with thiazide, and heart failures, we have ARNI as one option if there is comorbid conditions. Then of course we have second line, third line drugs as we are seeing on the slide. I am not going in that detail. So another question with our ophthalmologist, Dr. Aditi ma'am. Do we need examination of eye in hypertension? If yes, why and how often?
In patients of hypertension, there is no suggested guideline, but because hypertension causes end organ damage, we advise complete eye checkup, including a fundoscopy when a patient is diagnosed with hypertension, as well as yearly retinal examination in patients of hypertension with diabetes.
Ma'am, how patient could present, or what could be the possible things which we should keep in mind as clinician when we are thinking of hypertension and eyes put together?
Yes. So when a patient presents, normally hypertensive changes inside the eye are an incidental finding. They just walk inside the OPD with minor hypertensive changes inside the eye. But patients can present with a lot of other things. Patient can present with severe headache. Patient can present with blurred vision. Patient can present with double vision or diplopia. Patient can present with visual defects. Patient can present with loss of vision. So these are some of the things that patient can present with in your OPD. And if you see any of these alarming symptoms, then I think it would be advisable to do a consult an eye checkup or do a complete eye checkup.
These are not uncommon symptoms which we encounter in our practice. So if we are seeing any of these things, we should not ignore that. Of course, we treat hypertension, but along with that, we also need to have an ophthalmologic consultation. Why? Because hypertension, we all know, is asymptomatic, and asymptomatic. The most common symptom of hypertension is that it is asymptomatic and is undiagnosed in more than 50% of the patients, and presentation comes when there is some damage occurring, such as stroke or acute coronary syndrome, and more than 90% is essential hypertension. So this is something which comes to our clinic. That means whenever a patient is coming to a clinic, we need to have measurement of blood pressure, and in present scenario, it is any age that should be measured for blood pressure. I guess Dr. Ahuja will agree with me in that. So what is the threshold to start hypertension? Dr. Chandalia, sir.
Blood pressure more than 140/90 is a threshold when to start.
Exactly. We have already seen that in previous slide. We have little bit of relaxation with age. So we have two parts. One is when to start and what should be the target blood pressure. If we see this, in most of the situations, we start treatment at more than 140/90 and the target is round about 130/80. If there is a comorbid condition, we may start little earlier, and target is also little less in comparison to essential hypertension. So what are the risk factors for hypertension? Dr. Mehta.
Well, hypertension is basically lifestyle disease. So there are few factors which affect and risky for hypertension, like dyslipidemia, obesity, sedentary life, smoking, increasing age.
We have been listening so
One
many...
more thing, sir. Men are more prone to hypertension than female.
We are listening so many lectures since morning, and we have been repeatedly talking about sedentary lifestyle and dyslipidemia, which is now common because of our lifestyle. So we definitely need to implement that. And though it is more common in male gender, but unfortunately in last few years, females are not left behind, probably because of the work culture. They have to actually do the double role, that they are taking care of the household as well as their work, and probably they are a little more stressed. So we must not ignore the female gender when we are talking of hypertension. So these are the risk factors, and most of them are something which is under our control that we can take care of. We talk of age. Age is something which we cannot talk about, which we cannot change. So why talk about it?
Family history, we cannot talk about it, but we can take care of our diet, we can take care of our exercise, we can stop smoking. By God's grace and thanks to the politicians that at least Gujarat is dry state, so not that common, alcohol is not that common. So, though it's available, that's a different story. So these are two common things to coexist. May I request Dr. Ahuja to kindly enlighten us on this? Diabetes and hypertension put together.
Yes, hypertension and diabetes happen to come together in a lot of cases because of very, very common risk factors and very, very common pathophysiological changes. Both of them have common risk factors such as stress, physical inactivity, dyslipidemia. And apart from that, the pathophysiological changes also are quite similar. Changes of oxidative stress, changes of inflammation, atherosclerosis, and the lipid abnormalities which occur are quite similar in both. And therefore, the complications are also quite similar, the most common being, of course, atherosclerotic cardiovascular disease. So, common risk factors, common pathophysiological changes, and common consequences.
So, it means if we are taking care of one, probably the other will be taken care of
quite substantially.
Quite substantially.
Yes.
Thank you so much. And what is systolic hypertension, once again, Dr. Ahuja sir, and what is resistant hypertension? How do we define them and how do we differentiate them?
Well, isolated systolic hypertension is more common in elderly, where only the systolic blood pressure goes up, the diastolic remains low. The concept is that diastolic blood pressure continues to increase up to 50 years of age, and after that it goes down. Whereas systolic blood pressure keeps rising. So people who are above 60 or 70 you will find that the diastolic blood pressure is quite normal, sometimes even below normal, but the systolic could be 160, 170 and above. So this phenomenon where you only have systolic hypertension and not the diastolic is called isolated systolic hypertension and is classically seen with elderly people with hypertension. What is resistant hypertension? Patients who are on optimally tolerated doses of 3 drugs, which includes 1 diuretic, and if despite that, if the target blood pressure is not met, after you have ruled out non-compliance and if the patient is not taking any other drug which increases blood pressure, then this condition is called resistant hypertension.
Here 2 things come to my mind. One is, what is the cause that systolic remains normal and diastolic remains normal and systolic goes up? Any one-line pathology behind that?
Sir, arteriosclerosis is one thing, and secondly, there is a pathophysiological change where there is the vasodilatation which occurs gets the diastolic blood pressure slightly on the lower side as a compensatory mechanism to maintain blood flow in vital coronary bed, for example, which is predominantly diastolic. So therefore, the diastolic blood pressure does not increase so much compared to systolic blood pressure. The pathophysiological changes initially were thought that diastolic hypertension is more important for all the target organ damage, but now we know that it is the systolic hypertension which is a major culprit which causes target organ damage and which is also more difficult to treat.
That means even if the diastolic is normal, we must treat the systolic hypertension also.
Absolutely.
Definitely. And resistant hypertension we have talked about. Ma'am, what do we do about hypertensive retinopathy and what it is in terms of what a family physician should understand that this could be hypertensive retinopathy?
Okay. So, when hypertension causes changes in the retina as well as its vasculature, it is called hypertensive retinopathy. The basic pathophysiology one should understand it's because there is generalized narrowing of the arterioles inside the eye, in the retina. And the main cause is vasospasm. This is in early stages of hypertension. In chronic stages of hypertension, we see other changes. We see all these exudative changes. We see thickening of arterioles. We see flame-shaped hemorrhages, exudates, all the exudative changes inside the eye. So that is in chronic hypertension and severe grades of hypertension. I think it is important for family physicians to, as we discussed, to have a regular eye checkup and especially pick out patients with chronic hypertension and send them for a regular eye checkup as and when required.
And we can understand it could be hypertensive retinopathy if there is blurred vision or headache or double vision. That could be symptom of retinopathy?
So,
no, something else.
The symptoms we discussed are the symptoms. As we discussed, they are mostly incidental. They have no symptoms at all.
Once again,
Yes,
it could be
no
a symptom.
symptoms at all. Patient just come in with grade 2, grade 3 hypertensive changes. The only symptoms patient will present with symptoms is when patient has an acute hypertensive emergency.
So we need to be proactive in
Exactly.
ocular examination also.
Very proactive.
Thank you so much, ma'am. So what could be the earliest endothelial marker for dysfunction in terms of hypertension and diabetes for Ahuja sir, once again?
Well, endothelial dysfunction, when it occurs, endothelium primary function is maintain endothelial integrity, and this next will be production of nitric oxide. So whenever that is lost, hypertension, the blood pressure increases because of vasoconstriction. So if you want to really look at marker, then blood pressure would be a very common way to assess. But if you want to look at a laboratory abnormality, then, for commercial practice or from practical point of view, there are important tests. A simple test would be a CRP, where inflammation will be an important vascular marker. There are other tests, ICAM, VCAM, VEGF. They are not into clinical practice, so I would not recommend doing those tests. But for all patients who have hypertension and diabetes, checking blood pressure and inflammatory markers such as CRP, you can also use uric acid actually for that matter. Which can be indirectly used as a marker of endothelial damage. And a simple test which you can actually do in your clinical practice is to check for brachial artery flow mediated dilatation, where you get put a ultrasound probe and check the brachial artery diameter. Then you inflate the blood pressure cuff around the arm, get it to 200 millimeters, and occlude the flow in the in the brachial artery for say 2 or 3 minutes. And whenever you release, the increase in the dilatation is a very direct marker of endothelial damage. So it's an important test, but you need to have an ultrasound probe to do this.
Yeah.
So a radiologist would be able to help you do this.
Anything clinically which we can do? One part was to inflate the cuff up to 200 millimeters of mercury, and then ultrasound probe. Anything other than ultrasound probe which can be of help for family physicians?
Well, there's no such test like how would you measure the diameter of a brachial artery? That is not possible.
Not possible. Do we have any role of microalbuminuria in identifying endothelial dysfunction?
Yeah, absolutely. But that's more to do with progression of renal damage, renal pathology. Urine albumin creatinine ratio in a single spot urine test is a very, very important test, like Madam recommended a retinal examination or a complete ocular examination. All hypertensive patients on admission and then every yearly should also undergo UACR. Because this thing is not affected by the patient's body mass index, it is not affected by the patient's muscle mass, it is not also affected by actual creatinine levels or blood protein levels. Because it's a ratio of urinary albumin and creatinine excretion, it offers a very, very early and sensitive marker of a nephropathy. But also an inflammatory marker for that.
But only if the kidneys are involved, then only this could be helpful. Otherwise, this is not as helpful. But we can find out if kidneys are involved if this is positive.
If it is positive, certainly kidneys are involved, but microalbuminuria also raises in all stressful illnesses like an acute myocardial infarction, acute stroke, and in fact that is associated with a worse prognosis. So if you want to really look at and differentiate people with worse prognosis from the better ones, then UACR can also offer you a very early marker of that.
Thank you.
And it rises in 24 hours after an acute stress.
Ma'am wants to add something.
As he mentioned, sometimes even the retinal examination can be a sign that the kidney is now going to get involved or the kidney is getting involved. We see a lot of patients with grade 3, grade 4 changes, macular changes or disc changes, and we send the patients that please go do a create, go to your physician. So it can be also diverted like that. We see a lot of retinal patients and then we get the create done and we see that the create is high and they have kidney changes inside. So we've seen this also.
Guess this point raises one thing very clearly, that hypertension and diabetes is affecting each and every organ of the body. Broadly classifying, it could be microvascular complication as in case of eyes and kidneys, and macrovascular complication which could present as ACS or a stroke. Am I right? Absolutely. Thank you so much. We move ahead. So that was one thing we have talked about. So in adults with hypertension, does treatment with antihypertensive pharmacologic therapy, matlab medical therapy which we are talking about, at specific BP thresholds which we talked about 140/90, to a specified goal that is 130/80, has any improvement in health outcomes, or it is just we are trying to treat hypertension, or we are having some extra benefit by doing this? Sir, Ahuja sir.
Well, absolutely. The SPRINT trial has very, very clearly documented that patients who achieve target blood pressure not only reduce their risk of target organ damage, the microvascular as well as macro, but their quality of life also improves, their longevity also improves, they have lesser chances of having myocardial infarctions, heart failures, and cardiovascular death. So achieving blood pressure targets is very, very important, and it's not just the cosmetic figure that we were chasing.
Exactly. This is the point which we are trying to reach at, that it is not the numbers which we are worried about. We are worried about prevention of complications of an uncontrolled hypertension, and that's why we are here to highlight this particular point, that we must start treatment at the threshold and we must reach the goal to prevent the complications. So it has been observed that almost 10 times increment in various complications has been observed, and up to 50% decrement in various complications has been observed with proper treatment of hypertension if we are able to achieve the specified goal. And this has been proven in various randomized controlled trials. I guess you will agree with me. With this, we come to once again about the symptoms of hypertensive retinopathy, which we have talked about. So, do various class of drugs have any specific or comparative benefits when we talk of health outcomes? Dr. Ahuja sir. We have beta blockers, thiazides, loop diuretics, ACE inhibitors, ARBs. So where to place what, or what is the benefit of using these drugs?
Now this is very, very important. The first important dictum in hypertension management is optimal blood pressure control to target goal. Now there are various classes of agents. You have the RAS blockers, calcium channel blockers, beta blockers, thiazides. You have mineralocorticoid receptor antagonists. You have alpha blockers. You have centrally acting drugs. There are plenty of trials which have shown that not all drugs or all classes behave equally. There are certain classes of drugs which not only reduce blood pressure, but they also reduce the risk of complications. And therefore, these drugs have been classified as first-line agents. And they happen to be calcium channel blockers, beta blockers, thiazide diuretics, and RAS inhibitors, that is ACE inhibitors and ARBs. Other drugs like mineralocorticoid receptor antagonists, centrally acting drugs, or alpha blockers, they reduce blood pressure, but they do not have substantial impact on reducing cardiovascular outcomes, and therefore they have been recommended as second-line or third-line agents when blood pressure remains uncontrolled despite being on maximally tolerated doses of all the first-line agents. So therefore, it is not only important to control blood pressure cosmetically, of course, that any drug would do, but it is important to use first-line agents. The recommendation for younger people is A, B, that is ACE inhibitors, ARBs, or beta blockers. You can also use diuretic. And for elderly people, it is C and D, that is calcium channel blocker and diuretic. So try to use, start with a single pill which has two drugs. If the blood pressure does not remain under control, add a third drug, and then go on sequentially adding the second and third line agents. So they all have different impacts, because of which they are classified as first line agents and second and third line agents.
At this point, one thing comes to mind, that is there any threshold where we should start with more than one drug?
Yes, actually now single drug is recommended only in two situations. Number one, very elderly and frail people who are likely to develop postural hypertension with using multiple drugs, or people who have very borderline blood pressures like 140, 145, who might possibly not require a second drug. In almost all other cases, you will require a fixed dose combination which has two drugs. Majority of the patients require 2.5 or 2.7 drugs has been seen in multiple trials, and therefore, apart from these two situations, you should start with a two-drug combination. A single pill, it could be a calcium channel blocker and a telmisartan, or you can use a beta blocker, you can combine it, or you can use a thiazide type of diuretic. So almost 90% of our patients would be on a two-drug combination. Only two situations, borderline blood pressure and very elderly people with a risk of postural hypotension, giddiness, fall, should be given single drug. In all other cases, you have a two-drug combination.
Due to paucity of time, we will be concluding. So one or two things just before concluding. Is it good idea to escalate the dose of a particular drug or add another class of drug rather than escalating the same doses of the same drug?
Now, this concept is very interesting. Hypertension is initiated and it progresses through multiple mechanisms, the most common being RAS overactivity and SNS overactivity. So, if a patient is, say, on telmisartan 40 milligrams and the blood pressure is still not controlled, it would be interesting, it would be more useful to add a drug with a different mechanism of action which targets a different pathophysiological pathway. You might add a calcium channel blocker, which is a direct vasodilator, or you might add a thiazide type of diuretic, or you can use a SNS blocker, that is sympathetic blocker, that is a beta blocker. That would be able, in that way you will be able to target multiple mechanisms, and it will be possible to reduce blood pressure to target goals using lower doses of two classes of drugs. Instead of adding a second drug, if you just do the first drug, increase the dose, say from 40 to 80 milligrams, it might still be possible that the blood pressure would not perhaps reach the target goal because the other pathophysiological mechanisms are not yet targeted. Whereas if you increase the dose, the risk of side effects, say for example, hyperkalemia with RAS blockers or pedal edema with calcium channel blockers would increase. So it makes sense adding two drugs with different mechanisms of action.
And one more thing, I guess the last question. Is it okay to prescribe ACE, ARB together? Yes, I want to highlight this point. That's why I'm putting this question.
Well, ACE and ARB together would produce such substantial RAS blockade that the risk of hyperkalemia is very, very significant and it is potentially life-threatening. It is humanly impossible to measure potassium on a daily basis. Patients might not remain compliant, and therefore it has been absolutely contraindicated to combine these two classes of agents. So do not start with ACE inhibitors and ARBs together. It's only one of the two.
And to be more precise, one of the three, ACE, ARB or ARNI.
Absolutely.
And suppose if MRA is there, aldosterone type of drug is there, then what is the precaution that we have to take?
Well, both of these classes of agents, ACE, ARBs and MRAs or ARNI also, all of them increase the potassium levels. So we'll have to be very, very mindful and monitoring the renal functions as well as potassium. People with normal kidney functions might not have a problem, but people with borderline kidney functions, elderly people or underweight people, you should have a very close watch on the renal functions as well as potassium. Up to 30% increase in potassium and creatinine is quite expected and is actually an indirect proof that the drug is working, but anything more than that, you should think of reducing the dose or reducing one of the two, or you might need temporary or permanent discontinuation depending on the case.
मुझे लालच बहुत आ रहा है, लेकिन एक last question और. Where do you place SGLT2 inhibitors in a non-diabetic patient?
SGLT2 inhibitors have shown substantial promise irrespective of diabetes. So whether a patient has diabetes or is at risk of getting diabetes, that is pre-diabetes, whether a patient has metabolic syndrome and requires weight loss, whether a patient has cardiovascular disease or has risk of getting heart failure or has overt heart failure, irrespective of the ejection fraction. In all these classes of agents, SGLT2 inhibitors have found their place, whether it is empagliflozin or dapagliflozin.
I guess discussion will go on and on. Any questions if we have one or two maybe, because they are wanting to complete it. So thank you so much. I must thank all my panelists. Wonderful discussion, nice answers, and I guess a lot of confusion has been cleared for all of us, so we can have better practice in our clinical scenario. Thank you so much. Thanks all the panelists. Thank you so much.
Thank you so much, everyone. Now I request Dr. Pragnesh Vacharajani sir and Dr. Ketan sir to honor moderator and esteemed panelist. Please honor Dr. Vinit, sir. Dr. Anand Ahuja, sir. Dr. Chandwani, sir. Dr. Hiren Mehta, sir.
A round of applause for our panelists.
And Dr. Aditi Tripathi, ma'am. Thank you all. At the end, I would like all the chairpersons who chaired the session today to take their token of honor from the point of honor corner near the registration area. We are done for today. Thank you, respected doctors, for showing keen interest. We truly appreciate serving you and cannot wait to see where we go tomorrow. See you all sharp at 7:30 p.m. in lawn area for melodious musical evening with gala dinner.